Right, because so now let's take a look at the revision of surgical trauma. In this, first of all, we'll be discussing the management where any trauma patient comes to us in an emergency, then how we are going to save the life of this person. And then we'll be discussing something related to the basics of shock, bleeding or hemorrhage, blood transfusion. And then we'll go into the organ-specific traumas, the head, face, neck, chest, and the abdomen. And finally, we'll be signing off with the discussion of burns. So first and foremost thing is, just imagine that we are sitting in the emergency of the hospital and we are receiving any trauma patient. This can be a car accident, motorcycle accident, or maybe a building collapse story, or maybe an earthquake type of story, or something like that. Now, how we are going to react to this situation? So WHO has laid certain guidelines, which are followed by different countries. And here in India, we call them as National Disaster Management Authority guidelines. According to these guidelines, as soon as you receive the information of some disaster or something, maybe a building collapse, you have to immediately send the quick response teams, which comprises of paramedical staff, to the disaster site. And this is START, that is simple triage and rapid treatment at the disaster site done by the paramedical staff, where they have to provide the first aid and transport the patient back to the hospital. In the hospital, you suppose this is the paramedical story, and when these are brought to the hospital, now in the hospital you are in the triage area in the emergency, where there's a designated triage team of doctors, and first and foremost thing will be to save the life. And at every stage we keep on doing the triage. Now how we have to save the life? Single most important thing, what we know for life is oxygen. So it is the oxygen which is going to every cell of the body, because of which we are able to live. And we know the normal route of passage of oxygen. God has given abundant oxygen in the atmosphere. So we inhale that oxygen, basically the air which is having the oxygen. So that air goes through the airway and then into the lungs, and through the lungs it goes into the blood, and through blood it is distributed to every cell of the body. So to save the life of any trauma patient or any patient whatsoever, we have to see whether this route, airway, lungs and blood, whether this is secure or not. So in the basic primary assessment, we have to ensure A for airway, B for breathing, C for circulation, D for disability, E for exposure. Once we are able to save the life of this patient, then we can do a secondary survey where we take a detailed history, do a detailed clinical examination, can do the specific investigations and the definitive treatment of that particular injury. So in primary assessment, airway securing, how we can do that? We have to clear off any debris or any mud, dirt, any foreign bodies from the airway. We have to settle any fractures, maybe the cervical spine. We have to stabilize the cervical spine with a neck collar or cervical collar. To secure the airway, we can put a laryngeal mask airway or endotracheal tube, either from the mouth or from the nose, but nasal intubation should not be done if there is a cribriform plate fracture. That is anterior cranial fossa fracture. The other method to secure the airway, tracheostomy, cricothyroidotomy, needle cricothyroidotomy. If the patient is in severe distress, no oxygen is able to go from the mouth, then just put a needle in the cricoid cartilage so that some air can go from this needle into the lungs. Regarding breathing part, we have to see whether the lungs are able to expand nicely or not. So to see whether the lungs are able to expand or not, if suppose because of trauma, there is injury to the pleura or maybe to the lungs or maybe blood vessels, there might be collection of air or blood in the pleural cavity, air, pneumothorax, blood, hemothorax, sometimes it can be a combination. This might be putting pressure on the lung, because of which the lung would be collapsing. So we have to ensure that lungs should be able to expand properly. And to allow the lung to expand properly, we have to drain the collection and advise breathing exercise. Once the lung is able to expand properly, then the oxygen will be going into the blood. Also, sometimes in trauma situations, the respiratory muscles are paralyzed. If that is the case, then we have to put the patient on artificial lung machine, that is the ventilator. Once the oxygen is able to go from the lungs into the blood, then we have to see that this pipeline of blood in our body, whether it is leaking or not. So any trauma patient, because of bleeding, there would be a leak in this pipeline of blood. So when the blood is leaking out, intravascular volume is going down, so the pressure also is going down. And if the systolic blood pressure is going down, there is not sufficient pressure inside this pipeline to pump the blood to different areas of the body. Like brain may not be receiving sufficient oxygen, heart may not be receiving oxygen, kidney, liver, all these things would not be receiving oxygen. So we have to ensure adequate pressure in this pipeline. And to restore the intravascular volume, the initial fluid of choice for resuscitation would be the isotonic crystalloids, that is normal saline. If that is not available, then ringalactate, or maybe a Hartmann solution which is close to the ringalactate. These are crystalloids. Colloids are not used initially for resuscitation because colloids have got proteins. If you give colloid in this pipeline, colloid will leak from the bleeding site, will go outside the vessel. Outside the vessel, it will exert the oncotic pressure and will drag more intravascular fluid to the outside, further reducing the intravascular volume, further aggravating hypovolemia, further reducing the blood pressure. So the very purpose of restoring the intravascular volume or restoring the intravascular pressure will be defeated. So we don't use colloids initially for resuscitation. Whenever this patient is bleeding, initially the heart starts pumping faster and faster in order to compensate so that oxygen can be supplied to different areas. Tachycardia is the earliest sign of hypovolemia. Even the blood vessels of the skin, they constrict so that the blood move towards the vital organs. So cutaneous vasoconstriction is also an early sign of hypovolemia. However, fall in systolic blood pressure takes some time. If more than 30% of blood loss has occurred, then the systolic blood pressure starts falling, and that means hypotension is a late sign of hypovolemia. When we have to pump in IV fluids, we give a fluid challenge, pump in 1 liter of normal saline within 1 hour. We use 2 wide bore IV cannulas, and these IV cannulas, which cannula has to be used can be remembered by the simple color codings. Like if we go into the core of the earth, there is an orange lava. The surface of the earth, that is the road, is grey. On that, there is a green grass. In that, pink flowers. Above is the blue sky. In that, yellow sun and a violet rainbow. So 14 gauge, 16, 18, 20, 22, 24, 26. As the gauge is increasing, the bore, that is the diameter of the IV cannula, is decreasing. That means if you have to give more fluid in short period of time, you have to use a wide bore IV cannula. That means a 14 gauge or a 16 gauge IV cannula. If you have to give normal fluids in a newborn baby, then obviously the newborn baby, the veins will be very small in diameter. So we use a 26 gauge, that is the violet color cannula in a newborn baby. In adult females, we generally use the pink color cannula. Pink for females, that is how we can remember. Now, whatever fluid we are pumping into this pipeline, whether this fluid is sufficient or not, can be assessed by measuring the urine output. If the fluid is sufficient, that means sufficient pressure is generated in the pipeline, sufficient fluid is going into the kidney, so kidney would be excreting the sufficient fluid out. That means the urine output should be normal. The minimal urine output targeted in this situation is in adults 0.5 ml per kg per minute, in children 1 ml per kg per minute, and in an infant more than 2 ml per kg per In case of adult, the targeted urine output is 0.5 ml per kg per hour. In children, 1 ml per kg per hour, and infant more than 2 ml per kg per hour. If huge amount of blood has been lost, that means RBC has been lost, hemoglobin has been lost. So even if whatever fluid you are giving, but since the RBC, the hemoglobin has gone down, so we have to give hemoglobin RBC, that means blood, to these patients so that oxygen can be carried nicely to the hemoglobin. We also know that we have to stop the bleeding so that whatever fluid we are pumping that remains inside the circulation and the pressure can be maintained. To stop the bleed, we know we need platelets, we need clotting factors, so we can pump in platelets, clotting factors as well. We can use tranexamic acid injection will help in the aggregation of these platelets and clotting factors and stop the bleed. First dose of tranexamic acid given in 10 minutes within 3 hours. Second dose can be given within 8 hours. If even after giving IV fluids, blood transfusions, tranexamic acid, we feel that there is significant bleeding going on inside and patient will die very soon because of blood loss, then we should not wait. We should immediately take this patient in the operation theater, open the area where we suspect the bleed and apply direct pressure to control the bleed. Once the bleed is controlled, then whatever fluid or blood you are pumping in the pipeline, that will remain in the pipeline and the intravascular volume and pressure can remain normal. Best method to control bleeding is a direct pressure. Disability assessment. Whenever there is any bleeding from anywhere in the body, obviously the blood is not getting supplied to the brain, so the brain may show signs of altered consciousness, for which we can measure with a Glasgow Coma Scale that what is the severity. And in exposure, we have to expose the patient completely, impress the patient completely, but we have to take care of hypothermia. We should cover the patient with warm blankets, because whenever there is bleeding, not only blood is getting lost, but you know that blood is at temperature of 37 degrees, which is getting lost. So the patient is actually going into hypothermia already. So we should not aggravate this hypothermia. We have to undress by taking care of this hypothermia. To assess the Glasgow Coma Scale, we measure the eye, verbal and motor responses. Maximum eye 4, verbal 5, motor 6. Total maximum GCS 15, total minimum 3. For eye responses, if the patient is able to open the eye spontaneously, it is 4. If he opens his eyes on voice command or to some sound, that is I3. If he opens his eyes on pressure or painful stimulus, this is I2. If he does not open his eyes, that is I1. Verbal responses, if the patient is fully conscious and well oriented to time, place and person and talking to you in a decent manner, this is verbal 5. If the patient is confused, then it is verbal 4. If the patient is using inappropriate words, that is verbal 3. If he is not able to speak out any words, but he's just making some sounds, this is verbal 2. And if no sound is coming, this is verbal 1. In the motor responses, we see whether the patient is able to use the motor movements properly or not, if he's able to move the limbs like that. So if he's able to obey all our commands, that is motor 6. If he localizes the stimulus, pinchy stimulus, that is motor 5. If he shows withdrawal movement or a normal flexion movement, that is motor 4. Abnormal flexion movement, motor 3. Extension, motor 2. And no movement at all, that is motor 1. We can also grade the severity of injury into mild, moderate and severe. GCS of 13 to 15 is mild injury. 9 to 12, chalti ka naw se bara, that is moderate. And 8 or less than 8 is severe. Out of all these responses, motor response is considered as the best for prognosis. If we are not able to test any response, then we use the term NT. If there is any variation in the responses between two sides, then the better response is considered in GCS. We can do the segregation of the patients, that is triage, into different categories. Red category means the injury is very serious, it is immediately life-threatening. We have to do immediate intervention, preferably within 6 hours. Yellow, injury is not immediately life-threatening, but definitely injury is serious. So we might wait for some time, but intervention has to be done maybe within 24 hours. Green is for an ambulatory patient who is not having any significant injury, may require some hospital care, but he can easily wait. And black is black, pulseless. Either the patient has died or the situation is such that whatever we do will not be able to save the life of this patient. So we should not waste our precious time or precious seconds in saving these black category patients. We should focus more on the red, yellow category patients. White is ambulatory patient who does not have any injury, who does not require any hospital care. Once the life has been saved, then a detailed history, examination, investigation, and treatment can be done. In detailed history, we should not forget to take the history about ample, A for allergy, M for any medications, like if the patient was taking aspirin, the risk of bleeding would be high, so we should give antiplatelets. We should give platelets for this patient. If the patient is taking warfarin, then we have to give vitamin K and fresh frozen plasma. If the patient was taking heparin, then we have to give counter to heparin, that is protamine sulfate. P is for any past illness or pregnancy. L, when did the patient had the last meal, and E, what were the events of injury. Basic story about shock. Shock is simply hypoperfusion of tissues. That means inadequate organ perfusion and tissue oxygenation. Now, most common type of shock we see in trauma patients is a hypovolemic shock. If we just try to understand the basic sciences, we know God has given us a wonderful heart to pump the blood to different parts of the body, but if this heart is not able to pump the blood, maybe because of injury to the heart, maybe because of collection of blood around the heart, that is pericardial effusion or cardiac tamponade type of situation, or maybe myocardial infarction where the heart is not pumping, that is cardiogenic shock. So the oxygen will not be going to the tissues. The commonest shock what we see in trauma patient is this hypovolemic shock. If this is the artery and if there is bleeding from this artery, that means oxygen is getting lost here, so tissue is not receiving the oxygen. Hypoperfusion of tissues, that is shock. This is hypovolemic shock. If there is a bacterial party going on in some area, there will be intense inflammation causing vasodilatation, so the blood will be diverted towards this particular area. That means blood will be stealed from other areas, which will lead to hypoperfusion in the other areas. So this type of shock, which is related to infections, is called a septic shock or a warm shock. And if there is an injury or trauma or maybe anesthesia wherein the brainstem or the cervical thoracic spine, they are gone, then the sympathetic will be blocked. And if the sympathetic tone is gone, then the capacitance vessels in our body, that is the veins, they will become dilated. So the blood will remain pooled in these capacitance veins and the blood will not be able to come to the heart. So if blood is not coming in the heart, how will the heart be able to pump the blood out? This type of shock is called as neurogenic shock. In this hypovolemic shock, earliest sign we know is tachycardia. So more than 100 beats per minute in an adult is tachycardia. In a school child, more than 120, preschool more than 140, infant more than 160. Now, bleeding or hemorrhage, we can measure the amount of blood loss by some crude methods. Blood clot in a clenched fist 500 ml. If we talk about closed fractures, then maybe humerus or tibia fractures, the blood loss is considered as around 750 ml, femur 1500 and pelvic fractures 2000 ml. Another method to calculate the blood loss is colorimetric method, which is a hemoglobin estimation. Before the trauma or before the operation, that is pre-op hemoglobin, we subtract the post-op hemoglobin or post-trauma hemoglobin from that, and whatever is the difference, that is X grams. 1 gram is taken as 1 unit of blood, that is 450 ml of blood. Important for us would be the different categories of blood loss. Just like the scores in the tennis game, 0 to 15, 15 to 30, 30 to 40, more than 40. 0 to 15, 15 to 30, 30 to 40, more than 40. That means 7 up to 750 ml, then 750 to 1500 ml, 1500 to 2000 ml, and more than 2000 ml. These are the different 4 categories of blood loss. And in these 4 categories, for pulse rate, and the other parameters, they remain in class 1 blood loss, because losing up to 750 ml of blood is just like if you are giving say 2 units of blood donation. That is not going to cause too many significant changes. So everything remains normal, whether it is the pulse, respiratory rate, systolic pressure, urine output, or GCS, that is normal. But as the blood loss increases, the pulse rate starts rising, and we may find pulse rate more than 100 to 120 beats per minute. The respiratory rate might go from less than 20 to 20 to 30 per minute. But the systolic BP starts falling when there is more than 30% of blood loss. That means category 3 or 4 blood loss. So systolic pressure remains normal, and if systolic pressure is normal, that means sufficient fluid will be going to the kidneys, so the urine output will be normal. If sufficient pressure is there in the pipeline, then blood would be going to the brain as well, so GCS would also be normal. So class 1 and class 2. Class 1, everything is normal. Class 2, only the pulse rises from 100 up to 120, respiratory rate from 20 up to 30, but systolic BP, urine output, and GCS remains normal. However, in class 3, pulse rate 120 to 140, respiratory rate 30 to 40, systolic BP starts falling, so urine output and GCS will also start falling. Class 4, that is more than 40% of blood loss. More than 2000 ml of blood loss is quite significant. Pulse rate going from more than 140 beats per minute, respiratory rate more than 35 per minute, systolic BP markedly going down, urine output almost negligible, and GCS would also be going down drastically. Urine output start reducing in mild shock. However, urine output is reduced in moderate shock. The ideal replacement for blood loss is blood transfusion. The storage temperature of blood is 4 plus minus 2 degrees centigrade. We use SAGM as the anticoagulant, sodium chloride, adenine, glucose, mannitol, and this is shelf life of 5 weeks. There may be some complications of blood transfusion, like transfusion reaction, simple pyrexial reaction due to pyrogens in the donor apparatus. Maybe a wrong blood is transfused due to incompatibility, mismatched blood transfusion. The commonest reason for this is a clerical error. This can lead to antigen antibody reaction, which can form large clumps and cause renal failure. Most common symptom of mismatched transfusion is pain and heat sensation along the vein. Most common sign of mismatched transfusion is oliguria, which is more common than hemoglobinuria. Most common sign in anesthetized patient during the operation when patient is under anesthesia. If the surgeon notices generalized losing of blood from the cut surfaces, that means a wrong blood has been given to this patient. And in the treatment for this mismatched transfusion, because antigen antibody clumps have blocked the kidneys, we have to give diuretics, or we might have to do dialysis. Another complication of blood transfusion can be air embolism, thrombophlebitis. Various infections can be transmitted through blood, like HIV, hepatitis B, hepatitis C, malaria, syphilis. Massive blood transfusion, when more than 10 units of packed RBCs are given within 24 hours, or more than 4 units of packed RBCs given within few hours. Complications of massive transfusion, because you are giving huge amount of blood in a quick period of time. There may be volume overload, congestive cardiac failure, hyperkalemia due to lysis of RBCs in the stored blood. There can be hypothermia, thrombocytopenia, DIC, that is disseminated intravascular coagulopathy or dilutional coagulopathy, and metabolic acidosis, because the stored blood has a pH of 6.3. We should know that the stored blood, the viability of platelets and clotting factors is quite low. So if you are giving massive transfusion which do not have viable platelets and clotting factors, this will lead to deficiency of platelets and clotting factors in the recipient, deficiency of platelets, thrombocytopenia, deficiency of clotting factors, the blood will not clot. So it will keep on coming out from the cut surfaces, coagulation failure, or disseminated intravascular coagulopathy or DIC. The treatment for thrombocytopenia will be giving platelets, and treatment for this DIC should be giving clotting factors. Fresh frozen plasma is a rich source of clotting factors. Fresh frozen plasma is stored at minus 40 degrees centigrade, and it has a shelf life of 6 months to 2 years. If you go to the organ-specific traumas, like the head trauma, in the head, there are 3 things: the scalp, skull, and the brain. CSF and skull, they both protect the brain. In the scalp, the most dangerous zone is the loose cellular tissue, because there are emissary veins which connect the scalp with the brain. So any roadside dirt can travel through this loose cellular tissue and cause brain infections. Scalp lacerations should not be treated lightly. We should clean these lacerations thoroughly, irrigate them nicely with normal saline, suture them in 2 layers, first the talia aponeurotica and then the skin. In the skull, there can be different type of fractures, like linear fracture. This is usually due to a blunt trauma to the skull, while depressed skull fracture is because of a penetrating trauma like this. There can be base of skull fracture. Base of skull can be divided into anterior, middle, posterior cranial fossa. In the anterior cranial fossa, most common part injured is the cribriform plate or the ethmoid bone. This causes leakage of CSF from the nose, CSF rhinorrhea, collection of blood around the eyes, periorbital hematomas, raccoon eyes, or panda's sign. Middle cranial fossa, the commonest part injured is the petrous part of temporal bone, which can cause CSF leaking out from the ear, CSF autoria, and bruising brownish discoloration of the mastoid, Beckel sign. So Beckel sign is seen most often in the middle cranial fossa fractures. Posterior cranial fossa fractures, there can be occipital bone injuries. Pons fracture is something which is seen in children, and orbital blood fractures, the commonest part injured is the inferior wall or the floor of the orbit. The second commonest part would be the medial wall of the orbit. Inside the brain, there can be primary or secondary injuries. Coup and counter coup. Coup is injury at the site of impact. Counter coup is injury opposite to the site of impact, commonly seen when the head is in motion. Primary brain injuries means direct injury to the brain parenchyma, which can be classified as diffuse axonal, cerebral concussion, and cerebral concussion with laceration. Diffuse axonal injury is simply injury to the axons. Depending on the number and severity of axonal injury, the patient presentation is also variable. If less axons are injured, patient may be normal. More axons injured, he may be confused. More axons injured, comatose. More axons injured, he may even die. When we do a CT scan, we do not find anything on CT scan in diffuse axonal injuries. However, in 20% of the cases, we may see some pinpoint hemorrhages or punctate hemorrhages. Cerebral concussion. Cerebral concussion is basically a hidden injury, so there may be nausea, headache, amnesia to the patient. CT scan will be normal in this situation also, and treatment will be just rest and hydration. Cerebral concussion with laceration. If there is laceration of the brain parenchyma, this can lead to focal neurological deficit which persists for more than 24 hours. In the secondary brain injuries, it is the after effect of primary injury. Like there can be hematomas inside. For example, if you look here, collection of blood within the brain parenchyma, this is intracerebral hematoma. The blue colored, what we are seeing here, suppose this blue color is the dura mater. If there is collection of blood outside the dura mater, this is extradural or epidural. If there is collection of blood beneath the dura mater, this is subdural hematoma. The extradural hematomas most commonly are seen in the temporoparietal region due to injury to middle meningeal artery, which is a branch of maxillary artery. There can be injury to transverse sagittal sinuses, and these extradural hematomas may present with lucid interval, which is a transient period of consciousness after trauma, where the patient remains fully conscious, can carry out the normal routine activities, but may collapse later on. The extradural hematoma appears hyperdense biconvex on a CT scan, and this is because of the attachment of dura with the bone at different places. So extradural hematoma looks like a lens that is lenticular, or we can call it as an orange, right? While subdural hematoma, which is also called as Boxer's hematoma, this is due to injury to cortical bridging emissary veins. On a non-contrast CT, it appears hyperdense, concave, or convex, crescent type like a banana. Whether it is extradural, subdural, or any head injury in the initial phase, we do a non-contrast CT scan. Subdural hematoma, if Up to 3 days we call it as acute, 4 to 21 days subacute, after 21 days chronic. Management of head injury, as we know that brain is surrounded by the skull and there is no extra space in this brain which can accommodate any external thing. Whenever something extra comes into the brain, whether it is air, blood, fluid, tumor, there is fighting for space inside the brain which increases the intracranial pressure. If the intracranial pressure increases, then the cerebral perfusion pressure, that means the pressure at which the blood is being perfused to the brain cells, that will decrease, and this will decrease the oxygen supply to the brain cells. The duration of hypoxia to the brain is directly proportional to irreversible damage to the brain. As a doctor, we don't want any part of the brain to suffer from irreversible damage. So we want that oxygen should be perfused into the brain. And for doing this, we have to reduce the intracranial pressure. Normal intracranial pressure is between 8 to 12 millimeter of mercury. If it becomes more than 22, then it is quite dangerous and fatal. So as a doctor, we have to keep these intracranial pressures below 20 millimeter of mercury so that cerebral perfusion pressure can be kept above 60 millimeter of mercury. For reducing the intracranial pressure, we can use diuretics. Osmotic diuretic used is mannitol, but mannitol should be used with caution because mannitol can cross the blood-brain barrier, and if there is large area of bleed inside the brain, if you are giving mannitol, it leaks into that bleed area, and because of osmosis, it will drive more intravascular blood into the extravascular space, further aggravating the bleed. If diuretics are not able to control the bleed, then we can create burr holes or decompressive craniotomies. Lumbar puncture is best avoided because if the intracranial pressure is high and you put a needle into the lumbar space, the brain will come to know that some window has opened somewhere, and because of high pressure here, the brain may try to herniate through the foramen magnum. So to avoid the risk of cerebral herniation, we should avoid doing a lumbar puncture. The fluid which we can use in head traumas, the normal saline, ringalactate, hypertonic saline, but dextrose-based solution should not be used because hyperglycemia is harmful to brain. In the face, we can divide the face into upper face and lower face. Upper face, there are Lee-Ford fractures discussed in ENT classes. Sorry. Lower face, the mandibular fractures, most common part in that is the condyle. Second most common, the angle of mandible. The dangerous is the symphysis mentae fracture because there is insertion of genioglossus muscle. If there is fracture of the symphysis here, the genioglossus insertion can be lost and the tongue can fall back and close the airway and patient can die. For these mandibular fractures, we can take X-ray which shows the entire mandible, that is called as orthopentamogram. Like this, what we are seeing is an orthopentamogram, and here we can see the site of fracture as well. In the treatment, we have to align the two fractured ends. So if the patient teeth are intact, we do an interdental wiring. If the patient teeth are lost in the accident, edentalus patient, then we do a open reduction and internal fixation with the help of plates and screws. In the neck trauma, blunt traumas, there can be injury to the cervical spine, for which neck immobilization, cervical collar is required. Neck is usually saved. The soft tissue of the neck are usually not injured because above there is face and below is chest. But in penetrating traumas, there can be injury to any zone of the neck. Zone 1 is from the suprasternal notch to the cricoid cartilage. Zone 2 is from the cricoid cartilage to the angle of mandible, and zone 3 from the angle of mandible to the base of skull. If there is trauma, penetrating trauma to any of these areas, and the foreign body is inside, any foreign body should not be removed on the roadside. Patient should be taken inside the operation theatre under full control. These foreign bodies should be removed. If there is no foreign body inside, just there was somebody who has hit the knife and taken the knife out, there is just a hole here. Whether the patient is stable or unstable, if the patient is stable, we admit the patient for observation, and then maybe we do not require any exploration or anything, and the treatment would be conservative. But if the patient is unstable, maybe the bleeding would have been very severe. So we do the basic resuscitation, ABCDE, try to save the life. And if even after giving IV fluids, blood, and tranexamic acid, the bleeding is not stopping, that means we have to take the patient in the operation theatre, extort this area completely, apply the direct pressure, and control the bleed and save the life of the patient. To calculate whether the patient is stable or unstable, we can take the help of shock index, which is the ratio of pulse rate to systolic blood pressure. If this ratio is 1 or more than 1, then we consider the patient is hemodynamically unstable. In the chest trauma, most common part injured are the ribs. It is usually on the left side. 4 to 9 ribs are commonly injured. This can lead to either pneumothorax, hemothorax, or hemopneumothorax. For example, if this is the normal lung parenchyma, on this side, this all supposes the collection of air. So this is pneumothorax. This is going to put pressure on the ipsilateral lung. So ipsilateral lung can collapse. If there is injury to any blood vessel inside, blood can get collected, which will put pressure on the lung. So there will be a lung collapse on this side. This is hemothorax. If there is massive collection of air, then this is not only going to put pressure on one side of the lung, but it will also shift the mediastinum to the opposite side, and this will put pressure on the other lung as well. If both the lungs are under pressure, that means the oxygen is not going inside. That means the patient is going to die very soon, within seconds or minutes. So this is a dire surgical emergency, tension pneumothorax, where we have to put a wide bore needle into the fourth intercostal space, just anterior to the midclavicular line, to decompress the system, so that we can buy some time. The lung may be decompressed, oxygen may go inside, and then we may get 5 to 10 minutes or 15 minutes where we can put the intercostal tube and decompress the entire system nicely. So in pneumothorax or hemothorax, if only one lung is affected, that means the other lung is normal. That means oxygen is still going into the blood, so the patient may have mild difficulty in breathing or dyspnea. In these cases, where we do percussion, percussion is done by the middle finger on the middle finger, and the movement in percussion occurs at the wrist joint. If you hear a resonant note, tympanic note, or a nice loud note, that means there is air, pneumothorax. But if the sound becomes dull, that means there is fluid, maybe in hemothorax or hydrothorax or pleural effusion. When we do the auscultation, whether it is pneumothorax or hemothorax, if you're doing the auscultation, then you may not hear the breath sounds in that area where the lung is not there. You may not hear the breath sounds in the area where the lung is not there. So diminished breath sounds would be seen. Now, first investigation would be a chest X-ray, and in the chest X-ray, if you see more blackness, that means hyperlucency. This is pneumothorax. Here you are not able to see any bronchovascular markings. For example, in this area you are not seeing the bronchovascular markings, so this means that lung is collapsed here. If there is a hemothorax or maybe any pleural effusion or something, then this fluid will be getting collected down. So you will see a white haziness here and a blunting of costophrenic angle. This is hemothorax or maybe hydrothorax or pleural effusion. But if the story is related to trauma, then most likely it will be a hemothorax. Best investigation or investigation of choice would be a CT scan. The treatment for these pneumohemothoraxes, we want that patient should not have any difficulty in breathing. That means this lung should expand nicely. To achieve adequate lung expansion, you have to brain this collection and breathing exercise for expansion of lung. To brain this collection, we can put the intercostal tube, and this intercostal tube is put in the 4th or 5th intercostal space, just anterior to the mid-axillary line. Now these 4 lines what we are seeing here, this supposes the mid-clavicular line. Then there are 3 lines in the axilla, the anterior axillary line, the mid-axillary line, and the posterior axillary line. The intercostal tube is put in the 4th or 5th intercostal space, just anterior to the mid-axillary line. And this tube is connected to an underwater seal brain. This tube is put along the upper border of the lower rib, and this tube is usually 28 to 32 French in size. Once the collection is trained, we advise the patient to do breathing exercises with a spirometer or maybe a football bladder to achieve adequate lung expansion. This procedure of putting a tube and draining the collection from the pleural cavity is called as tube thoracocentesis. Sometimes when we put the intercostal tube, we may find huge amount of blood coming out from the tube. If more than 1.5 liters of blood has been drained through the intercostal tube at one instance, or there is more than 200 ml per hour of blood coming out from the tube for consecutively 2 to 4 hours or more than that, then also it means there is significant bleeding inside. We should not wait. We should do a thoracotomy, apply direct pressure, and control the bleed. If there are major tracheobronchial or esophageal ruptures, then also we have to do a thoracotomy. Tension pneumothorax is a real surgical emergency where the patient would be in severe respiratory distress due to massive air collection. Because of this massive air collection, there is a shift of the mediastinum to the opposite side, and the opposite lung is also compressed. Because of this, the patient may have dilated engorged neck veins also, because there will be compression of the vena cava, because of which the neck and facial veins may get dilated and engorged. Because this is a dire surgical emergency, whatever widest bone needle is available in the emergency, put that needle in the 4th, 5th intercostal space just anterior to the mid-axillary line in case of adults. However, in case of children, in a needle thoracocentesis for tension pneumothorax, we can put this needle in the 2nd intercostal space in the mid-clavicular line. Finally, the treatment for these tension pneumothorax would also be intercostal tube drainage and breathing exercise. This tension pneumothorax should be differentiated from cardiac tamponade. In cardiac tamponade, there is huge amount of blood which is getting collected around the heart, maybe because of injury to the heart or something, because of which if there is huge amount of fluid in this area, it can compress the vena cavas. Again, the neck and facial veins would be dilated. The heart is not able to pump because heart is being pressed, so there will be hypotension. And when you auscultate this area because of fluid all over the heart sounds will be muffled. This dilated engorged neck veins, hypotension and muffled heart sounds is called as Beck-Stride seen in cardiac tamponade. In this, heart sounds are muffled, but breath sounds will be normal. While in tension pneumothorax, breath sounds will be diminished, but heart sounds will be normal. This cardiac tamponade would require immediate pericardiocentesis by putting a needle into the pericardial cavity. There is a sucking wound of open pneumothorax. If somebody has hit a knife into the thorax and takes the knife out, there is an open wound in the thorax. Since outside pressure is positive and inside pressure is negative, air from outside will be continuously sucked inside, and that can lead to massive pneumothorax or tension pneumothorax. Again, this would be a real surgical emergency. Immediately what we can do, at least, we can just put a paper or a silver foil over that wound and put a tape on 3 sides. By doing this, you prevent the outside air from going in, plus at the same time, this may act as a one-way valve wherein the inside air will be coming out, but the outside air will not be going in. However, again, this would require intercostal tube drainage and breathing exercises as soon as the patient becomes a little stable. Flail chest is fracture of 2 or more than 2 consecutive ribs at 2 or more than 2 sites, and this flail segment shows paradoxical respiration. That means opposite movement. Normally during inspiration, the lungs move out, the rib cage also moves out, but in flail chest, during inspiration, the lungs move out, but this flail segment, this will move inside, which can cause serious injury to the lungs. So this is also a real surgical emergency where we have to do immediate operative corrections. So emergency conditions include tension pneumothorax, open pneumothorax, flail chest, and cardiac tamponade. In the abdominal traumas, blunt abdominal traumas, most commonly spleen, second most commonly liver. Penetrating abdominal trauma, most commonly liver, second most commonly small intestine. In the seatbelt abdominal trauma or whiplash injury, it is a mesentery. Mesentery is carrying the blood vessels which are supplying blood to the intestine. So if mesentery is injured, then blood supply to the intestine will decrease, leading to gut ischemia. In bomb blast injuries, usually the air-filled cavities are injured, like the eardrum, trachea, lungs, and the intestine. Most common structure injured is eardrum, but most common organ injured would be the lungs. In blunt abdominal traumas, depending on whether the patient is stable or unstable, suppose there is abdominal trauma and patient is hemodynamically stable, that means there is not significant injury inside, or even if there is a significant injury, suppose splenic injury, but the blood may have clotted around the spleen, and this clot may put pressure on the spleen which prevents any further bleed. That is why the patient is stable. In these situations, admit the patient in the hospital for observation. Since the patient is stable, you can do the investigations. First, you do a FAST, that is focused assessment by sonography in trauma. Then better than ultrasound would be CCT. So the best investigation or investigation of choice would be CCT in a hemodynamically stable patient. And if CCT also shows that everything is stable inside, no active bleed inside, the treatment can be conservative without any operation. But if, because of this trauma, there is significant injury to the spleen or liver, major bleeding inside, blood loss, hypovolemia, patient going into shock, hemodynamically unstable. Now, in these unstable patients, it is a multimodality approach. You know that first and foremost, you have to save the life. To save the life, A, B, C, D, E, A for airway, B for breathing, C for circulation, D for disability, E for exposure. So multiple doctors are taking care. Somebody's taking care of the airway, somebody taking care of the circulation. In these situations, when the basic resuscitation is going on with the IV fluids or maybe blood, then if the facility of ultrasound is available in the emergency, you can quickly do a FAST, and that can tell you where is the significant injury. In this particular patient who is going to die very soon, there is no time to get a CCT done. So CCT is not done in a hemodynamically unstable patient. So in these unstable patients, once you do a FAST and FAST turns out to be positive, patient is not getting controlled, the bleeding is not getting controlled by pumping an IV fluids, blood or tranexamic acid, immediately take this patient in the operation theater, do a laparotomy, apply direct pressure to the bleeding site, and take control of the bleeding and save the life of your patient. For doing a laparotomy, we prefer a midline incision because it is the fastest access to the peritoneal cavity. It has got equal exposure on both sides and can be extended easily on both the sides. During this laparotomy, sometimes if there is major liver bleed we've noticed, then we can simply put our thumb and the finger in the foramen of Winslow or maybe a clamp in the hepatoduodenal ligament to block the portal vein and hepatic artery, because 80% of blood to the liver is supplied by the portal vein, 20% by the hepatic artery. If you block both of them, no supply to the liver, the bleeding can stop. And at least this would help in saving the life of this patient. When we are doing a FAST, that is focused assessment by sonography in trauma, we keep the ultrasound probe in 4 areas: epicastrum for pericardial fluid, right hypochondrium for liver, right kidney, left hypochondrium for spleen, left kidney, and pelvis for any free fluid. E-FAST is an extended FAST when the abdominal sonography is extended to the thorax. So here, apart from these 4 areas, we are also putting the ultrasound probe in bilateral pleural areas to look for any pleural collection. Diagnostic peritoneal lavage, that is just making a cut beneath the umbilicus and putting a infant feeding tube or a fine catheter into the peritoneal cavity, putting 100 ml of saline in the peritoneal cavity and aspirating the fluid whether it is bloody or not. This is a sensitive investigation to see whether there is bleed in the peritoneal cavity or not, but because it is invasive and now we have got FAST available, so now diagnostic peritoneal lavage has become obsolete. In penetrating abdominal traumas, if the foreign body is inside, this has to be removed inside the operation theater only. If the foreign body is not inside, just a hole in the abdomen here. And if the patient is stable, see whether there is any breach in the peritoneum or not. No peritoneal breach, that means the foreign body has not gone into the peritoneal cavity. No need to do a laparotomy, just do a wound exploration. If penetrating abdominal trauma, patient is stable, but you find a peritoneal breach, maybe because of momentum coming out, or maybe you are seeing the intestinal peristalsis from the wound, that means the penetrating object or the knife has gone inside the peritoneal cavity. Patient may be stable, that means there is no major vascular injury inside, but still there is the possibility of intestinal perforation by that knife. So we admit this patient in the hospital, keep him under our observation for 24 to 48 hours. If the patient develops any symptom signs of peritonitis, then we do a laparotomy, otherwise laparotomy will not be required in these patients. However, penetrating abdominal traumas, if the patient is hemodynamically unstable, that means there is a serious vascular injury inside. So you first do the basic resuscitation to save the life, the same ABCDE, and then you might take this patient for exploration to apply direct pressure at the bleeding site, take control of the bleed, and save the life of this patient. In the retroperitoneum, we can divide the retroperitoneum into 3 zones. Zone 1 is the central zone, which is having the aorta and the IVC. Zone 2 is the lateral zone, which is having the kidneys, and zone 3 would be the pelvic retroperitoneum. If the patient is hemodynamically unstable, trauma to any of these zones, we know we have to follow the same protocol, ABCDE, and then exploration, apply pressure, stop the bleed, and save the life. If the patient is stable, generally no surgical exploration is needed, but if there is trauma to zone 1 and the patient is stable, then also there is a possibility that because aorta and IVC are lying here, a small blood clot may be pressing the injury, and that is why it is not bleeding out. The patient is stable, but this clot can dislodge at any point of time. So even if the patient is stable, for zone 1 retroperitoneal traumas, we take the patient in the operation theater, do exploration, and see whether anything is required or not. In the thermal trauma of the burns is simply any damage or destruction of the skin or its appendage by any insult, which may be heat, cold, electrical, chemical, radiation. Most common burn what we see in day-to-day practice are the scalds. Scalds are caused by hot liquids, but they don't come to us in the hospital. Most commonly, the patient of burns coming to us in the hospital are of flame burns, fire burns. And now, in these flame burns, the 3 pathophysiological events, hypoxia, hypovolemia, and sepsis. Reason for hypoxia can be because of this injury, there can be injury to the airway. So, rheumatoid tumor dolor, swelling of the airway will not allow the oxygen to go inside. There may be the soot particles or the carbon particles may be inhaled by this patient, which may be going down into the alveoli, can cause chemical alveolitis, alveolar edema, which will not allow the oxygen to go nicely into the blood. There may be toxins like carbon monoxide or hydrogen cyanide, which has gone inside the body, and carbon monoxide has got more than 200 times affinity than oxygen to bind with hemoglobin. So whatever oxyhemoglobin this patient will be having, all the oxygen will be displaced and carboxyhemoglobin will be there now, so cells will not be receiving oxygen, hypoxia to the cells. If there are deep burns over the chest wall, then a scar is seen in deep burns, and this scar has a leathery appearance which may not allow proper movement of the ribs, because of which again there can be hypoxia. Hypovolemia is loss of intravascular volume. In this burn patient, there is intense inflammation, so the blood vessels become leaky, and the intravascular fluid leaks into the extravascular space, leading to hypovolemia, hypovolemic shock, and collection of fluid in the extravascular space can lead to edema. First 24 to 36 hours is the most crucial period. Sepsis. You know that God has given us a wonderful skin, which acts as a natural defense barrier and which protect from invasion by external microorganisms. But if the skin is lost, if the skin is damaged, then the external microorganism can invade easily and can lead to serious infections. Most common infection in a burn patient is by Pseudomonas, and second most common by the Staph aureus. To assess the severity in a burn patient, inhalational injury is very important. If there is any evidence of burns around the nose, or maybe the lips, or maybe the face, neck area, like signing or burning of the nasal hairs, that means the airway might have swelled, which will require early endotracheal intubation. We can also assess the severity by calculating the percentage of burns, for which we use a Wallace rule of 9. According to Wallace rule of 9, 9% for the head and neck, 9% front of chest, 9% back of chest, 9% front of abdomen, 9% back of abdomen, 9% for one upper limb, 9% for front of one lower limb, 9% for back of one lower limb. So this makes 99, and 1% is for the perineum. 1% is for the perineum. In case of children, the surface area of the head and neck is much bigger as compared to the adult. So at 1 year of age, head and neck burn is taken as 18%, and then we reduce 1% every year, so that at 10 years of age, it comes out to be 9%, which is equal to that of adult. In a patchy distribution of burn, we can also take the help of palm rule, and palm rule is actually just the palmar surface of the hand. And in this palmar surface of the hand, this means the palm and the fingers. This is equal to 1%. So you cut a piece of paper equal to the size of the patient's hand, and it means only the palm and the fingers and not the upper limb. So this is what you're seeing on the screen, this is hand, and this is 1%. Now you take this paper and put on all the burnt areas and calculate the percentage of burns. In children, we can also take the help of Lund and Browder chart. Right. The hand burns or the palm rule says it is 1%. Another method to assess the severity is to calculate the depth of burn. For example, if suppose only the epidermis is involved, then it is first degree. If dermis is involved, then it is second degree. If subcutaneous fat is involved, third degree. If muscle or bone is involved, fourth degree. Second degree can be divided into second degree superficial when only superficial dermis is involved, second degree deep when deep dermis is involved. So that is how we can classify 4 degrees: first degree epidermis, second degree dermis, second degree superficial dermis, second degree deep dermis, third degree subcutaneous fat, and fourth degree muscle or the bone. The first degree burns, they are just like abrasions, just like the sunburns. Burns के नाम पे कलंक हैं. They do not require any treatment, just exposure. They are not included in calculating the percentage of burns. While second degree superficial burns, they are pink in color. They are painful because the nerve endings are lying in the deep dermis. So second degree burns, they are painful. First degree are also painful. Second degree are also painful. Second degree superficial, they are pink in color. They are painful. They may be associated with blister formation. Second degree deep, they are red, blotchy, velvety in appearance. Painful, blister formation is there. While third and fourth degree burns, where the entire skin has become dead, so they appear either white or black, leathery in appearance. They are painless because the nerve endings are completely destroyed, which are located in the deep dermis. Right. And these third and fourth degree burns will require surgery, where you will have to remove the skin because this is dead, and do a debridement and then put a new skin grafting. To manage these burn patients, the pre-hospital management ensure the rescue of safety first and follow the protocol: stop, drop, and cool. Stop the burning process, drop the burning person on the ground with the burning surface up, and cool this burn wound with running water at room temperature. Ice should not be used for cooling because it can cause hypothermia. Already in a burn patient, there is intense inflammation going on where the intravascular volume is leaking out, and from out it is going to the atmosphere also. So the heat is actually getting lost to the atmosphere. Burning per person from inside, he's going into hypothermia. Ice should not be used because this can cause serious hypothermia and patient can die. Once the patient is brought to the hospital, first thing to be done is save the life, the same ABCD. Airway, if there are airway burns, early endotracheal intubation is recommended because if you put the endotracheal tube late, the patient might develop laryngeal edema and then it would be difficult to put this endotracheal tube. For breathing part, just a moment. Right. For breathing part, if there are extensive burns over the chest, which might be causing respiratory muscle paralysis, then we have to put this patient on ventilator. Circulatory part, we know that we have to restore the intravascular volume. So we pump in IV fluids. Initial fluid of choice for resuscitation, the Cristalux. Here we prefer using ring lactate. If ring lactate is not there, then Hartmann solution. And if that is also not there, we can use normal saline. Colloid should not be given in the first 24 hours for the reasons we discussed earlier. How much fluid has to be given? That can be calculated by ATLS formula. In case of adults, 2 into percentage burns into weight in kgs. This gives us the XML of ring lactate to be given in first 24 hours. Half of this has to be given in first 8 hours and half has to be given in the remaining 16 hours. However, in children, we multiplied by a factor of 3 and in electrical burns, we multiplied by a factor of 4. The original Parkland formula says 4. So, unless and until in the exams they specify about Parklands, we don't use Parklands, we use ATLS formula, that is Advanced Trauma Life Support Guidelines. Whatever fluid we are giving, whether that is sufficient or not, that can be assessed by urine output. Once the life of the patient is saved, then we can do the definitive treatment, like for the burn wound. If it is first degree burns, just exposure, no treatment. Second degree burns, we don't want external contamination going inside. Blisters should not be broken because they act as a sterile dressing. However, for second degree, we can put the dressing. Most commonly, we use silver sulfadiazine in a concentration of 1%. We can use mupirocin, mefenide acetate, and silver nitrate solution. Mefenide acetate is painful, causes metabolic acidosis. For third and fourth degree burns, which are full thickness, that means the entire skin is dead. So we do a debridement and put a new skin, that is skin grafting. When we are doing the skin graft, auto-iso, allo-xeno, autograft, same person, iso identical twins, allo same species, and xeno different species. Instruments used in skin grafting, Humbee's knife and Wolf blade. We can also use dermatome. This what we are seeing is the Humbee's knife. Now, with this Humbee's knife, we can either take a partial thickness graft or a full thickness graft. Most commonly, the partial thickness graft, which are called as the split skin graft, also called as Thiersch graft. These partial thickness of split skin graft or Thiersch graft are composed of epidermis and superficial dermis, most commonly taken from the thigh. The anteromedial aspect can be taken from the anterolateral aspect of thigh as well. These grafts, once taken, the donor area is covered with a bandage for 14 days. After 14 days, when we take off the bandage, this area shows nice epithelium growing here. There are 2 organs in our body which can completely regrow: skin and liver. When we have to put the skin graft, partial thickness skin graft can be expanded, so it can be used to cover a large area. But the drawback is these partial thickness graft, they contract more, so the cosmetic outcome is not very good. When we have to take a full thickness graft, then full thickness graft are also called as Wolf graft. They are composed of epidermis and complete dermis. They are most often taken from the post-auricular and supraclavicular region. The donor site has to be sutured. These full thickness graft cannot be expanded, so they can cover only small areas. But the best part is they contract less, so the cosmetic outcome is good. If we have to use a graft on the face, we prefer using a full thickness graft. Now, when we are going to put the graft at the recipient site, there should not be any infection, especially beta hemolytic streptococci should not be there because it can eat up the graft. There should not be a bare bone cartilage or tendon because the skin will not be taken up on the bare bone cartilage or the tendon. Once we put the skin graft here, then, as you can see, we have created multiple holes in this graft. This will allow the granulation tissue to come up, which will help in fixing of the graft as well. How the skin graft is going to survive? The first 48 hours, this skin graft will imbibe the nutrients from the underlying surface. And gradually the neovascularization angiogenesis will start, and this will start having the blood supply. And by 5th day, the graft will settle at the recipient site, and this can be the final outcome of what we are seeing here of skin grafting. Right. We can also do a scarotomy if there is a scar which is acting as a tourniquet. Fasciotomy is something which we do in compartment syndrome. Nutrition in burn patients, enteral nutrition is preferred unless it is contraindicated, and it should be started within 6 hours. There is no rule of prophylactic antibiotics. The physiotherapy in burn patient should be started on day 1, except in case of skin grafting when we start it after the graft has settled, that is after 5 days. Most common cause of immediate death in a burn patient is hypoxia, that is asphyxia, suffocation. Most common cause of early death in burns is hypovolemia, and late death is because of sepsis. Electrical burns can cause damage to the skin like charring, thrombosis of the vessels, injury to the nerves, and most importantly, rhabdomyolysis in the muscles, which releases myoglobin, which can go into the kidney, cause myoglobinuria, which can lead to renal failure also. Electrical injuries, the electrical current can interfere with the rhythm of the heart, that is interfere with the pacemaker. So we have to be very aggressive in the management. Aggressive fluid management has to be done. Management of compartment syndrome is by fasciotomy. The impending sign or the sign of compartment syndrome is pain on passive stretching of the affected muscle. In chemical burns, whether by acid or alkali, acid causes coagulative necrosis, alkali causes liquefactive necrosis. Alkalis are more dangerous because they can penetrate into the deeper areas. The treatment for chemical burns would be irrigation with running water for long duration, 20 to 30 minutes. If there are powder chemical burns, first we have to remove the powder with a brush before we rinse it with water. There is no role of neutralizing agents. For example, if there is an acid burn, don't think that now you have to neutralize it by putting the alkali. Cold burns like frostbite and non-freezing injury or trench foot. Frostbite is something which is seen much below freezing temperatures, and non-freezing injury or trench foot is something which is seen at around 0 degrees centigrade temperature in wet climate or wet conditions like rainy season, fishermen, sailors. Basic difference between the two: in frostbite, there is occlusion of microvessels, while trench foot or non-freezing injury, there is alternating spasm and relaxation of the arterioles. In this frostbite, the patient presents with hardness, numbness, while in trench foot, usually we find signs of inflammation, rheumatoid tumor, callus dolor, maybe some edema is seen here with redness, ulceration, ecchymosis. In the treatment of these cold injuries, we do gradual warming with 40 degrees centigrade warm water bath for 20 to 30 minutes, hot liquids orally, wound hygiene, we should not break the blisters. Aspirin is used, which is an antiplatelet drug, which may help in increasing the blood flow towards the injured site. If there is a microvascular occlusion like in frostbite, there is some role of thrombolytics if they are given within 23 hours. Surgical intervention like amputation of the gangrenous part should be delayed for few weeks or months, because in cold injuries, the denaturation process is slowed. So if you do amputation today, the denaturation might be taking place in the proximal part as well, and then again you'll have to do amputation here. So the amputation or surgical intervention should be delayed for weeks or months unless and until a clear line of demarcation develops between the dead and the live parts, or viable and the non-viable parts. The role of calcium channel blockers, nitrates, vasodilators, hyperbaric oxygen, and sympathectomy is not very clear in these cold burns. Now if you take a look at the vascular surgery story, the vessel story, the artery, veins, and the lymphatics. In arteries, we talk about gradual arterial obstruction like atherosclerosis, Burgess disease, sudden arterial occlusion like embolism, AV fistulas, aneurysms. In veins, we talk about superficial veins problems like varicose veins, deep vein problem like deep vein thrombosis. In lymphatics, we talk about lymphedemas, which can be primary or secondary lymphedemas. In arteries, gradual arterial obstruction, the commonest cause of arterial obstruction is atherosclerosis. Like in smokers, obese, patients who do not have control on their diet, the chances of atherosclerosis are high. Burgess disease, which is seen in smokers or tobacco users only, thromboangiitis obliterans. Burgess disease is commonly seen in young males, less than 30 years or maybe up to less than 45 years. Atherosclerosis is usually seen later in life, maybe after 50 years of age. Now, if we say that there is a traffic jam developing in the artery, gradually what is going to happen, if there is any traffic jam which is slowly developing in the artery, then the supply to the distal part might decrease a bit. So initially, the patient will experience intermittent claudication, which is actually a calf pain on walking. Grade 1, calf pain on walking, which is relieved by further walking, because as he's walking further, there is vasodilation happening, which will increase the blood flow and wash off the substance P. Gradually, the patient may experience calf pain on walking, but he'll continue to walk with pain. Gradually, calf pain on walking, but now the pain is so severe that he cannot walk any further. He has to take rest. And grade 4 of void is when the patient starts experiencing pain even at rest. So this is rest pain. Intermittent claudication is a calf pain which occurs on walking. It is not present at rest, usually in the lower limbs. Sometimes it can be felt in the upper limbs. For example, if you have to write at a very fast pace, then your fingers may start paining. That is called as writer's spasm. Rest pain is pain in the foot at rest. Apart from this, there can be coldness, numbness, paresthesias, which indicate moderate to severe arterial insufficiency. It may progress to pre-gangrene, which is a combination of rest pain, color changes, paresthesia with or without skin ulceration, and gangrene, where there is macroscopic death of tissues. Like this is a dry gangrene, which is due to arterial occlusion, and this is a wet gangrene, which is due to some infection, like we see in diabetes when there is arterial and venous occlusion as well. So the different stages of arterial obstruction. The story started with intermittent claudication, that is calf pain on walking, gradually rest pain in the foot, gradually coldness, numbness, paresthesia in the foot, then pre-gangrene, gangrene in the foot. So these are the different stages. Patient can come to you in August 2023 with any of these stages. How to approach? First, the examination of pulses. Distal to the traffic jam, the pulse will be low volume or feeble or maybe absent, and proximal to the obstruction, it would be high volume. So just by examination of the pulse, we can identify where is the low volume, where is the high volume, so we can define the site of obstruction accordingly. The femoral pulse is felt 2 centimeters below the mid-inguinal point. The popliteal pulse is the most difficult pulse to feel because popliteal artery is deep and there is no bony prominence. The anterior tibial is palpated at the ankle next to the tendon of extensor hallucis longus. Posterior tibial is palpated between the posterior border of medial malleolus and the Achilles tendon, and dorsalis pedis is palpated in the proximal half of the first metatarsal space. Sometimes, if the body has formed the collaterals around the obstruction, we may see a disappearing pulse, where on initial examination the distal pulse may be normal because the blood is coming through the collaterals. But now you ask the patient to walk in the hospital corridor, exercise. This exercise may not be able to give the desired results because this bypass channel or collateral is a small channel, so blood may not, the desired amount of blood may not be coming through this collateral, and then this pulse will disappear on exercise. Again, you ask the patient to take rest, and this distal pulse will reappear. So this disappearing pulse is because of collaterals. If we do the auscultation and keep the stethoscope proximal to the obstruction, we hear a blue, that is a whoosh type of sound. This simply indicates turbulence due to some stenosis or obstruction distally. We can measure ankle brachial pressure index as well, which is the ratio of systolic blood pressure at the ankle to the systolic blood pressure at the arm. And this is the equipment what we are using. This is a handheld Doppler. We keep the Doppler pencil on the dorsalis pedis artery, and this is the sphygmomanometer, the BP cuff, which is applied here, and we can measure the systolic pressure at the ankle like this, compare the systolic pressure at the arm. If the ratio is 1.1 plus minus 0.2, that is normal. Less than 0.9 is intermittent claudication, less than 0.5 is rest pain, 0.3 critical limb ischemia, and 0.1 gangrene. Fontaine's classification of this summary says grade 1 no symptoms, grade 2 intermittent claudication, which can be A and B mild moderate, grade 3 rest pain, and grade 4 gangrene. To confirm our clinical findings, investigation of choice is color Doppler. Angiography, because it is invasive, it carries the risk of thrombosis, so color Doppler is preferred. In the treatment of these arterial obstructions, we want that adequate blood should reach to the distal part. So the aim is to increase the distal supply. Initially, we advise lifestyle modification, stop smoking, reduce weight, brisk walk 40 minutes in the morning, 40 minutes in the evening. Dietary modifications. If the patient follows the advice, God can form the collaterals or bypass channels around the obstruction in 6 months. However, this treatment is very expensive, patients can't afford, so we have to give medical treatment. We can use vasodilators like cilostazol, oxypentyphylline, antiplatelets if have to be given for a long term, aspirin, short term, clopidogrel. We can use statins also. PTA, percutaneous transluminal angioplasty. We use Fogarty catheter in vascular surgery, wherein we have to just keep the Fogarty catheter balloon at the site of stenosis, like we are passing a guide wire. Now we put the Fogarty catheter, keep the balloon at the site of stenosis, inflate the balloon, and then keep it inflated for 1 minute and take it out. This is balloon angioplasty. As you can see, the lumen has become wide, so the flow will increase. To avoid restenosis, we can just leave a stent in this area. So that is a stent angioplasty. Usually we use drug-coated stents, that is sirolimus or everolimus coated stents here. Another option is bypass surgery. That is, by surgery we can create a bypass graft, and this bypass graft can be taken from inside the body, that is autologous, or can be bought from the market, that is synthetic. Autologous grafts, if we are doing a coronary artery bypass graft, then the best one is left internal mammary artery. We can use right internal mammary artery, gastroepiploic artery, long surface vein, radial artery, but not the intercostal arteries. However, when we are doing a femoropopliteal bypass, no need to open the chest to take the internal memory artery. We can just take the long saphenous vein from the thigh itself, from the lower limb, and then we can do a femoropopliteal bypass graft. In the synthetic grafts, the textile and non-textile, textile are better. They're made of Dacron. They can be woven or knitted. Woven grafts are better than knitted grafts. Non-textile are PTFE, that is polytetrafluoroethylene. Long-term patency with the internal memory artery. Most common cause of early graft failure is graft occlusion. Most common cause of early graft failure is faulty technique. And most common cause of late graft failure is graft occlusion. Most common cause of graft infection is by Staph aureus. This what you're seeing are the synthetic Dacron graft used for bypass surgeries. In the summary, that which procedure should be preferred depending on the site of obstruction. For example, if this is the pinky is the inguinal region, if there is a aortoiliac obstruction that is suprainguinal, then we use a Dacron graft. If it is a inguinal level obstruction, that is iliofemoral obstruction, we do angioplasty. And if it is an infrainguinal obstruction, that is a femoropopliteal obstruction, we use a long saphenous vein. Rarely, like in Burgess disease, when we do not have too many treatment options, if the patient comes to us with rest pain, to relieve the rest pain, that means to increase the blood flow in the foot, we can do lumbar sympathectomy, remove the lumbar sympathetic chain from the lumbar region. This will make the arterioles of the foot dilate. And if they dilate, they will steal blood from the calf, so more blood will come in the foot arterioles and the rest pain will be relieved. But if this patient was having intermittent claudication, which is calf pain, if you do a lumbar sympathectomy, that will divert the blood from the calf to the foot. So decrease the blood in the calf pain will further increase, intermittent claudication will further aggravate. So we should not do lumbar sympathectomy in intermittent claudication. If the patient presents with gangrene, then we have to do amputation, and amputation will definitely offer the best pain relief. Burgess disease, also called as thromboangiitis obliterans. It is thrombosis, thrombophlebitis of small to medium-sized vessels associated with Raynaud's syndrome. Less than 45 or less than 30 years of age, 95% are males, associated with smoking and tobacco use, usually in the lower limbs, but can be seen in the upper limbs as well. It involves the artery, vein, and can involve the nerves, but it does not involve the lymphatics. Okay, so this is the upper limb Burgess here, like this. Fine. Patient usually present with rest pain, and it is a disease involving small to medium-sized vessels. And the treatment mainstay is lifestyle modification. We are very blunt to these patients. You can either have your cigarettes or your legs, but the patient chooses cigarettes. We try giving medicines like vasodilators, oxypentyphylline, antiplatelets like aspirin, clopidogrel, and rarely we can go for lumbar sympathectomy to relieve the rest pain. Raynaud's disease is actually a spasm of the arterioles on cold exposure, commonly seen in young females in the upper limbs. Because it is a pathology of the arterioles, so the pulses remain normal. Primary Raynaud's when it is not associated with any other disease, and secondary Raynaud's when associated with some other diseases like systemic lupus erythematosus, rheumatoid arthritis, scleroderma, thoracic outlet syndrome, cervical rib. Raynaud phenomena is a characteristic sequence of color changes: white, blue, red, white, blue, red, white, blue, red. Now, in this young female, as soon as she is asked to dip her hand in cold water, because of spasm of the arterioles, it becomes white. Due to stagnation of blood, becomes blue. And now when the lady warms her hand, the blood again reappears and it becomes red. The primary mainstay of treatment of Raynaud's is lifestyle modification, avoid cold exposure, wear warm clothing. We can use medicines like calcium channel blockers and nitrates to relax these arterioles. And very rarely, we can advise cervical sympathectomy in intractable cases. Sudden arterial occlusion, embolism. It is sudden occlusion of a vessel by a substance which is foreign to the bloodstream. Most common source of embolism is the heart. We are talking about arterial embolism, not the venous embolism. Arterial emboli originate from the heart, mural thrombi from the heart, like in subacute ventricular endocarditis. If there are vegetation sitting over the heart valves, the heart suddenly fibrillates. These vegetations can be lifted off. They come into the aorta and then they can go anywhere in the body and create a complete traffic jam in that particular area. Venous embolism or venous thrombosis. We mainly talk about deep vein thrombosis, which occurs in the calf vein or the soleal vein. Also, this is a sudden obstruction, that is acute ischemia, acute limb ischemia. Patient does not have any time where bypass or collateral channels can form around the obstruction, so no collaterals are seen in acute limb ischemia. Patient, because of sudden cutoff of the blood supply, presents with pain which is severe and out of proportion to the clinical signs: pallor, pulselessness, paresthesia, paralysis, and poikilothermia. The treatment has to be done in emergency. Initially, we have to start the low molecular weight heparin, which does not allow the thrombus to expand or migrate. And then we have to do thrombolysis, like standard thrombolytic agent, tissue plasminogen activator, streptokinase, urokinase, alteplase can be used. If this does not help, then we have to do a thrombectomy or embolectomy. AV fistulas, this is an abnormal relationship between artery and vein. Most common causes of penetrating trauma. This can be iatrogenic, like in dialysis. Seminofistulas can be associated with infections, maybe parasitic, viral, bacterial infections. Now, whenever abnormal relation between artery and vein forms, more pressure in the artery, more blood will be going into the vein. So this vein will become abnormally dilated and tortuous, that is varicose, giving rise to risk of bleeding and ulcer formation. More venous return to the heart, more cardiac output. If we apply pressure over the artery proximal to the fistula, that will reduce the supply of blood into the vein. That means the cardiac output will decrease because the venous return decreases. This pressure over the artery proximal to the fistula, reversing the changes of AV fistula, is called as Branham sign or Nicoledoni's sign. The treatment would be take a Fogarty catheter here and put an embolus between this artery and vein, that is the fistula. So angioembolization or therapeutic embolization can be done. Most common substance what we are using in angioembolization is a coil. Other substances which can be used include human durameter blood clot and ethyl alcohol sponge. We can even do surgical quadruple ligation of these fistulas, but now angioembolization is the preferred method of treatment. Aneurysm is simply abnormal dilatation of the artery. जैसे जैसे उम्र बढ़ती है हमारे कमजोर होती हैं. As we grow older, tissues become weaker and weaker. So this can lead to abnormal dilatation in the artery, especially if in an elderly person the patient is having more blood pressure, hypertension, then the chances of aneurysms would be higher. True aneurysms will be having all the layers of the artery, like the intima, media, and the adventitia. But false aneurysms will not be having all the layers of the artery. Most common site of peripheral aneurysm is the popliteal artery, and most common site of pseudoaneurysm is the femoral artery. Usually the patients are asymptomatic. Sometimes there may be extensile pulsation, discomfort. No active treatment is required if the patient is asymptomatic or if abdominal aortic aneurysm is less than 5.5 centimeter in size. Investigation of choice for aneurysms is a CT scan. If the patient is symptomatic or if abdominal aortic aneurysm is more than 5.5 centimeter in size where the risk of rupture is high, then we do endovascular aneurysm repair, EVAR. Mortality in rupture aortic aneurysm is 50%. If popliteal artery aneurysm size is more than 2.5 centimeter, then also we do repair. In the venous disorders, superficial veins like the varicose veins, if you look at the venous anatomy in the lower limb, there's the dorsal venous arch. The medial end is the long saphenous vein, which ascends from the medial malleolus here, and it opens right up into the femoral vein just beneath the groin crease. On the lateral side is the short saphenous vein, which opens into the popliteal vein in the popliteal fossa at the sapheno-popliteal junction, and there are multiple connections between the superficial and deep veins, which are called as perforators. So there are superficial veins, long and short saphenous vein. There are deep veins like the tibial, popliteal, and the femoral vein, and there are connections of the perforating veins between the two. We know that God has given us a wonderful heart to pump the blood to different parts of the body, but God has not given us any heart in the peripheries which can pump the blood back towards the heart. So the muscles in the peripheries, they act as the peripheral heart, like in the lower limb, the calf muscle, the most bulky area, soleal pump, or the peripheral heart. Soleal muscle is the peripheral heart. So now what happens? Whatever blood is coming into these veins, when this blood is moving up because of contraction of the muscles, this blood cannot fall back because God has given valves in the veins. Normally, when the muscles are contracting, blood is moving up. So from the deep vein, this is going into the inferior vena cava, suppose, like this is the femoral vein, then the external iliac, common iliac, inferior vena cava. So this blood is moving up towards the inferior vena cava. The direction of valves in the connections with the superficial veins, like saphenofemoral junction, the direction of valve is such that it can allow the blood to move from superficial to deep, but will not allow the blood to move from deep to superficial. Whenever the muscles are contracting, because the deep veins are within the muscles, blood in the deep vein is moving up towards the heart. That means the deep veins are getting empty. At this time, the superficial veins will put their blood into the deep veins, and that is how the blood moves up towards the heart. But those people who keep on standing for long periods, like traffic policemen, rickshaw pullers, or if there is any back pressure coming in the deep veins, like pregnancy, when the fetus is sitting over the mother's inferior vena cava for 9 months, it may be putting pressure on the inferior vena cava. So blood from the femoral vein may not be able to drain nicely, and there will be a back pressure coming into the femoral vein. Or maybe any pelvic tumor, like a tubo-ovarian mass, genetic reasons, progesterone, deep vein thrombosis. If there is more back pressure in the femoral vein, this can put pressure on the valves here, and this can make this valve incompetent. If this valve becomes incompetent, that means saphenofemoral valve becomes incompetent. Now, when this patient is walking, when the muscles are contracting, if we carefully take a look at the two, this is a normal story, and this is a valvular incompetence story. In normal story, when the muscles are contracting, the pressure in the deep vein is increasing, blood from the deep vein is moving up towards the heart, blood from the superficial vein is moving into the deep vein. So, volume in the superficial vein is decreasing in a normal person and walking, so pressure in the superficial vein is decreasing. But if the valve is incompetent, when the muscles are contracting, high pressure in the deep vein, and if the valve is incompetent, the blood from the deep vein will come into the superficial vein, so more blood coming into the superficial vein, pressure in the superficial vein will increase on walking. This is ambulatory venous hypertension. If more blood comes into the superficial veins, they will become abnormally dilated and tortuous, and this can lead to pooling of blood in these veins. Initially, this is supposed to be normal. These are simple reticular veins or telangiectasias. These are frank varicose veins. Now, gradually, if the blood remains pooled in the superficial veins, if you look at the most dependent area, suppose long saphenous vein, the medial malleolus area, if the blood remains pooled beneath the skin, the red hemoglobin will disintegrate into brown and black. So this can lead to brownish blackish pigmentation in the lower leg, lipodermatosclerosis. If the blood remains pooled beneath the skin for long periods, it will put pressure on the overlying skin, and the skin can ulcerate. Venous ulcers, which are most often seen around the medial malleolus, which is also called as the Gator's area. Gator's area is the area between two malleoli. These venous ulcers can transform into squamous cell carcinoma, marginal ulcer. Marginal ulcer can lead to squamous cell carcinomas, which are slow growing, can involve the lymph nodes, and treatment would be surgical removal. This image, what we are seeing here, this is the brownish blackish pigmentation of the lower leg, lipodermatosclerosis, and sometimes we notice a champagne glass or a champagne bottle appearance as well. Now, these patients can present with aching discomfort in the calf or heel or bleeding, complications like venous ulcer, lipodermatosclerosis, and champagne glass or bottle appearance. We can take the help of a C classification in varicose veins, wherein C for clinical, E for etiology, A for anatomy, and P for pathology. If we talk about clinical classification, then C1 is reticular veins or telangiectasia, C2 varicose, C3 edema, C4 skin, C5 C6 ulcer, C5 heel, C6 active ulcer, and C4 is divided into ABC, A eczema, B lipodermatosclerosis, and C corona. C1 reticular, C2 varicose, C3 edema, C4 skin, C5 C6 ulcer, C5 heel, C6 active, C4 ABC, A eczema, B lipodermatosclerosis, and C corona. We can perform some clinical tests to identify which valve is incompetent, whether it is the saphenofemoral, saphenopopliteal, or the perforator valves are incompetent. That is the Tunicke test, Roddy-Trendelenburg test. We can also do a Figans test to test the perforator incompetence. Perthes test is done deep vein thrombosis, and Edson's test is done for cervical rib. Investigation of choice for these varicose veins is duplex imaging. In saphenofemoral incompetence, on duplex imaging, we find a Mickey Mouse sign. Like here, this is the common femoral vein. This is the great saphenous vein. The valve has become incompetent, so more blood is going into the long saphenous of the great saphenous vein, and this is giving us a Mickey Mouse sign. Mickey Mouse sign indicates saphenofemoral incompetence in varicose veins. In the treatment, the patient comes to us at early stages, just simple lifestyle modification, avoid prolonged standing. When the patient is lying supine or sleeping, we ask the patient to raise the lower limbs so that the blood does not remain pooled in the veins and it keeps on coming back towards the heart. We can advise elastic compression stockings also, which can generate external pressure on the superficial veins, which will not allow the blood to pool in the superficial veins. However, in the late stages, the treatment of choice, or the gold standard treatment of choice, is the endothermal ablation. Endothermal ablation, which can be achieved by laser or radiofrequency ablation. If you see before and after endothermal ablation, this was the story before, and this is after endothermal ablation. So we are just trying to destroy the long saphenous vein so that the blood does not remain pooled in this long saphenous vein. We can also use sclerotherapy, like we can put foam or phenol in almond oil. Other sclerosing agents use ethanolamine oleate, sodium tetradecyl sulfate, tetracycline, polydophenol escarole, pisibanil, OK432. We were doing surgery also for varicose veins, which was a Trendelenburg operation. In Trendelenburg operation, we were ligating the long saphenous vein as close as possible to the femoral vein. This is flush ligation of long saphenous vein, and then with the help of a stripper, we were stripping the long saphenous vein. When we were doing the stripping of this long saphenous vein, then we were not doing the stripping below the knee level, because below the knee level, the saphenous nerve lies very close to the long saphenous vein. Same way, we do not strip the short saphenous vein, because here, sural nerve is lying very close to the short saphenous vein. In long saphenous vein stripping, saphenous nerve can be injured if we are doing the stripping below the knee, while in short saphenous vein stripping, sural nerve can be injured. If there are perforator incompetence, then we are doing endoscopic surgery, that is called as SEPS, subfacial endoscopic perforator surgery, just 2 incisions, and with the help of this, we can ligate all the perforators in the leg. Regarding the deep veins thrombosis, most common site is the calf vein or the soleal vein. Most common cause is prolonged immobilization. That means patients who are admitted in ICU, paraplegia, multiple sclerosis, bedridden, or low limb fracture, long haul flights. We know about virtual stride, endothelial injury stasis, and hypercoagulability. This can lead to a thrombus formation. So those individuals who keep lying for long periods, there might be a thrombus formation in the deep vein, because of which the blood flow will not be going towards the heart. So pooling of blood stasis, open invitation for the bacteria, party, reubert, calidolor, and functionalacia. Earlier, two clinical signs like Homan sign, which was resistance to dorsiflexion of the foot. If this area was inflamed, any movement in this area, the patient will feel pain and patient will not allow that movement. So if we try to do dorsiflexion of the foot and patient resists this movement, this is what is Homan sign, which is seen in deep vein thrombosis. Calf pain or squeezing the calf muscles is called as Moses sign. But now these signs have become obsolete. We should not do these signs. Better to do a duplex imaging, or the gold standard investigation for DVT would be a ascending venous phlebography, but that is also not routinely done. Duplex imaging is sufficient. We do not want to disturb this thrombus, because if you try to make any movement in this area, it will carry a risk that thrombus can move up. And if it moves up towards the femoral vein, then external iliac, common iliac, inferior vena cava, right atrium, right ventricle, pulmonary artery, lungs. That means pulmonary embolism can occur. So we do not want to disturb this area. We just admit this patient in the hospital, immobilize the patient in the hospital, start low molecular weight heparin, and then start with oral warfarin, continue for a period of 3 months. In case of recurrent deep vein thrombosis, we can apply a filter in the inferior vena cava to prevent pulmonary embolism. Lymphedema is accumulation of interstitial fluid. In lower limbs, usually more than 4.5 liters of fluid can get collected. Most common lymphedema is a secondary lymphedema. This is due to filariasis in our country, especially Eastern UP and Bihar. Now, the most common cause of upper limb lymphedema is post-modified radical mastectomy for breast cancer. Primary lymphedemas, where it may be due to hypoplasia of lymphatic channels, depending on at what age the patient comes to us, less than 2 years, congenita or Milroy's disease, 2 to 35 years, precox or Meeks disease, after 35 years, TARDA. Secondary lymphedemas are more common and the concept is very simple. Whenever there is any traffic jam in the lymph nodes, the lymph will not drain and accumulation of lymph will cause lymphedema. Traffic jam in the lymph nodes can be because of some infections like parasite filariasis. Traffic jam in the lymph nodes can be because the cancer is going into the lymph nodes, or maybe surgery for cancers where the lymph nodes have been removed, or radiotherapy for cancers where the lymph nodes have been destroyed. So that can lead to these lymphedemas. Chronic filarial lymphedema is elephantiasis. This is what is elephantiasis. The treatment for these lymphedemas is quite tedious. We do not have any specific treatment. We just advise manual lymphatic drainage, manual massaging, pneumatic compression devices. The results of surgical treatment like nodovenous stents are very, very poor. If we talk about the endocrine surgery, the thyroid in the breast, sticking to the discussion of the surgical aspect of thyroid, that is goiter, which is simply enlargement of the thyroid gland. Most common cause is iodine deficiency. If iodine is deficient, T3T4 is not formed, so T3T4 will be less in the blood, TRH will be high, TSH will be high, and TSH will be acting on the follicles, promoting the release of T3T4 from the follicle and enlarging the follicle. If there is deficiency of iodine, T3T4 is not formed. T3T4 is less in the blood, TRH high, TSH high, TSH is stimulating the follicle to release T3T4, but there is no T3T4 in the follicle. So continuous stimulation of the follicle is enlarging, all the follicles of the thyroid gland enlarging, diffuse goiter. But if you give iodine at this stage, or maybe thyroxine at this stage, as soon as iodine comes, the T3T4 will start forming, T3T4 will come in the blood. That means thyroxine is coming in the blood. Or you are giving thyroxine, that means thyroxine in the blood. So if T3T4 level increase, the TRH will decrease, TSH will decrease, and the follicles will regress, and the diffuse goiter can disappear. So diffuse goiter is reversible. But if the patient is developing goiter and no iodine or thyroxine is supplemented, then the follicles will keep on enlarging, and a stage will come when these follicles will break, necrosis will occur, and the necrotic follicles will coalesce to form a nodule, which can be a single nodule or multiple nodules. That is a nodular goiter. Nodular stage of goiter, multinodal goiter is the most common, and nodular stage of goiter is irreversible because these are dead follicles, so they are not going to regress. Sometimes nodular goiter can complicate like secondary thyrotoxicosis. If the internodular tissue becomes more active, or if by chance there are some active follicles in the periphery of the nodule, they may become overactive and they start producing more T3 and T4, leading to secondary thyrotoxicosis, or in long-standing endemic goitus, follicular thyroid cancer can occur. If the patient is having any pressure symptoms, maybe dyspnea, dysphagia type, or maybe some complications, or patients wish for cosmetic reasons, we have to remove this goiter. If only one lobe is having the nodule, we remove that one lobe with this semithyroidectomy. If both the lobes are having the nodules, then we do a total thyroidectomy. Whenever we are doing a thyroid surgery, it is mandatory to see whether the patient is euthyroid or hyperthyroid. If the patient by chance is hyperthyroid, and you take this patient for thyroidectomy, during surgery you will be handling the thyroid gland, which will release more T3 and T4 in the blood. If already the T3T4 levels were high in the blood, now during thyroid surgery more T3T4 has come into the blood, so this will aggravate hyperthyroidism. Thyrotoxic crisis or thyroid storm will occur. That is the reason we don't want this. We want to make the patient euthyroid before surgery. We can take the help of antithyroid drugs like carbimazole, methimazole, propylthiouracil, which are given up to evening before surgery. We can use iodides, which reduce the vascularity as well. They are given up to morning before surgery. If rapid control of hyperthyroidism is required, then we give beta blockers. Beta blockers inhibit peripheral conversion of T4 to T3. They do not have any central action, so they are continuing for 7 days after surgery. When we are doing a thyroid surgery, some complications can occur like hemorrhage. Reactionary hemorrhage is due to slipping of ligature from superior thyroid artery. This blood may create a clot in the neck after a few hours of surgery and cause compression of the trachea, leading to respiratory distress. Patient can die. So in these cases, you have to immediately open the skin sutures, evacuate the clot, release the pressure on the trachea, and save the life of this patient. However, this may require exploration in the operation theatre to control that reactionary hemorrhage. Respiratory distress after thyroid surgery or during thyroid surgery can be due to 3 reasons. During surgery, if the surgeon has accidentally injured both the recurrent laryngeal nerve, then there may be paralysis of the vocal cord. As the anesthetist is trying to extubate the patient or remove the endotracheal tube after surgery, since the vocal cords are paralyzed, the patient's oxygen saturation will fall down. Again, the anesthetist will have to intubate the patient. So if the anesthetist is not able to take the endotracheal tube out because the patient's oxygen saturation is going down, that means the surgeon has injured both the recurrent laryngeal nerves. If respiratory distress occurs within few hours after surgery, this can be due to reactionary hemorrhage. If respiratory distress occurs after a few days of surgery, maybe second, third, fourth, fifth, sixth day after surgery, it can be due to hypocalcemia. Nerves which are most commonly injured during thyroid surgery, external branch of superior laryngeal nerve. Second most common nerve injured in thyroid surgery is the recurrent laryngeal nerve. Sometimes when we are doing a total thyroidectomy, then hypothyroidism will occur, which will require lifelong thyroxine replacement. Rarely, hypoparathyroidism can occur. That is due to ischemia to the parathyroids, because inferior thyroid artery is the major supplying vessel to the parathyroids. If we are doing a total thyroidectomy, we might cause damage to the vessel supplying blood to the parathyroids. Second reason for hypoparathyroidism can be accidental removal of parathyroids during surgery. If by chance accidentally they are removed during surgery, they should be replanted back into the patient into any muscular area. If the incision is open, put them into the sternomastoid muscle. If the incision has been closed, then you can put them in the muscles of the forearm or in the arm. Retrosternal goiter. This picture what we are seeing. This is a multinodular goiter here. This is the classification for different types of hemorrhage: primary, reactionary, and secondary. Primary hemorrhage, which occurs during operation; reactionary, within 4 to 24 hours after operation due to slipping of a ligature, dislodgement of clot, or rise in blood pressure, and this will require re-exploration. Secondary hemorrhage, bleeding, which occurs after 24 hours of operation. This is due to infection. The bacterial party causes necrosis of the tissues and causes erosion or sloughing of the wall of the vessel. Should be treated by antibiotics. Retrosternal goiter, as the name implies, is enlargement of the thyroid gland behind the sternum. Usually, the lower pole of the thyroid gland enlarges behind the sternum. This can lead to pressure symptoms like dyspnea, dysphagia. Pressure on the vena cava can lead to engorged dilated neck veins. There can be stridor. We can elicit a Pemberton's test or Pemberton's sign. Flushing of the face on raising both the hands above the head multiple times. This is what is Pemberton's test. And removal of retrosternal goiters is by a neck incision or a cervical incision. If you look into the breast, the basic anatomy: breast is a modified sweat gland lying between two layers of superficial fascia and breast rests on the pectoralis fascia. The extent of breast, anatomical and surgical extent: anatomically vertically from second rib above to sixth rib below, surgically vertically from clavicle above to the seventh rib below, anatomically horizontally from the lateral border of sternum to the anterior axillary line, surgically horizontally from the midline to the edge of latissimus dorsi muscle. Some part of the breast extends into the axilla as the axillary tail of Spence. In the center, there is a brown pigmented area, the areola, which are having the sebaceous glands, which enlarge during pregnancy and lactation and serve to lubricate the nipple. These are Montgomery tubercles. In the center of the areola, there is a nipple, which is having the smooth erectile muscles. That is why nipple is an erectile tissue. Breast can be divided into various quadrants, where the most important is the upper outer quadrant, as this is the common site of breast cancer. Least common site of breast cancer is the lower inner quadrant. Lymphatic drainage: 80% of the breast is drained by the axillary lymph nodes, remaining by the internal memory, especially the medial posterior part of breast by internal memory. Axillary lymph nodes can be divided into 3 levels on the basis of pectoralis minor muscle, lateral to muscle, level 1, at the muscle, level 2, above the muscle, level 3. 5 subgroups in the axilla: interior, posterior, central, lateral, and apical. There is no medial subgroup in the axilla. Inside the breast, there are 3 things: the lactiferous ducts, the lobules, and then the supportive tissue or the stroma. And in the supportive tissue, there are suspensory ligaments of Cooper's or Esley's. Congenital problems related to breast can be emacia, absence of breast, which can be associated with Poling syndrome, absence of breast with absence of sternal part of pectoralis major muscle, more common in males. Polymecia is multiple breast, athelia, absence of nipple, polythelia, multiple nipple. Polymecia or polythelia is more often seen along the milk line, which extend from axilla to the groin. So most common site of polymecia, polythelia would be the axilla. Second most common would be the groin. If we take a look at the mestalgia stories inside: cyclical and non-cyclical mestalgia. Cyclical related to menstrual cycle, related to hormonal influence. Non-cyclical not related to monthly cycle, not related to hormones. Cyclical mestalgia is more commonly seen in young females, especially in the 15, 20, 25 years age group, when the body or the breast is trying to adapt to changing level of hormones. We know whenever the hormone level increases, there is hyperplasia of cells of the duct lobule stroma. So this can create some congestion inside the breast, leading to pain. We try to reassure these young girls that there's nothing significant here. Your body is just trying to adapt to the changes. Many times, just nice reassurance helps. But if the girl is not able to bear the pain, we can give some decongestive agents like tablets of oil of evening prime dose. If this does not help, we can do hormonal manipulation by giving Danazol and bromocriptine. If this does not help, we might have to offer tamoxifen, that is selective estrogen receptor modulator, which is used as anti-estrogen in the hormonal therapy for premenopausal females breast cancer if the hormone receptors are positive. While the non-cyclical mestalgias, this is related to inflammation. If there is inflammation of the vein, like thrombophlebitis of superficial veins of the skin of the breast and the chest wall, this cord-like thing what you're seeing, this is Mondus disease. However, inflammation of the breast, that is mastitis, more commonly seen during pregnancy and lactation. During lactation, when the baby takes the feed, if the Montgomery tubercles in the areola are not able to secrete sufficient sebum, that means the nipple is not receiving the sebum or the oil, so nipple will remain dry. If this lady does not use any external lubricants to lubricate the nipple, the dryness in the nipple will persist, and this will lead to cracks in the nipple. If there are cracks in the nipple, now when the baby takes the feed, then staph aureus from the baby's mouth, they can travel through cracks in the nipple and go inside the mother's breast, which is engorged with milk. And then the party starts. And in this party, there will be acute inflammation, rheumatoid or functional lesion, redness, swelling, raised temperature, pain. If the patient comes to us at this stage of mastitis, we can treat this with giving antibiotics and breast support. If the patient does not come to us at this stage, then because of the staph party inside, there may be small pus pockets developing inside. And because of these small pus pockets developing inside, we have to remove these pus. So we give antibiotics, and under ultrasound guidance, we can do multiple needle aspirations from these pus pockets. However, if the patient does not report to us, even at this stage, there is a possibility that the party continues inside the breast and an abscess can form inside the breast, wherein clinically the sign of fluctuation will be positive and ultrasound will show good significant liquid collection inside the breast at one place. Now, in this case, we have to drain this abscess. We give antibiotics, and to drain this abscess, we do our incision and drainage. Like this is a picture of breast abscess. Now here, when we have to make the incision and drain this abscess, then we know that the arrangement of lactiferous ducts inside the breast is in a radial manner. So we prefer making a radial incision to drain the breast abscess, that is the breast incision. We don't make transverse incision. If the lady does not want a scar over the breast, then a cosmetic incision can be periareolar or circumareolar incision. The scar of this incision will be camouflaged between the brighter and the darker portions, and that is why we say periareolar circumareolar is more cosmetic. Patient sometimes can come to us with discharges from the nipple, most common being milk, which is physiological. Most common pathological discharge is serous. Most common cause of green discharge from nipple is ductectasia, and most common cause of blood discharge from nipple is duct carcinoma and duct papilloma. Ductectasia simply means dilatation of the lactiferous duct. It is also called as plasma cell mastitis or periductal mastitis. It is abnormal dilatation of the lactiferous ducts. Smokers and alcoholics who remain dehydrated, the secretions become thick. When these thick secretions are traveling in the duct, especially as we know that the ducts are converging at the nipples, which is a narrow area, so this is already a narrow area. If thick secretions are traveling in the duct, they can get arrested somewhere close to this nipple, maybe in the subareolar region. Now, because of stasis of these secretions here, there would be a proximal dilatation involving multiple lactiferous ducts. Secretions may get collected here. Sometimes they come out of the nipple, which is usually green in color. Sometimes can be brown, black, or rarely they can be bloody in nature. Because the lactiferous ducts are converging at the nipple, any pathology in the duct can manifest at the nipple. Like here, there can be circumferential retraction of the here there can be slit-like retraction of the nipple. Circumferential retraction is seen in breast cancer. If there is stasis of secretions in the subareolar region, it can lead to a chronic subareolar abscess or a mass, which is called as Zuska's disease. How to approach these patients if the patient presents with green discharge? No investigation required because green discharge is not seen in any other pathology, so the diagnosis is certain and we just go ahead with the treatment of ductal. If the patient presents with blood discharge from nipple, then blood discharges from any opening in the body should not be taken lightly because it can be a cancer as well. So first investigation to be done is a cytological evaluation to see the malignant cells in the discharge. And then if no malignant cells are there, we can do ultrasound less than 40 years, mammography after 40 years. If the diagnosis is not made, we can put a contrast into the duct and see the ectasia, that is ductography, or we can put an endoscope into the duct, do a ductoscopy and diagnose this ductal. If the patient presents to us with a lump, like chronic subcellular mass or a lump, then for any breast lump, the standard is triple assessment, CRP, C clinical, R radiological, and P pathological. And that is how we make the diagnosis of ductal. Once the diagnosis is made, we just want that the ectasia should be relieved. That means we want the secretions to move out of the nipple. So we encourage this lady to take plenty of fluids and advise breast massage so that secretions can come out of the nipple. This is the treatment of choice. If this does not help, then we can put a wire into the lactiferous duct under a microscope and remove the secretions from there. That is, open the duct, so it is a microdocotomy. If microdocotomy also fails, then we have to excise the lactiferous duct, and since in duct ectasia it involves multiple lactiferous ducts, excision of multiple lactiferous duct is Hatfield's operation. Removal of single lactiferous duct is microdocectomy. The disadvantage of Hatfield's operation, this patient will not be able to breastfeed. Duct papilloma is a papillary growth from the lactiferous duct. This is a pre-malignant condition. It presents with blood discharge from the nipple. If only single duct is involved without atypia, risk of cancer is less, but if multiple ducts are involved with atypia, risk of cancer would be high. Since single duct is involved usually in papilloma, पानी पिलाने से पेपिलोमा गायब नहीं होगा, तार डालने से पेपिलोमा गायब नहीं होगा, fluids will not relieve papilloma, microdocotomy will not relieve papilloma. It's a pre-malignant condition, so you have to excise it. That means remove the lactiferous duct. Since single duct is involved, we are doing a microdocectomy, but if in the MCQs they say multiple ducts having papilloma, you do a Hatfield's operation. Breast lumps. We know that every female every month has got fluctuating level of hormones. When these hormones rises, there is hyperplasia of cells. When these hormone falls, there is involution of the hyperplasia. This process keeps on going in every female every month. Sometimes there can be an aberration. For example, if suppose under the hormonal influence the hyperplasia occurred, but this hyperplasia failed to involute. If this was a controlled hyperplasia, it will lead to a benign lump or a benign tumor. But if the hormonal stimulus persists, then this hyperplasia may not be a normal hyperplasia. There may be more mitotic figures, that is atypical hyperplasia. If the hormonal stimulation persists, it can lead to carcinoma in situ. And if the hormonal stimulation persists, it can lead to invasive carcinomas. So the story of hormones in relation to benign tumors and the malignant tumors inside the breast. Now, most commonly, the benign breast tumor is fibroadenoma. Most common breast tumor less than 30 years is fibroadenoma. After 30 years, most common breast tumor is invasive ductal carcinoma. Most common benign breast disease is a fibrocystic disease. DuPont and Pease classify different changes inside the breast into three categories: non-proliferative, proliferative without atypia, and proliferative with atypia. Non-proliferative 70% of the time, simple hyperplasia, duct ectasia, fibroadenoma, no increased risk of cancer in these. Proliferative without atypia 26% like sclerosing adenosis and duct papilloma, slightly higher chances of cancer, while proliferative with atypia 4% of changes, very high risk of cancer with atypical ductal or atypical lobular hyperplasia. Fibroadenoma also called as breast mouse because it is freely mobile inside the breast. This is hyperplasia of intralobular stroma, usually seen in young females when the breast is adapting to the changing level of hormones, 15 to 25 years. Usually these fibroadenomas, they are small, patient is asymptomatic, and they resolve spontaneously by 30 years of age. If the fibroadenoma is more than 5 cm in size, we call it as giant fibroadenoma. These fibroadenomas most commonly present with a freely mobile lump inside the breast. And to approach any lump in the breast, the standard triple assessment CRP, clinical, that is history and examination, radiological, that is ultrasound less than 40, mammo after 40, pathological, biopsy is the best, we can do FNAC as well. If we are doing mammography in fibroadenomas, they show popcorn calcification. Mammography in breast cancer, irregular microcalcifications. Ideally, no treatment is required for these fibroadenomas because they can resolve spontaneously by 30 years of age, but there may be some specific indications for surgery. For example, if there is a breast lump, you do a biopsy or FNAC and you see there is a suspicious cytology, you're not sure whether it's benign or malignant, you don't want to take any chance and you should remove the fibroadenomas. Usually we make a periareolar or a circumareolar incision like this, go inside and take this fibroadenoma out like this. If it's a big size fibroadenoma, patients wish, or if it persists even after 30 years of age, then we can go ahead with excision of these fibroadenomas. Cystosarcoma phyllodes or phyllodes tumor, serocystic disease of Brody. This is a stromal hyperplasia seen in elderly females after 40 years of age. There is diffuse enlargement of the breast with variegated bossulated appearance. If the entire breast is enlarged something like this with a bubbly type of appearance or a bossulated appearance, it is a phyllodes tumor. If it becomes malignant, because it is arising from the stroma, it will be sarcoma, and sarcoma does not spread via lymphatics, so no need to remove the lymph nodes. We just do a wide local excision. Like if it is involving the entire breast, we do a simple mastectomy, and when we do a histopathological examination, we find a classical leaf-like appearance. Because of this leaf is phyla, we call it as phyllodes tumor. In the exams, they can ask you the treatment for any of the sarcomas, whether it's a liposarcoma, lymphangiosarcoma, osteosarcoma, malignant cyst, or desmoid tumor. Desmoid tumor is seen in females usually below the umbilicus arising from the muscles aponeurosis of the anterior abdominal wall. One thing which you have to take care, lymph nodes you will not remove. The treatment would be generally wide local excision. If we take a look at something related to salivary glands, we have got the two parotid glands here which are drained through the Stensen's duct which opens in the buccal mucosa opposite to the upper second molar. The two submandibular glands behind the angle of mandible drain through the Wharton's duct and the floor of the mouth. The sublingual gland, which drains into the floor of the mouth through numerous ducts, or these ducts can open into the submandibular duct as well. And there are huge number of minor salivary glands ranging from 400 to 1000, and they are distributed all over the aerodigestive tract, right from the lips, buccal mucosa, tongue, and so on. In the minor salivary glands, sometimes we can see the mucus extravasation cyst or mucus retention cyst. This is a mucus retention cyst. Most commonly, these cysts are seen in the lower lip. People who have a habit of biting their lips, it is the lower lip what they're biting usually, right? So mucus retention cyst can occur here. Related to sublingual gland, there may be sometimes ranula in the floor of the mouth. This is a bluish translucent swelling. This is a mucus extravasation cyst. It shows positive transformation because of clear fluid inside, and it resembles frog's belly. That is by the name ranula, rana tigris. These ranulas, they are transluminant. Most brilliantly transluminant swelling in the body is a cystic hydroma. Other transluminant swellings include hydrocele, meningocele, and rarely branchial cyst. Some ranulas can resolve spontaneously. If they persist, then we have to do surgical excision of the ranula along with removal of the sublingual gland. Whenever we are doing surgery for sublingual gland, removing the sublingual gland, the most common structure damage is the submandibular duct. Most common nerve damage is the lingual nerve. A plunging granule is a mucus retention cyst in the sublingual gland, where there is a swelling in the floor of the mouth, and then it projects through the mylohyoid muscle in the floor of the mouth and presents with another swelling in the neck. So there is a swelling in the floor of the mouth, there is a swelling in the neck as well, with just a tubular projection through the mylohyoid muscle. That is the dumbbell-shaped swelling. In the submandibular gland, commonly we come across these stones, the sialolithiasis. 80% of stones in the salivary glands, they occur in the submandibular gland for the simple reason that major contributor of saliva is by the submandibular, and the submandibular duct travels against the gravity in a tortuous manner. Smokers and alcoholics, women dehydrated who lose water, the secretions become thick, and these thick secretions can create traffic jam in the submandibular duct, leading to proximal dilatation, stasis, infection, and stone formation. These stones, they are composed of phosphates and oxalates. These stones, because they are creating some traffic jam, patient presents with pain and swelling at the angle of mandible, which is intermittent at meal times, called as mealtime syndrome. This can be a potential question in your exam. Mealtime syndrome related to sialolithiasis. Submandibular stones, they have got calcium, so they are visible on X-ray. But parotid stones do not have calcium, they are not visible on X-ray. Stones which are not visible on X-ray, that is radiolucent stones, are remembered by the mnemonic PG में जाएंगे लक्ष्य से नहाएंगे. P for parotid duct, G for gallbladder, Lux for urinary stones like lysine, uric acid, and xanthine stones. In the treatment for these stones in the salivary gland, we encourage the patients to take plenty of fluids. If the stone in the submandibular duct is less than 4 mm, we pass an endoscope, do a Dormier basketing, and remove the stone. If the stone is 4 or more than 4 mm in size, we first break the stone with either extracorporeal shockwave or maybe intracorporeal shockwave, and then pass an endoscope and do a Dormier basketing to remove these stones. If by chance these minimal invasive methods are not able to remove the stones, then we have to do open surgeries. If the stone is lying in the floor of the mouth, then we just make a cut directly over the submandibular duct, take the stone out and suture the duct. If the stone is lying close to the submandibular gland, maybe in the hilum, then we have to remove the submandibular gland, and nerves which can be injured during removal of the submandibular gland are marginal mandibular, lingual, and hypoglossal nerve. Right. In the tumors of the salivary gland, most common site of salivary gland tumors is the parotid. Most common benign tumor of salivary gland is pleomorphic adenoma. Second most common is the Warden's tumor or adenolymphoma. Malignancy in the parotid is mucoepidermoid carcinoma. Malignancy in the salivary glands, which has a propensity to invade into the nerve sheath, is the adenoid cystic carcinoma. Pleomorphic adenomas are the most common tumors in the salivary glands. Most commonly they are seen in the parotid gland, like here. If there is a pleomorphic adenoma, usually it involves the superficial lobe of the parotid, and these benign tumors, they are usually soft to firm in consistency, have a regular margin, they are not fixed to the underlying overlying structures, they do not involve the lymph nodes or the nerves. The treatment is superficial parotidectomy or a conservative parotidectomy, where we remain above the facial nerve. We can do an extracapsular parotidectomy, which is an alternative procedure which carries less risk of facial nerve injury. For superficial parotidectomy, we use a lazy S incision like this, and after doing the superficial parotidectomy, we actually remove the superficial lobe from the branches of the facial nerve, so there is always a risk of injury to the facial nerve, which can cause temporary or permanent weakness. There can be facial numbness, permanent numbness of the earlobe, and rarely a Fray syndrome, which is auriculotemporal syndrome or respiratory sweating, where there is inappropriate regeneration of parasympathetic nerve fibers from the auriculotemporal nerve into the skin of parotid region. Because of this, whenever there is parasympathetic stimulation, like on smell or taste of food, there will be sweating erythema in the parotid region. This is gustatory sweating or Fray syndrome. It can be prevented by putting a barrier between the facial nerve branches and the skin during surgery by using a sternomastoid muscle or maybe temporalis fascia or artificial membranes. However, if the patient has developed Fray syndrome, it can be confirmed by a starch iodide test. In the starch iodide test, we paint this area with povidone iodine, then give something to eat if there is sweating. And if we apply starch here, starch when comes in contact with iodine, if there is moisture, in presence of moisture, starch changes its color. That confirms sweating in this area. And if it is there, then we advise the patient to use antiperspirants or maybe botulinum toxin to destroy these nerve endings and treat this Fray syndrome. Thank you very much for your patience. May God bless you all. Wish you all the very best. May you come out with firing cylinders and with flying colors. God bless you. Take care. All the best. Right, so if we take a look at the pediatric surgery story, if we go down from top to bottom, in the face, the cleft lip and palate, neck swelling, thyroglossal cyst, branchial cyst and cystic hygroma. In the thorax, esophageal atresia and dysphagia lysoia. In the epigastrium, duodenal atresia, annular pancreas, hypertrophic pyloric stenosis. In the right hypochondrium, biliary atresia, choledochal cyst and intussusception. Lumbar region, absent kidney, ectopic kidney, polycystic kidney and horseshoe kidney. Right iliac fossa, Meckel's diverticulum. Left iliac fossa, Hirschsprung disease. Hypogastrium related to ureteric openings, duplication of renal pelvis and ureter, uretrocele. In the urethra, posterior urethral valves and hypospadias. In the scrotum, undescended testis and imperforate anus in the anal canal. So cleft lip and palate is the commonest congenital anomaly of orofacial structures. Most common is a combined cleft lip and palate, 45%. Cleft palate alone, 40%, cleft lip 15%, where left-sided cleft lips are more common. Risk factors may be genetic or environmental factors, like cleft lip is due to failure of fusion of median nasal process with the maxillary process. Cleft palate is due to failure of fusion of two palatine shelves. Environmental factors, if the mother had epilepsy during pregnancy, or if she is taking antiepileptic drugs like phenytoin diazepam and steroids. There can be partial cleft lip, something like this, or there can be complete cleft lip. It can be either unilateral or it can be bilateral. Cleft lip can be diagnosed on antenatal ultrasound after 18 weeks of pregnancy, and there would be problem related to airway, breathing, swelling, speech and dentition. So this will require surgical correction or plastic surgery. The timing of surgery for cleft lip is 3 to 5 months, soft palate 6 months, hard palate 12 to 15 months. Millard's and Wardell's operation they done for cleft lip. In the neck swellings, midline swelling, a thyroglossal cyst. During intrauterine life, a thyroglossal bud descends from the foramen cecum on the tongue exactly in the middle of the neck, so that in the lower part of the neck it unites with the two ultimobranchial bodies and forms the two lobes of thyroid. Generally, this thyroglossal tract completely obliterates before birth, but if it persists after birth, there may be accumulation of secretions anywhere in this thyroglossal tract, leading to a thyroglossal cyst. This is found in the midline, just beneath the hyoid, that is in the subhyoid location. And these thyroglossal cysts may contain cholesterol crystals, just like the branchial cyst and the hydrocele fluid. Most commonly present with the midline neck swelling, which moves with deglutition, as all thyroid swellings move with deglutition. But a characteristic feature of thyroglossal cyst is it also moves with protrusion of tongue. That is because of the attachment of thyroglossal tract to the foramen cecum on the tongue. Sometimes they can complicate. Stasis, infection, abscess can occur, which can rupture and form a thyroglossal sinus, or rarely a thyroglossal fistula. This thyroglossal sinus or fistula is never congenital, it is always acquired. Thyroglossal cysts can also complicate into papillary thyroid cancer, and the treatment for them should be complete excision not only of the cyst or fistula but also of the entire thyroglossal tract right up to the foramen cecum on the tongue. That is cyst trunk suppression. Branchial cyst and branchial fistulas, they are related to remnants of the second branchial cleft. Both branchial cyst and branchial fistula, they are located on the anterior border of sternomastoid muscle. Branchial cyst is located at the junction of the upper and the middle neck. Fistula is located in the lower neck. Cyst is lined by squamous epithelium, fistula by ciliated columnar epithelium. Internal opening of branchial fistula is located on the anterior aspect of posterior fascial pillar behind the tonsil. In type 3 branchial fistula, the internal opening is at the piriform sinus, and the treatment for both branchial cyst and branchial fistula is complete excision. Cystic hygroma, which is a lymphatic swelling in the posterior triangle of neck due to sequestration of jugular lymphatic sacs. These cystic hygromas, they contain clear lymph inside, and since it is a vascular swelling, so it is lined by endothelium. All swellings in the body which have got clear fluid inside, they show positive transillumination. Most brilliantly transluminant swelling in the body is cystic hygroma. Other swellings which show positive transillumination include ranula, hydrocele, meningocele, and rarely branchial cyst. Cystic hygromas, 50% of the times, we find them in the neonate, newborn babies, and sometimes they can become so large that they can even obstruct labor. The treatment should be complete excision. However, all vascular swellings, we can use sclerotherapy. Like here we use Picibanil OK432. Sclerotherapy can also be used in esophageal varices, hemorrhoids or piles, varicose veins, varicocele. In the thorax, esophageal atresia is simply absence of some part of the esophagus, and this is because of posterior deviation of the tracheoesophageal septum. Esophageal atresia can be classified into various types, like both upper and lower esophagus may be blind, not connected to the trachea, or upper esophagus connected to the trachea, or lower esophagus connected to the trachea, or both upper and lower esophagus connected to the trachea. Or sometimes there is no atresia of the esophagus, just a connection with the trachea. Abnormal connection with the trachea, that is called as tracheoesophageal fistula. Most common esophageal atresia is type C, where the upper esophagus is blind and the lower esophagus is connected to the trachea. This is a H type, where there is no atresia, just a connection of the esophagus with the trachea. Esophageal atresia can be associated with other congenital anomalies which are remembered by the mnemonic VECTERL. V for vertebral, A anorectal, C cardiac, T tracheoesophageal fistula, R renal, and L limb defects. During pregnancy, in this fetus, where there is esophageal atresia, the amniotic fluid will not go down. So the amniotic fluid will keep on coming out and will add to the volume of amniotic fluid, polyhydramnios. How these esophageal atresias present to us? Immediately after birth, you will find continuous pouring of saliva or frothing of saliva from the mouth. High risk of aspiration, pulmonary complications. Initial bedside test or initial evaluation, if you try to pass a nasogastric tube, it will not go beyond 10 centimeters. If you take an X-ray, then you can find coiling of the nasogastric tube in the upper esophagus. Coiling of the nasogastric tube in the upper esophagus. Whether there is any connection of the lower esophagus with the trachea or not. If you find gas in the stomach or the intestines, that means lower esophagus is connected to the trachea. If you don't find any gas here in the abdomen, that means there is no connection of the lower esophagus with the trachea. Best investigation would be CECT of the thorax, and the treatment should be a thoracotomy, division of fistula and esophagostomy, which is done on day 1 or day 2 of life. If by chance the two ends of two esophagus are far, then we wait for 4 to 6 weeks, allow the two ends to grow, reassess. If the two ends come close, do a esophagostomy. If they still remain far, mobilize the stomach and connect the esophagus with the esophagus, or we can do colonic or jejunal interposition. During the waiting period, baby will survive by enteral nutrition either by feeding gastrostomy or feeding jejunostomy. Dysphagia lusoria is compression of the esophagus by aberrant right subclavian artery. However, lusoria is specific for aberrant right subclavian artery. Dysphagia can be caused by other vascular compressions like double aortic arch or the right aortic arch. In the abdomen, duodenal atresia is absence of some part of the duodenum, and that is due to failure of fusion of the foregut with the midgut. This is the most common GI anomaly associated with Down syndrome. It is the commonest cause of intestinal obstruction in a newborn baby. However, the commonest cause of intestinal obstruction overall are the postoperative adhesions. Duodenal atresia will present with bilious vomiting within few hours of birth. When we take the X-ray, then we find a double bubble sign. Single bubble is seen in pyloric obstruction, double in duodenal obstruction, triple in jejunal obstruction, multiple central air fluid levels are seen in small intestinal obstruction, and multiple peripheral air bubbles or fluid levels, air fluid levels, they are seen in large intestinal obstruction. The treatment of choice for duodenal atresia would be simply connecting the duodenum with the duodenum, that is duodenal-duodenostomy. If you are not able to do that, then alternative treatment would be connecting the duodenum with the jejunum, that is a duodeno-jejunostomy. This is the alternative treatment. Annular pancreas is basically a ring of the pancreatic tissue which surrounds the duodenum. Can cause duodenal obstruction on X-ray double bubble sign. Treatment, duodenostomy, alternative duodeno-jejunostomy. Hypertrophic pyloric stenosis is basically hypertrophy of the pyloric musculature. This is stenosis and not atresia. It is idiopathic. It is due to hypertrophy of the circular muscle fibers. This story is usually seen in firstborn male child, and the incidence is 2 to 3 per 1,000 live births. Because of hypertrophy of the pyloric musculature, the baby presents with olive lump in the epigastrium in the 3rd week of life. However, maybe in the 2nd to 6th week of life. When we give a test feed to the baby, we find vigorous peristaltic movements moving from left to the right side. This baby, because of rapid jam at the pylorus, will present with non-bilious vomiting. Acid will be lost in vomiting, so there will be metabolic alkalosis. Chloride is lost, so there is hypochloremia. Because of metabolic alkalosis, the baby's kidney will try to throw the alkaline urine up, which happens initially. But if the baby is persistently vomiting for 2, 3, 4 days, baby is getting dehydrated. And then this dehydration becomes more important for this baby. So baby's kidney want to conserve sodium and water. For that, ADH aldosterone type of people get stimulated. Reabsorption of sodium and water from the kidney will make the potassium and H ions to be excreted in urine. Potassium getting lost in urine, that is kaliuresis, hypokalemia. H ion getting lost in urine, acidic urine, that is paradoxical aciduria. How to approach these babies? First of all, in emergency. Because the baby is dehydrated, first thing to be done is rehydration and electrolyte correction. Any patient presenting with abdominal mass or a lump, first investigation will always be ultrasound of the abdomen. And here, ultrasound of the abdomen is the investigation of choice or the most sensitive investigation for hypertrophic pyloric stenosis. If the thickness of pyloric muscle is more than 3 to 4 mm or length of pyloric canal more than 16 to 17 mm, it favors the diagnosis of hypertrophic pyloric stenosis. The treatment, initially, we can try doing a pneumatic balloon dilatation, but there are chances of restenosis, so better option or the treatment of choice would be surgery. By surgery, we cut the serosa and the muscle so that the muscle is relaxed. This is called as Ramstead seromyotomy. So this is the surgical treatment of choice for pyloric stenosis. In the right hypochondrium, we talk about biliary atresia. This is absence of biliary channels. Exact cause is not known, but is thought to be due to inflammatory fibrosis starting in the first week of life. We know that bile is formed by liver, and then bile is coming through the right left hepatic duct, common bile duct into the intestine, where the fats in the food, they get emulsified and digested. If bile is not coming in the intestine, fats will not be digested, so there will be steatorrhea. If bile is not going down, bile will be moving up into the liver, in the blood, jaundice. Congestion in the liver will cause hepatomegaly. We can classify this biliary atresia into 3 types. If there is only absence of common bile duct, type 1, absence of common bile duct and common hepatic duct, type 2, absence of common bile duct, common hepatic duct and the right left hepatic duct, this is type 3. Most common is type 3 and quite common in Pakistan as well. Babies, 10-day-old baby presenting with jaundice, steatorrhea, hepatomegaly, first investigation in any jaundice patient will be liver function test. We can do ultrasound and we might be seeing absence of biliary channels. To see the biliary channels, the 3 wonderful investigations are ERCP, MRCP and HEDA scan. ERCP is endoscopic retrograde cholangiopancreatography. MRCP is magnetic resonance cholangiopancreatography. And HEDA scan is hepatobiliary immunodiacetic acid. This is a radioisotope scan. In ERCP, we are passing the endoscope from the mouth, taking the endoscope in the duodenum, and then we are pushing the contrast into the CBD and the pancreatic duct and taking the X-ray. That is endoscopic retrograde cholangiopancreatography. MRCP is a MRI. MRI is difficult in small babies as the babies cannot lie still, they keep moving, so that gives a lot of motion artifacts. In biliary atresia, the age is around 7 days, 10 days, 15 days. So MRCP is ruled out. ERCP cannot be done because whether it is type 1, type 2 or type 3, common bile duct is absent. So we cannot push the contrast. So the only investigation left with us is a HEDA scan to see these biliary channels. That is why investigation of choice for biliary atresia is HEDA scan. Now what we want in the treatment is whatever bile is coming, that bile should go in the intestine. So we request the innocent guy, the jejunum, and we connect the common hepatic duct with the jejunum. That is a hepatico-jejunostomy. So treatment for type 1 biliary atresia is a roux and Y hepatico-jejunostomy. But for type 2 and type 3, suppose type 3, where there are no biliary channels, then we have to do a Kasai operation, where we just take the jejunum directly into the liver. This may not be able to drain the bile completely. So maybe in sometime 6 months, 1 year, 2 years, there will be biliary congestion inside the liver and the liver may fail. Eventually, we have to do a liver transplant in these type 2, type 3 biliary atresias. Choledochal cyst is a cystic dilatation of the biliary channels. Exact cause is not known, but it is believed to be due to anomalous pancreatico-biliary duct junction. Rodani classified the choledochal cyst into 5 types. 1, 2, 3 involve CBD, 4, 5 involve the hepatic duct. Most common is type 1, diffuse dilatation of CBD, where there is diffuse dilatation of CBD. Type 2 is eccentric dilatation of CBD above the pancreas. Type 3 is dilatation of CBD within the pancreas. Type 4 is divided into A and B. A is which involve dilatation of extrahepatic as well as intrahepatic ducts. 4B involve dilatation of only extrahepatic duct. 5 involve dilatation of only intrahepatic duct. 5 is also called as Caroli's disease, and we find a central dot sign in Caroli's which corresponds to the portal vein. How these choledochal cysts can present? If we imagine type 1, which is the diffuse dilatation of the CBD, there may be biliary stasis causing painless intermittent jaundice in infancy, or maybe mass in the right hypochondrium. If the baby presents with jaundice, first LFT. If mass, first ultrasound. To see the biliary channels, MRCP, ERCP, HEDA. MRCP not possible because this is a small baby which will give motion artifacts. So ERCP is the investigation of choice. Because this cyst can cause complications like cholangitis, choledocholitis and cholangiocarcinoma, we cannot leave the cyst, we have to excise the cyst. And once we excise the cyst, we connect the common hepatic duct with the jejunum. So cyst excision and hepatico-jejunostomy. That is the treatment of choice for choledochal cyst. In emergency, if suppose because of biliary stasis, there is a bacterial party in the bile duct, this will cause acute inflammation of the bile duct, cholangitis. Patient will present with sudden severe pain in the right hypochondrium, high-grade fever, chills and rigors, and jaundice. Pain, fever, jaundice, pain, fever, jaundice, pain, fever, jaundice is the famous Charcot's triad. If this party goes into the blood, it can lead to septicemia. Pain, fever, jaundice with septicemia, that means including hypertension and mental confusion. This is Raynaud's pentad. We have to save the life of this baby. Basic resuscitation, start IV fluids and IV antibiotics, do a quick LFT ultrasound if possible, and to remove the septic load from the CBD, we can do a endobiliary stenting, that is ERCP and stenting, which will move the septic load into the duodenum, jejunum, ileum, colon, out from the anal canal. Stones in the bile duct, choledocholithiasis. Cancer in the bile duct, cholangiocarcinoma. Most common site of cholangiocarcinoma is the confluence of right and left hepatic ducts. This is a hilar cholangiocarcinoma or Klatskin's tumor. Intussusception. This is simply invagination of one part of the intestine into the adjacent part, or telescoping of one portion of the intestine into the adjacent part. Most common, ileocolic, 6 months, can be 5 to 10 months. Most common cause is idiopathic. The entering tube is called as the inner tube or the intussusceptum. Middle tube, which is having the inner and the outer tube, and the outer tube, the intussuscipiens or the receiving tube. Point of entry of intussusception is neck. Terminal part of inner tube is the apex of intussusception. In case of adults, polyps in the colon are common. So colocolic polyps are common, or colocolic intussusception is common in adults. Whenever some part of the intestine becomes heavy, peristalsis forces that heavy part of intestine to ride into the adjacent part. That is why whenever there is hypertrophy of the Pierce patches at 6 months when top feed is given, then these Pierce patches which are situated in the wall of the terminal ileum, they engulf the bacteria and they hypertrophy, make the terminal ileum heavy, and peristalsis forces this terminal ileum to go into the cecum, ileocolic intussusceptions. Babies can present with excessive cry and discomfort. Because of peristalsis, the intussusception moves upwards, and many times we find sausage lump in the right hypochondrium with the concavity directed towards the umbilicus. We can find this lump in the left paraumbilical region also, but the concavity will be again towards the umbilicus. Because of bleeding here, baby may pass red currant jelly stools, that is blood and mucus in stool. When we clinically examine these babies, emptiness in the right ileal fossa, एक अजीब सा खालीपन महसूस होता है right ileal fossa. This is sign of dance. When we put our finger into the rectum of this baby, then the examiner's finger is stained with blood. These are important clues for intussusception. If the baby presents with a sausage lump, first investigation will be ultrasound, where we find a donut sign. On X-ray, we find a meniscus or crescent sign, and a very hot MCQ is this barium enema image, wherein on giving the enema, the contrast will be flowing into the cecum. If the ileum is tightly fitted inside, no contrast will be coming down. This appears like a claw sign. If there is some space between the inner tube and the outer tube, the contrast will be flowing around the inner tube and form rings. That is a coiled spring sign. Best investigation for intussusception is CECT, and the treatment is hydrostatic reduction. We just want to reduce the intussusception, so we can use air enemas, saline or barium enemas. Like in this picture, you are seeing a claw sign here. That is, the ileum is tightly fitted inside, so the contrast is not moving down. But when we give the contrast with pressure or air with pressure, that pressure forces the inner tube to move out, and that reduces the intussusception, which you can see here. Right. If by chance hydrostatic reduction fails, then we do operative reduction, wherein we never pull. It is always gentle push, milking of the outer tube to reduce the inner tube. If by chance this area is gangrenous, then we have to do resection and anastomosis of the remaining parts. In the lumbar region, absent kidney, one kidney may be absent due to renal agenesis. Ectopic kidney, when the kidney fails to ascend upwards, generally left-sided, found in the pelvis in the retroperitoneum. Polycystic kidney disease, multiple cysts in both the kidneys. This may be congenital, which is called as adult, because it manifests after 30 years of age. It is autosomal dominant. Infantile is autosomal recessive. This is rare and carries high mortality. So what we see is the congenital or adult polycystic kidney disease, which is bilateral, associated with cysts in other organs, most commonly liver, maybe in the spleen, pancreas, ovaries, associated with mitral valve collapse and very aneurysm of circle of Phillips. Most commonly hypertension, maybe gene related. Because of multiple cysts in both the kidneys will enlarge, swelling in both the lumbar region, stretching of the renal capsule will cause pain in both the lumbar region. There may be hematuria, and because the cyst will be pressing on the nephrons will be damaged, so they'll not be able to filter the urea creatinine. Patient will end up in uremia. In clinical approach, swelling in the abdomen, first investigation ultrasound. Ultrasound will show that there are multiple cysts in both the kidneys. Best would be CECT of the abdomen. Whenever we are using contrast, either in CT or in IVP IVU, there may be thinning of the pelvic calyceal system, which is called as the spider leg appearance. Spider leg appearance, thinning of the pelvic calyceal system. In the treatment, initially we can try doing a deroofing of the cyst, but eventually if both the kidneys are gone, then we have to do a kidney transplant. Generally, we prefer left kidney from the donor because of long left renal vein, and the transplanted kidney is placed in the right iliac fossa. Whenever transplanted organ is placed in a different anatomical location, that is a heterotopic transplant, like for kidney. For liver, we put the liver in the same anatomical location, that is orthotopic transplant. Various contrast studies what we can do for the upper urinary tract, like maybe for the kidney and the ureter, IVP, IVU, we can do a retrograde pyelography, or we can do a antegrade pyelography. For lower urinary tract, that is bladder and urethra. For bladder, we just push the contrast in the bladder and take the X-ray, cystogram, cystography. For urethra, we push the contrast from below, and the contrast is traveling in a retrograde manner like this. So this is a retrograde urethrogram. There are two pathologies for which we have to contract the bladder to see the pathology. That is micturating cystourethrogram or voiding cystogram. If there is vesicoureteric reflux or posterior urethral valves, we do MCU. Contrast studies in the GIT. For the esophagus, we do a barium swallow. Stomach, barium meal. Duodenum, jejunum, ileum, barium meal follow through. And colon, we do a barium enema. Horseshoe kidney, the incidence is 1 in 900. Sometimes, if during ascent of the kidney, if the lower poles, medial subdivisions of the lower poles fuse in the midline, it results in a horseshoe kidney. It is a pair of ectopic kidney, as inferior mesenteric artery does not allow the ascent of the kidney. Isthmus in horseshoe kidney is lying at L3, L4, where L4 is a better answer. Usually, the patients are asymptomatic, but sometimes there may be a traffic jam situation in the ureters, which can lead to proximal dilatation. This may cause swelling and pain, but not in the lumbar region, in the lower abdomen, because horseshoe kidney is ectopic, pair of ectopic kidney. It is not in the lumbar, it is in the lower abdomen. Because of stasis, UTI, stones can form. First investigation, if there is swelling pain in the lower abdomen, we do ultrasound. Ultrasound will tell us that, oh, both the kidneys are fused in the midline, especially the lower poles. We do a CECT, and that is the investigation of choice. So this is how horseshoe kidney looks like on a CECT. So when we are giving the contrast, either on CT or IVP, sometimes we can find this flower vase ureters, also called as the hand joining sign. In the treatment, for UTI we give antibiotics, for stones we remove the stones. Division of isthmus is not the treatment of choice in horseshoe kidney, because if you divide the isthmus, the parenchyma will bleed profusely and unnecessarily the bleeding might cause significant problems in the baby. There are various fistulas, sinuses, diverticulas. Normally, we know that there is no connection of the intestine and the bladder with our umbilicus. But during intrauterine life, there was a connection of the intestine with the umbilicus and connection of bladder with the umbilicus. This connection of intestine with the umbilicus is vitellointestinal duct or the omphallomesenteric duct. Connection of the bladder with the umbilicus is the allantois. They both involute completely before birth, so that after birth there is no connection. But by chance, if these connections persist, suppose the vitellointestinal duct persists, intestinal contents will come out from the newborn baby's umbilicus, greenish, yellowish, fecal smelling discharge. If allantois fails to involute, urine will come from the umbilicus or watery discharge from the umbilicus. If by chance only the umbilical end persist, the organ end closes, whether of the vitellointestinal duct or of the allantois. Only the umbilical end persist. In such cases, this is lined by mucosa, which will secrete mucus, so the baby will present with mucus discharge from the umbilicus. That is umbilical sinus. One-sided affair with the skin is a sinus. One-sided affair with the organ is a diverticula. For example, if the intestinal end of the vitellointestinal duct persists, this is a Meckel's diverticulum. If the vesical end of the allantois persists, this is a congenital urinary bladder diverticulum. These are congenital diverticulas. They are true diverticulas because they contain all the layers of the organ. They are present since birth. They should be differentiated from acquired diverticulas. Acquired diverticulas are commonly seen in elderly people. As we grow older, the tissues become weaker and weaker. जैसे जैसे उम्र बढ़ती है, इमारतें कमजोर होने लगती हैं. Whenever there will be a traffic jam situation, the proximal people will dilate, pressure in the proximal people will be high, and that will force the mucosa submucosa to protrude out. Sigmoid colon diverticulus, common in constipated elderly people. Fecal matter staying in the rectum. Dilatation of the sigmoid, pressure in the sigmoid high, forces the sigmoid mucosa submucosa to protrude out. Same story with Zenker's. This is the pharynx, this is the esophagus. There is a cricopharyngeal sphincter. If the tone of the sphincter is high, pressure in the pharynx will be high, will force the posterior pharyngeal wall to protrude outside. This is Zenker's diverticulum. Through the Killian's dehiscence or Killian's triangle, inferior constrictor muscle, thyropharyngeus and cricopharyngeus muscle. This is also acquired diverticulus seen in elderly people. These acquired diverticulus are false diverticulus because they do not contain all the layers. They only contain mucosa and superficial submucosa. Meckel's diverticulum is a congenital diverticulum. It is the persistence of intestinal and of vitellointestinal duct. This border of the intestine, which is towards the mesentery, this is the mesenteric border. The opposite border is the anti-mesenteric border. Meckel's is found on the anti-mesenteric border. It has its own blood supply. It's a congenital 2 diverticula containing all the layers present since birth. Follows rule of 2, 2% population, 2 centimeter wide, 2 inches long, located 2 feet proximal to the ileocecal junction. 2% of patients can be symptomatic. If symptomatic, presents at around 2 years of age. Mecals consist of heterotopic epithelium, most commonly the gastric epithelium. However, colonic pancreatic epithelium can also be found in Mecals. If Mecals is found in the hernial sac, then it is called as Lichter's hernia. Usually Mecals are asymptomatic, but if present with symptoms meet symptoms of acute appendicitis. Most common complication in Mecals is bleeding. However, diverticulitis, diverticular perforation, peptic ulcer, intussusception, and intestinal obstruction can occur. Intestinal obstruction in Mecals is not because of Mecals diverticula, but it is because of a band which can persist from the umbilicus to the apex of Mecals, around which the intestines can rotate and lead to intestinal obstruction. Best investigation to diagnose Mecals is the Mecals scan. In this Mecals scan, we use technetium pertechnetate, and this is taken up by the gastric epithelium. So we see the stomach along with the gastric epithelium in Mecals, and that is the best investigation to diagnose Mecals. However, we can do a barium meal follow-through, or we can do video capsule endoscopy. If Mecals is asymptomatic, no treatment has to be done. If Mecals is symptomatic or complicated, if it is narrow mouth, we do diverticulectomy. If it is wide mouth, then we cannot do a diverticulectomy, but we remove a segment of the intestine which is bearing the Mecals and do a end-to-end anastomosis. In Mecals surgery, we are commonly using these staplers. This what we are seeing is a linear stapler. Hirschsprung disease or congenital megacolon or congenital aganglionosis. This is absence of ganglion cells in the nerve plexus, most commonly in the rectosigmoid. Rectum is always involved. Now, depending on whether the aganglionic segment is short or long, the story can present differently. We know that the nerves, they are controlling the muscle movements of the rectosigmoid or the GIT. If there are absence of ganglion cells, the motor movements will be affected and the peristalsis will not occur. Suppose only a short segment is aganglionic, then the story will not present immediately after birth, because whatever fecal matter is coming here, the force of peristalsis may be sufficient to force the fecal matter to negotiate the small aganglionic segment. As the baby grows old, maybe in childhood, this baby may suffer from constipation. And when we are evaluating for constipation, if we do a barium enema, then on barium enema, when we are giving the contrast from below, there may be a short segment, like the narrow contracted segment is pathological, while the proximal dilated segment, this is normal. Barium enema can actually delineate the narrow contracted segment length. So to know the length of a ganglionic segment, barium enema is the best. The contracted segment is pathological, the proximal dilated segment is normal. We can even do anorectal manometries, because whenever there is a traffic jam, proximal to the traffic jam there is dilatation and high pressure, we can just put an instrument to measure pressure in the rectum, and anorectal manometry can give us an idea. But the best investigation would be if we are able to take a biopsy, suction rectal biopsy. That biopsy can demonstrate absence of ganglion cells in the nerve plexus. Once the diagnosis is made, we can do various operations to treat Hirschsprung, like Duhamel, Swenson, Sove, coloanal anastomosis. If suppose a long segment is aganglionic, then the story will present in the newborn baby, because the fecal matter of the meconium which is coming, this meconium will get collected till that area where the ganglion cells are present. The peristalsis force is not sufficient to negotiate this meconium to pass through such a big aganglionic segment. So there is meconium impaction leading to complete traffic jam, intestinal obstruction, because of which the proximal colon will be grossly dilated, and a newborn baby presenting with gross distension of abdomen, where the risk of colonic perforation is high, which will cause leakage of the fecal matter in the perineal cavity, fecal peritonitis, potty peritonitis, septicemia, and death. So these are emergency situations where there is complete traffic jam of the large intestine. In this emergency, we just bring the proximal colon out on the abdominal wall as a proximal colostomy, so that the colon does not perforate inside. No septicemia, no death should occur. If we go into the hypogastric area, the commonest congenital anomaly of the upper urinary tract is the duplication of renal pelvis and ureter. If suppose there are two renal pelvis on one side, sometimes there is a traffic jam at the upper pelvic ureteric junction, which causes proximal dilatation, damage to the nephrons in this area, and this is going to put pressure on the lower pelvis, because of which the lower pelvis droops down. This is called as drooping lily sign, how the lower pelvis is drooped down in duplication of renal pelvis. If there are two ureters, they follow a Mayer-Wegert law, wherein generally the two ureters they join so that there is only one ureter which is opening in the bladder normally, no problems. But sometimes the two ureters may not join, and if they do not join, then the lower ureter may open normally in the bladder, upper ureter passes distally and open more medially. In case of males, most commonly it opens at the apex of trigon. However, it can open in the seminal vesicle, posterior urethra, ejaculatory duct. In females, this ectopic ureter most commonly opens distal to the distal sphincter. So there will be continuous dribbling of urine. A female who has normal bladder filling sensation, bladder contraction is also normal, sphincter is also normal, so she is able to pass urine normally. But at the same time, she presents with continuous dribbling of urine. This means ectopic ureter. Best investigation would be IVP-IVU, and treatment for ectopic ureter would be you just put that ectopic ureter back into the bladder, that is ureteric reimplantation. Ureterocele. This is a partial atresia of the ureteric orifice. This is ureterocele. Now, in these situations, there will be dilatation of the intramural ureter, that is that part of ureter which lies within the wall of the bladder, that is in the detrusor muscle. There may be stasis of urine leading to UTIs. It is more common in females and generally presents in childhood. When we are doing IVP-IVU, the contrast is coming here like this. It looks like a dilatation here, and when the proximal muscles contract forcefully, we can see the contrast coming out of the ureteric orifice, just like the snake takes its tongue out. That is why we call it as adder head or cobra head appearance. That is why we call it as adder head or cobra head appearance. And this is a hot image-based question, wherein you can find these two type of things here, or maybe a single thing. This is a bilateral ureterocele. So try to see as many images as possible for this adder head or cobra head appearance. The treatment for these ureteroceles would be excision of this ureterocele and reimplantation of the ureter. Earlier we were doing endoscopic incision of the ureteric orifice, but that caused vesico-ureteric reflux, for which we were doing MCU. That is why, because of reflux stories, we prefer excision of the ureterocele and reimplantation of the ureter. Posterior urethral valves, seen only in boys, distal to the verumontanum in the prostatic urethra. Most common cause of obstructive urethral lesion in a male child, depending on whether the valves are complete or incomplete. If they are incomplete, there would be some space from where the urine can pass. So the story does not present immediately after birth, as the baby is able to pass urine. In childhood, because of partial traffic jam, there may be stasis, recurrent UTI. We do micturating cystourethrogram to diagnose these posterior urethral valves. So here you can see the distended bladder, the distended prostatic urethra, and a traffic jam at this particular area. In the treatment, we do transurethral resection of these valves. If the valves are complete, This will cause complete traffic jam situation, and the story will present in the newborn baby with retention of urine. This is an emergency situation wherein you have to relieve the retention either by a urethral catheterization or a suprapubic cystostomy. Hypospadias. This is when the external urethral opening is not present at the normal location but is present anywhere on the undersurface of penis. We can classify them into granular, coronal, subcoronal, distal penile, mid-penile, proximal penile, penoscrotal, scrotal, and perineal. Opening which is more close to the normal will be more common and less severe. So out of these, granular will be most common, perineal will be least common. Granular will be least severe, perineal will be most severe. No treatment for granular. Sometimes in perineal hypospadias, because the urethral opening is in the perineum, so sex is difficult to differentiate in perineal hypospadias. Use of diethyl stilbestrol during pregnancy has been found to be with increased risk of hypospadias in the baby. In these hypospadias, because there is absence of urethra distal to the ectopic opening, this is forming a fibrous cord which causes weight and curvature of the penis. A downward curvature of the penis, that is a downward chordae or ventral chordae. The meatus is narrow, meatal stenosis is there. And because of this, baby will face problems in urination. At the time of puberty, erection will be a problem. He'll not be able to deposit the sperms in the vagina. These are serious issues and require surgical correction. What we need to do is we need to remove this chordae, make the penis straight, and want the urethral opening at the normal location. So a urethroplasty, chordae correction and urethroplasty, ideally done at 10 months of age, but we can do it from 6 months to 18 months of age. Most commonly, we are using TRIPUS for urethroplasty. So circumcision is contraindicated in hypospadia babies. And whenever we are doing a urethroplasty, we are connecting the patient's own urethra with the new urethra which we have made. Urine is continuously coming in this area. We'll make the sutures wet. Sutures can break. Urine get connected here. And this urine may create a hole in the skin. And urine may start coming out from the hole in the skin here. So abnormal connection can develop between the skin and the urethra, which is called as ureterocutaneous fistula, which is a common complication of hypospadia surgery. Undescended testes. If the testes are not descended into the scrotum, normally the testes are found in the bottom of the scrotum. If this is the normal path of descent of testes from the deep inguinal ring, inguinal canal, superficial inguinal ring, top of the scrotum and bottom of the scrotum. If the testes are arrested anywhere in the normal path of descent, undescended. If they deviate from the normal path and go somewhere else, ectopic. If the testes were already descended in the scrotum, but due to trimestral contraction, the testes sometimes may ascend up in the inguinal canal, but you can easily bring these testes down into the bottom of the scrotum by simple manual manipulation. This is called as retractile testes. अगर टेस्टिस अपने नॉर्मल रास्ते में कहीं पे अटक जाती है अनडिसेंडेड, अटक जाती है एक्टोपिक, उचक जाती है रिट्रैक्टाइल. मोस्ट कॉमन साइट ऑफ अनडिसेंडेड टेस्टिस is inguinal canal. Most common site of ectopic testis, superficial inguinal pouch or the Dennis Brown pouch. However, ectopic testis can be found at the root of the penis, femoral triangle, or maybe somewhere in the perineum. Incidence of undescended testis, 4% in full-term babies. That means 4 out of 100 male babies born will have undescended testis. 30% in preterm. 50% are right-sided, 30% left-sided, and 20% bilateral. 75% of undescended testis can descend down to the bottom of the scrotum within 3 months of life. Sometimes undescended testis can complicate A testis, A atrophy, T trauma, E epididymoarthritis, S sterility. If both the testes are undescended, they'll be intra-abdominal where the temperature is higher, so that will interfere with spermatogenesis. So sterility is seen in bilateral undescended testis. T torsion, I inguinal hernia, which is the commonest complication of undescended testis, and S seminoma. Most common cause of testicular cancer is undescended testis. Clinically, we can examine. Palpation can give us an idea about the presence of testis in the inguinal canal. If in doubt, we can do ultrasound of the abdomen and scrotum. If testis are neither seen on ultrasound nor on physical examination, then we can do a diagnostic laparoscopy to locate the testis. And the treatment would be bring the testis down to the bottom of the scrotum and fix the testis in the bottom of the scrotum. Fixing something in surgery is pexy. So this is orchidopexy, which is preferably done at 6 months, within 1 year, maybe between 6 months to 1 year. Imperforate anus. If somebody has done bad deeds in his previous life, God may not give him the anal opening in the next life. Now this can either be a low anomaly or high anomaly. Maybe rectum anal canal is formed. Everything is normal inside, but only the opening is not there. So you can simply make an opening at the potential site. Or commonly what we find in boys, the rectum is opening in the bulbar urethra, that is rectobulbar urethral fistula. In females, the rectum may be opening in the common vestibule, where there is opening of the urethra, vagina, and then posterior to the vagina, the rectal opening in the vestibule. Or sometimes the rectum is opening in the perineum in females. We can take an X-ray in a lateral prone position. We can keep a coin or a marker at the potential site of anal opening. By 24 hours, we expect that gas should have traveled to the lowermost part. So when we turn the baby in prone position, the gas will rise up. The distance of gas from the marker will give us an idea that what is the length of aprasia. If the gas would have been going right here, that means only a short distance is there. Low anomaly, anoplasty can be done. But if the gas is only up to this area, that means maybe rectum anal canal has not formed completely. High anomaly, and that will require a plastic surgery, posterior sagittal anorectoplasty. So this is all about the pediatric surgery revision. Thank you very much for your patience. May God bless you all. Wish you all the best, and may God give you all the strength and courage to come out with flying colors. May all the seniors, elders, teachers, God keep blessing you, and may you always have high hopes. Stay positive, stay pumped up. Thank you. God bless. Herein, we started with the story of dysphagia, and in dysphagia, we started with the story of Zenkus diverticulum. Zenkus diverticulum, also called as pharyngeal pouch or cricopharyngeal ecclesia. This is outpouching of the posterior pharyngeal wall posteriorly above the cricopharyngeal sphincter through the Killian's dehiscence, that is in the inferior constrictor muscle between the fibers of thyropharyngeus and the cricopharyngeus muscle. Zenkus diverticulum is acquired diverticulum. It is a false diverticulum as it does not contain all the layers. It contains only the mucosa and superficial submucosa. It is commonly seen in elderly people, 50% of the times associated with cervical webs, most commonly present with dysphagia, regurgitation, halitosis or false smelling breath, risk of complication like aspiration, pulmonary abscesses. Voice sign is a gurgling sound which is heard on reducing the swelling. Bright sign is something which is seen in laryngocele. Investigation of choice for Zenker's is a barium swallow. Treatment for Zenker's, less than 2 centimeters, cricopharyngeal myotomy, 2 to 4 centimeter diverticulopexy, and more than 4 centimeters Dolman's operation or diverticular esophagostomy, where we are taking the help of linear stapler. In this, linear stapler is fired, and we just divide the septum between the diverticula and the esophagus. Right? We just divide the septum so that we communicate this diverticula to the esophagus so that food does not stay here. And we are using linear stapler for this purpose. This is a barium swallow image, wherein this is the outpouching what you're seeing here, which is Zenker's diverticula. And this is compressing the esophagus. That is why you are seeing a narrow lumen of the esophagus in this area. Ecclesia cardia, this is basically failure of relaxation of lower esophageal sphincter. This is due to absence of ganglion cells in the Orbeck or Meienreich plexus in the esophagus. We should know that tone of the lower esophageal sphincter is regulated by acetylcholine. And in ecclesia cardia, we find unopposed action of acetylcholine at the ileus, because of which there is contracted lower esophageal sphincter. Because there are no ganglion cells in the Meienreich plexus of the Orbeck plexus, the peristaltic movement in the esophagus are absent. We can classify this ecclesia into 2 types: primary, secondary. Primary when the exact cause is not known, and secondary when it is secondary to some diseases like Chagas disease, diabetes, scleroderma. Pseudoecclesia is a different term. Pseudoecclesia is something which is not due to any pathology in the esophagus, but if there are tumors around the esophagus, maybe in the mediastinum or the cardia of the stomach, when they start putting pressure on the esophagus, that can cause traffic jam in the esophagus. Ecclesia cardia generally presents somewhere at around 25 to 40 years of age, most commonly presenting with a traffic jam situation, that is dysphagia. Initially, this dysphagia is for liquids and gradually for both liquids and solids. And the simple reason for that is that in ecclesia cardia, it is the problem of the muscle. So the muscle is in a state of spasm. When the patient takes the solid food like the idli, the solid food when it's coming here in the lower esophagus, because of the weight, it relaxes the lower esophageal sphincter and the solid food can go down. But if the patient is taking only sambar or liquid or water, then liquid does not have that much of weight to relax the lower esophageal muscles. So the liquid gets stuck. That is why we say that in ecclesia, initially there is dysphagia for liquids and gradually for both liquids as well as solids. Obviously, in any traffic jam situation in the esophagus, the proximal people will dilate, pressure in the proximal people will increase, and there will be risk of regurgitation, aspiration, pulmonary complications like pneumonia. Because of stasis of food in the middle esophagus for a long period of time, there is always the risk of esophagitis in the middle 1/3 of esophagus, which can even lead to squamous cell carcinoma in the middle 1/3 of esophagus. Any patient who is coming to you with dysphagia, August 2023, my dear friends, you will be doing a barium swallow. And if we do a barium swallow, in ecclesia cardia, we see the classical appearances where we call them as the classical bird beak or the pencil tip, the rat tail appearance, and there would be absence of gastric air bubble. Like this is a hot image based MCQ beta. This has very high chance of being asked in June 23 exam. Mind my words, June 23. Don't miss out on this image, right? This is the bird beak or the pencil tip. This is the rat tail, and here there is absence of gastric air bubble. We should not confuse this with the barium swallow images in cancers, where we may find a filling defect because the contrast will not go inside the cancer. So cancer appears as a filling defect here, and we may find a rat tail appearance in cancer esophagus. Rat tail appearance is more commonly associated with cancer esophagus than ecclesia cardia. Fine. However, the standard investigation for ecclesia would be esophageal manometry, where with the measurement of pressures inside the esophagus, we can segregate the different motility disorders in the esophagus. Like normal intraesophageal pressure is 10 to 25 mm of mercury. Ecclesia, it can increase from 25 and go up to 100 mm of mercury. Nutcracker 180 to 200, and diffuse esophageal spasm more than 300 to 400 mm of mercury. Another hot image based MCQ for June 2023 exam. If we are doing a barium swallow and we find a corkscrew esophagus, where you can find multiple narrowings and dilatations, So this looks like a corkscrew, as if we are opening a wine bottle with the help of that screw, right? So that type of appearance, that screw type of appearance is what is the corkscrew appearance. This suggests diffuse esophageal spasm. In the management of ecclesia cardia, we want to relieve the traffic jam at the lower esophageal sphincter. We want to relax the lower esophageal sphincter. Initially, we try giving medicines like calcium channel blockers and nitrates. We can also do a pneumatic balloon dilatation, but pneumatic balloon dilatation will carry the risk of rupture of lower esophagus. The treatment of choice would be a surgical treatment, where we would like to incise the muscle fibers at the lower esophageal sphincter. So we make a longitudinal incision cutting the muscles of lower esophageal sphincter. This is called as myotomy. When we are doing it by open surgery or laparoscopic, that is called as Heller's myotomy. However, nowadays, as we are becoming less and less invasive as possible, we can do this myotomy endoscopically also, where we pass the endoscope into the lumen of the esophagus, make a cut in the mucosa, take the endoscope in the submucosa, create a tunnel in the submucosa, and then cut the muscle fibers in the lower esophagus. This is called as POEM, per oral endoscopic myotomy. Right. Whenever we are cutting the lower esophageal sphincter, there could be a risk that lower esophageal sphincter is getting damaged, which can lead to reflux. And to avoid this reflux, we can do a fundoplication. Another story leading to dysphagia is the Schatzki's ring. Schatzki's ring is a circumferential, mucosal or submucosal thickening, which is commonly seen at the gastroesophageal junction. This is commonly seen in GERD patients, reflux patients, can be idiopathic as well. Sometimes it can cause dysphagia, but that can be relieved automatically also with the passage of solid food. The solid food can dilate this ring, so the patient may not have dysphagia after this. This is what we call as intermittent dysphagia. If the patient is coming to us with this dysphagia type of symptoms, then we can just pass an endoscope and do an endoscopic dilatation of the ring. So single endoscopic dilatation is curative for this Schatzki's ring. Another pathology is lye stricture. Lye stricture is stricture in the esophagus due to ingestion of castics. What you're seeing here, you can see how the lumen of the esophagus has narrowed down drastically. So this is because if somebody has swallowed the alkali, maybe the toilet cleaner like Harpic or maybe the phenyl, then this is going to cause intense inflammation of the esophagus, inflammation, healing, fibrosis, stricture formation. So this is what is the lye stricture in the esophagus due to ingestion of castics or alkali. Then we talk something about surgical chest pain or GERD. GERD is gastroesophageal reflux disease. Why we do not suffer from GERD? Because there are 3 important things with integrity of our lower esophageal sphincter, good gastric emptying, and good esophageal peristalsis. Despite this, all of us normal people can have transient lower esophageal sphincter relaxations for 3 to 4% of times in 24 hours, and these refluxes definitely will be more common in head-low position like supine position. However, sometimes if the lower esophageal sphincter becomes weak, wherein the most important culprit is smoking, because the toxins in the smoke, the nitrates in the smoke, they relax the lower esophageal sphincter and make it weak. So the chances of reflux of gastric contention in the esophagus would be high. Alcohol, chai, coffee, hot liquid, spicy food, obesity, progesterone, drugs like calcium channel blockers, nitrates all can damage the lower esophageal sphincter. And if this happens and patients suffer from GERD, then continuously the acid will be refluxing up into the esophagus, leading to heartburn or retrosternal discomfort or retrosternal pain associated with regurgitation and epigastric pain. How to approach a patient of epigastric pain or retrosternal pain? First, if we are thinking about any cardiac story, then we have to rule that out first. But if a patient is coming to us nicely in the OPD, then by the history, we can be able to make out that, okay, this might be related to some acid story, and acid story is related to the stress or to whatever he's following the lifestyle. So we try to modify the lifestyle first, wherein we advise the patient strictly not to smoke, not to drink alcohol, stop tea, coffee, stop hot liquids, stop spicy food, reduce weight, do not sleep for 3 to 4 hours after meals, and elevate the head end of the bed by 5 to 8 inches. If the patient follows the advice, the patient may become symptom-free, but since patients can't afford, this is expensive, so we have to give them a wonderful drug, proton pump inhibitors, which is the treatment of choice for GERD. Now, 90 to 95% of patients are successfully treated by GERD, so no investigation, nothing is required in the management of GERD. Really, if the patient keeps on coming to us with symptoms, then we would like to know where is the problem, whether it's the esophagus, stomach, or the duodenum, so we can do an upper GI endoscopy, which is the investigation of choice for GERD, for peptic ulcer also. On endoscopy, if we see some problem in the lower esophagus and suspect GERD, then to label or diagnose GERD by confirmation, then we do a 24-hour ambulatory pH monitoring. If the drop in pH is below 4 for more than 4% of times in 24 hours inside the esophagus, this is Johnson-de-Meester scoring or Johnson-de-Meester criteria, and this labels it as GERD. That is why investigation of choice for GERD is upper GI endoscopy, but gold standard investigation for GERD is 24-hour ambulatory pH monitoring. When you are doing the endoscopy, if suppose esophagus is normal, you find a problem in the stomach like ulcer in the stomach, you take a biopsy from the stomach ulcer to rule out cancer and pre-pyloric region to rule out H. pylori. If on endoscopy you find that esophagus, stomach are normal, but there is a duodenal ulcer, then duodenal ulcers hardly ever become malignant, so you just take a biopsy from the pre-pyloric region to rule out Helicobacter pylori. In GERD patients, if the medicines are not working, then surgery has to be done, and surgery for GERD would be a fundoplication. Floppy nascens fundoplication, which is a loose 30-degree wrap of fundus of the stomach around the lower esophagus. There can be various complications of GERD, like esophagitis, stricture esophagus, shortening esophagus, Barrett's esophagus, and sliding hiatus hernia. All this story is happening in the lower esophagus in GERD. Barrett's esophagus is actually intestinal columnar metaplasia of squamous mucosa of lower esophagus. Hallmark is presence of goblet cells in the esophagus. Squamo-columnar junction move upward. Very high risk of adenocarcinoma, and the treatment endoscopic resection of the dysplastic mucosa with radiofrequency ablation and aggressive PPIs. Hiatus hernias, generally it is the sliding hiatus hernia which is associated with GERD, but here itself we differentiate the sliding hiatus hernia from paraesophageal ruling or giant hiatus hernia. Sliding hiatus hernia is due to reflux when the gastroesophageal junction move up into the thorax, but paraesophageal hiatus hernia is due to weakness in the diaphragm where the G junction remains within the abdomen, but the fundus of the stomach move up into the thorax. Sliding hiatus hernia is much more common than paraesophageal. The chances of complications are more higher in paraesophageal or rolling or giant hiatus hernia. Both, whether it's sliding or rolling type, the stomach is in the thorax, patient can present with chest pain and dyspnea. First investigation, chest X-ray, but the best investigation will be CT with contrast, which can demonstrate where is the G junction, and the treatment will be just bring the stomach from the thorax into the abdomen and then wrap the fundus of the stomach around the lower esophagus, fundoplication. Another story related to surgical chest pain is Boerhaave syndrome or barrow trauma or spontaneous esophageal rupture. It is spontaneous. It is transmural, that means all layers are involved. It is commonly seen above the lower esophageal sphincter, or you can say just above the gastroesophageal junction. It is commonly seen in elderly people, and sometimes after heavy meals or binge drinking. Another keyword what you can make out here is binge drinking. If there is high intragastric pressure, there will be forceful vomiting, and the gastric contents will be released into the esophagus under high pressure. Old esophagus will not be able to tolerate such high pressure, and it will burst at its weakest point, that is on the left side posterior lateral wall, and all the gastric contents will be released into the mediastinum under pressure, causing mediastinitis and risk of septicemia. These patients come to us with sudden onset of severe left-sided chest pain radiating to the left arm and to the left shoulder, and there would be a subcutaneous surgical emphysema, which is a pathognomic feature here. The Meckel's triad is a combination of vomiting, chest pain, and subcutaneous emphysema seen in this Boerhaave syndrome. Because patient is coming to you with chest pain in a clinical approach in the emergency, first you have to rule out the cardiac event, so you do the ECG and the cardiac enzyme assessment. Once the cardiac event is ruled out, patient is being stabilized. You can do the auscultation, and if you hear sounds as if somebody is walking on the snow, footsteps on the snow, then it is due to subcutaneous emphysema, which may be in Boerhaave syndrome. So this footsteps on the snow on auscultation is called as Hammond's crunch, Hammond's sign, or mediastinal crunch. Please remember, do not confuse this with Homan's and Moses sign. Homan's sign is seen in DVT. Moses sign is also seen in DVT. First investigation to be done in these patients will be chest X-ray, which will show air in the mediastinum or pneumomediastinum. However, best would be a CT scan, and if we are using a contrast, we prefer a water-soluble gastrograph in contrast and not barium, because barium is hypertonic, which can cause injury to the surrounding structures. In the treatment for Boerhaave syndrome, because the patient is going into septicemia due to huge amount of bacterial infection in the mediastinum, our aim is to save the life first. We do a thoracotomy, do a mediastinal lavage with 10, 20, 30 liters of normal saline. Then decision whether to close or not to close the perforation depends on the amount of contamination. If the patient has come to us early, within 4 to 6 hours, we can close. But if the patient has come to us late, maybe after 4 to 6 hours, then just leave a drain in the mediastinum. Another story of chest pain may be related to iatrogenic esophageal perforation, though they are asymptomatic. Iatrogenic means doctor-induced. Most common cause the endoscopy. It is a rigid endoscopy, which will definitely have more chances than flexible endoscopy to cause this esophageal perforation. And this esophageal perforation, iatrogenic perforation, is more commonly seen above the cricopharynx or just near the cricopharynx. Out of the iatrogenic and Boerhaave, it is the iatrogenic which is much more common. Iatrogenic occurs near the cricopharynx. Boerhaave occurs in the lower esophagus on the left side posterior lateral wall. And the treatment for iatrogenic perforation usually is conservative. No operation is required. We just leave an nasogastric tube for 5 to 7 days. Iatrogenic perforations are small and they heal spontaneously. The various foreign bodies in the esophagus, like the common foreign body in a child is a coin. Adult, it is the food bolus or the food impacted food material. Elderly, it is the loose teeth or the denture. Now, there are lots and lots of ways to differentiate on X-ray whether it's a foreign body in the esophagus or in the trachea. Simple to understand is, if the coin is lying normally in a circular shadow on the AP or the PA views, it is in the esophagus. While if it is lying as a linear shadow in the lateral view, then it is the again the esophageal foreign body. Exactly opposite will be the status of tracheal foreign bodies. Now, if suppose we find on X-ray that there is a point which is stuck at the cricopharynx, that means coin is not going down, then the best is to do an endoscopic removal. However, majority of the times what we come across is that the baby has swallowed the coin and the coin has passed through the entire GI tract and come out of the anal canal maybe in 1 day, 2 days, or 3 days. Right. If the patient has swallowed some battery which is old or corroded, then they will require immediate removal. If somebody has impacted food bolus at the cricopharynx, then we encourage giving fizzy drinks or the soda drinks where the gas comes out and it can break the food bolus. However, the best method to remove the foreign bodies from the esophagus would be a esophagoscopic or endoscopic removal. So this is all about the story of thorax, what we have discussed. Now what we'll do is we'll take a break here and we will be back. Right, my dear friends, now if you take a look at the derivation of hiatus hernia, basically hernia is something where there is protrusion of a viscus or a part of viscus through a weakness or defect in the wall which contains it. So when the stomach goes through the opening in the diaphragm up into the thorax, that is hiatus hernia, it can be sliding or paraesophageal. Sliding is something which is associated with reflux. Because of reflux, the gastroesophageal junction is pushed up into the thorax. So this part of the stomach goes into the thorax, that is sliding, so the G junction is in the thorax. But paraesophageal or rolling is because of the weakness in the diaphragm. So it is the fundus of the stomach which goes up into the thorax. That means the G junction remains within the abdomen. Paraesophageal rolling or giant hiatus hernia. Sliding hernia is much more common than paraesophageal. Sliding is associated with reflux, but paraesophageal is associated with weakness in the diaphragm. Risk of complications will be higher in paraesophageal because the diaphragm can compress the fundus of the stomach here, so the blood supply is compressed. The risk of ischemia, strangulation, perforation will be high in paraesophageal hiatus hernia. Since the stomach has gone up into the thorax, so patient present with chest pain and dyspnea, the first investigation will be chest X-ray, but the best would be CT with oral contrast. And the treatment for all the hernias conceptually, we bring the part back into its original position and create a barrier so that it does not go again. So here we do a fundoplication. This is the image of chest X-ray where you can see the stomach shadow in the thorax. So this is hiatus hernia, but whether it is sliding or paraesophageal, that can be known on a CT scan with contrast, wherein we are seeing the gastroesophageal junction up in the thorax here. That means this is a sliding type of hiatus hernia. Another thing is the Bohr-Havi syndrome or barotrauma. This is commonly seen in people after binge drinking or heavy meals when there is forceful vomiting, in elderly people especially. High pressure in the esophagus will cause rupture of the esophagus, most commonly on the left side in the posterior wall, so that all the gastric contents will be released under pressure in the mediastinum, will cause severe mediastinitis and carries the risk of septicemia. Patient present with left-sided chest pain radiating to the left shoulder and to the left arm, mimicking myocardial infarction. Because of leakage of huge amount of air into the mediastinum, this air may seep into the layers of the chest wall and come to lie beneath the skin, which is called a subcutaneous emphysema or surgical emphysema, which is considered pathognomic of Bohr-Havi syndrome. There is a Meckler's triad, which is vomiting, chest pain, and subcutaneous emphysema. How to approach these patients in emergency? When they come with chest pain, first thought which comes to our mind is the cardiac event. So we have to rule out the cardiac event, get the ECG cardiac enzymes done, cardiac event ruled out, stabilize the patient, IV fluids, IV antibiotics. If you're suspecting this esophageal rupture and you do the auscultation, you can hear the sounds as if somebody is walking on the snow, that is footsteps on the snow, which is called as Hammond's sign or Hammond's crunch or mediastinal crunch. Please do not confuse with Homans and Moses sign, which are seen in deep vein thrombosis. The first investigation to be done is a chest X-ray, where you can find free air in the mediastinum, that is pneumomediastinum, but the best investigation would be CT scan. If oral contrast has to be used, iohexol is preferred. If that is not available, then we use gastrographin. So here, iohexol, if iohexol is given in the option, then this is preferred over gastrographin. Barium should not be used because barium is hypertonic and can cause significant injuries. In the treatment for Bohr-Havi, when the patient has been stabilized, diagnosis has been made, we do a thoracotomy and mediastinal lavage. Decision whether to close or not to close the perforation depends on the amount of contamination. If the contamination is less, patient coming to us within 4 to 6 hours, then we can close the perforation. But if the patient comes to us after 4 to 6 hours where we expect more contamination, we cannot put the sutures, we just leave a drain there. Iatrogenic esophageal perforation is a doctor-induced story due to upper GI endoscopy. Rigid endoscopes have more chances, and commonest site would be near the cricopharynx because that is the narrowest part of the entire GIT. Iatrogenic esophageal perforations are much more common than spontaneous esophageal perforation or Bohr-Havi syndrome. Iatrogenic esophageal perforations do not require surgical correction because they are usually small and they can heal spontaneously in 5 to 7 days. So we just do a conservative treatment, leave a nasogastric tube for 5 to 7 days. Just a reminder that iatrogenic perforations near the cricopharynx and Bohr-Havi syndrome, which is rare, is seen in the lower esophagus on the left side posterior lateral wall. Some foreign bodies inside the esophagus, like the coin, safety pin, or the dentures. Most common foreign body in a child is a coin, adult it is a food bolus or fishbone, adult it is loose teeth or denture. If they are asymptomatic, no treatment. If symptomatic, endoscopic removal, or if they are stuck also, then also we do endoscopic removal. If it is a food bolus at the cricopharynx, then we give fizzy drinks to disintegrate this food bolus so that it can go down. The batteries, especially the old batteries or the corroded batteries, require removal. These images help us to differentiate whether the foreign body is in the esophagus or in the trachea. In esophagus, the foreign body would be lying circularly like this on the AP views, and on the lateral view it will give a linear shadow. But due to tracheal rings in the vocal cords, if the foreign body is in the trachea, then on AP view it will be lying linear, and on the lateral view it will be lying circular like this. If we see in the epigastric area, gastritis and peptic ulcer, inflammation of the gastric mucosa is gastritis, and breach in the content of epithelium or mucosa is the ulcer. Gastritis can be acute, chronic, or special types. Acute gastritis, most often due to non-steroidal anti-inflammatory drugs, analgesics, can be related to smoking, Helicobacter pylori, and alcohol. It is acute insult to the gastric mucosa causing multiple erosions in the gastric mucosa which bleed, and this blood can either come out in vomiting as hematomasis or may go down as melena. A patient presenting with hematomasis, generally the commonest reason is peptic ulcer. Duodenal ulcer more commonly presents with bleeding, gastric erosions, Mallory tear, and esophageal varices. Esophageal varices are seen in chronic liver disease and chronic alcoholic patients and portal hypertension patients. Mallory tear is a longitudinal mucosal tear just below the gastroesophageal junction in the cardia of the stomach, associated with binge drinking in elderly people commonly, and presents with hematomasis. It is a longitudinal mucosal tear, right? If we differentiate the Bohr-Havi from Mallory and esophageal varices, Bohr-Havi and Mallory both are associated with binge drinking. Esophageal varices seen in chronic alcoholic and chronic liver disease. Bohr-Havi and Mallory, Bohr-Havi in the esophagus, Mallory in the cardia of stomach, esophageal varices in the esophagus. Bohr-Havi is a perforation, so all layers are involved transmural. Mallory is just a mucosal tear, and esophageal varices involve the mucosa submucosa. Bohr-Havi presents with left-sided chest pain, Mallory hematomasis, and esophageal varices also hematomasis. How to approach a hematomasis patient, a patient who is vomiting blood? We have to save the life of this patient. Basic resuscitation, IV fluids, the normal saline, ringalactate. If more than 30% of blood loss is there, then blood transfusion. Tranexamic acid is also helpful in stopping the bleed. Generally, this is sufficient, but if it fails, we do upper GI endoscopy, and if we are able to see a bleeding vessel on endoscopy, then we can deal with that bleeding vessel by endoscopic sclerotherapy, adrenaline diathermy, or clips. If we are not able to see bleeding vessel on endoscopy, maybe submucosal bleed, then we do angiography, where we use a Fogarty catheter in vascular surgery. And if we see bleeding from the vessel on angiography, we can do angioembolization or therapeutic embolization. Most commonly, we use a coil to stop the bleed. Surgical treatment is rarely done in acute gastritis. If more than 6 units of blood is required for stabilization, then we do a laparotomy, gastrotomy, and ligate the bleeding vessel. Chronic gastritis can be classified as type A and type B. A is for antibodies, that is autoimmune or atrophic, where antibodies are formed against the parietal cells. We know the job of the parietal cell is to produce acid and intrinsic factor. So if antibodies are formed, they will not allow the acid to come out. Hypochlorhydria. This will activate the G cells in the interim, which will release gastrin, hypergastrinemia, and this gastrin will stimulate the parietal cells to produce acid. But because antibodies are not allowing the acid to come out, gradually changes will develop in the parietal cells. Adenomas will develop, which can lead to cancer. If intrinsic factor is not there, there will be defective absorption of vitamin B12 causing pernicious anemia. The common site of gastric cancer in pernicious anemia is the fundus of the stomach. The common cause of hypergastrinemia is overuse of proton pump inhibitors now. B gastritis, B is for bacteria, so Helicobacter pylori. This may be responsible for gastric and duodenal problems. The gastric problems are related to disruption of the mucous barrier. H. pylori produces some toxins which can damage the mucous barrier, and if the mucous barrier is damaged, acid in the stomach will come in contact with the stomach mucosa and cause gastritis, gastric ulcer, or even gastric cancer. While H. pylori produces an enzyme urease which split urea into ammonia, ammonia being alkaline, now the parietal cells will secrete more acid to neutralize this alkali, and when more acid moves towards the duodenum, the first part of duodenum does not have the barrier, so this acid will hit the duodenal mucosa and cause duodenal ulcer. Whether it is gastritis, gastric ulcer, or duodenitis, duodenal ulcer, patient usually presents with the epigastric pain. And in epigastric pain, the first thought which comes to our mind is lifestyle. So we try to modify the lifestyle of the person. If that fails, then we give PPIs. PPIs will be able to reduce the acid secretion, take control in the symptoms to some extent. But if the story is bacteria, PPIs will not kill the bacteria, and patient will come to us again with the symptoms. So now we will do upper GI endoscopy to see where is the problem, whether it's the lower esophagus, stomach, or the duodenum. On endoscopy, if you find a problem in the lower esophagus like esophagitis, you suspect GERD and you do a 24-hour ambulatory pH monitoring, which is the gold standard investigation for GERD. And the surgical treatment for GERD would be a fundoplication. If you don't find anything in the lower esophagus on endoscopy, but you find ulcer in the stomach ulcers can become malignant, so you take a biopsy from the stomach ulcer to rule out cancer. Also, stomach ulcers are associated with bacteria H. pylori which live in the antrum of the stomach, so you take a biopsy from the P. pylori region to rule out H. pylori. If you do not find anything in the esophagus or the stomach, but you find something ulcer in the duodenum, then duodenal ulcers hardly ever become malignant, so you don't take a biopsy from duodenal ulcer. But most common cause of duodenal ulcer is the bacteria H. pylori, so you take a biopsy from the P. pylori region to confirm this H. pylori. When we take a biopsy, then we can take the help of various stains like Jeanstein, Ethenstein, silver stains to identify this bacteria. We can do a rapid urease test, which is the CLO test or the Campylobacter-like organism test. We can also do a urea breath test using a radio-labeled carbon, 13 carbon or 14 carbon. 13 carbon would be better. If H. pylori is found, then we have to eradicate this bacteria. So eradication therapy involves a triple drug therapy, which is a combination of 2 antibiotics and 1 PPI given for a period of 14 days. The special gastritis include Meniere's disease, which is gross hypertrophy of gastric mucosal folds. It is a pre-malignant condition. Erosive gastritis is due to NSAIDs. Age gastritis due to cryptosporidiosis. Eosinophilic gastritis is allergen-induced, and reflux gastritis is seen after gastric surgery due to damage to the pylorus. When we are connecting the stomach with the jejunal alkaline contents will reflux into the stomach and will cause damage to the stomach mucosa. This is called as reflux gastritis or alkaline gastritis. Gradually, the gastric mucosa would like to become like the jejunal mucosa. Both are columnar, so the columnar will not change into columnar, but yes, there is a difference between gastric columnar and intestinal columnar, where intestinal columnar will have more amount of blood cells. So there will be intestinal metaplasia inside the stomach, which will increase the risk of adenocarcinoma of the stomach. If we talk about peptic ulcers, most common site of peptic ulcer is first part of duodenum. The second most common site is the stomach. In the stomach, they are more commonly seen in the pre-pyloric region on the lesser curvature. They may be seen in the lower esophagus. They may be seen in the mecal diverticle or the stoma of gastrojejunostomy. And the various risk factors for these peptic ulcers would be most commonly it is the Helicobacter pylori. However, various S like NSAID, smoking, spirit, spices, stress, steroids, syndrome, Zolliker-Ellison syndrome, or gastrinoma. Peptic ulcers seen in head injury patients are Cushing ulcers. Peptic ulcer in burn patients are Culling ulcers. Skin ulcer in burn patients are Marjolin ulcer. If we see the difference between duodenal and gastric ulcers, duodenal ulcers are much more common than gastric ulcers. Duodenal ulcers are commonly seen in young and rich people. The size of the duodenal ulcer is small as compared to gastric ulcer, while gastric ulcers are more commonly seen in elderly people and poor people. The basic pathogenesis of duodenal ulcer is high acid. Gastric ulcer, it is destruction of the barrier. So axial secretion will always be high in duodenal ulcer, but axial secretion can be anything in gastric ulcer, maybe high, normal, or low. Both gastric and duodenal ulcer present with epigastric pain. However, duodenal ulcer pain occurs 2 to 3 hours after meals. Gastric ulcer pain occurs immediately after meals. Duodenal ulcer pain is relieved by food, while gastric ulcer pain is relieved by vomiting. The appetite and weight increases in duodenal ulcer, decreases in gastric ulcer. A blood group patients have more chances of gastric. O blood group have more chances of duodenal ulcer. Patient presenting with epigastric pain, first thought acid, so lifestyle modification. If that does not help, then PPIs. PPIs are the gold standard treatment for peptic ulcers. 90-95% of patients are successfully treated by PPIs alone. In gastric ulcer, we can add sucralfate, which forms a coating on the surface of the stomach mucosa and prevent contact of acid with the stomach mucosa. If PPI fails, then we do upper GI endoscopy, and on endoscopy, depending on what we find, we proceed accordingly. If Helicobacter pylori is found, then we give eradication therapy, triple drug therapy for 14 days, 2 antibiotics, 1 PPI. If the symptoms recur, we consider reinfection with H. pylori and we give re-eradication therapy. If the patient keeps on coming back to us again and again, then we are left with no option but to do some surgery. And in surgery for duodenal ulcer, we have to take control of the acid secretion. So we have got different types of vagotomies like truncal vagotomy, selective vagotomy, and highly selective vagotomy. In truncal vagotomy, there would be best acid control, so the least chance of recurrence. In highly selective vagotomy, there will be least acid control, so maximum chance of recurrence. Whenever we are doing selective or truncal vagotomies, we are also chopping the motor nerve fibers. So this will decrease the motility of the stomach. In order to drain the food from the stomach, we do a pyloroplasty or a gastrojejunostomy. While for gastric ulcers, since gastric ulcers can become malignant, so the treatment should be remove the ulcer part of the stomach. So we are doing some form of gastrectomy in this, maybe a partial gastrectomy, and the surgical treatment of choice is the Roux-en-Y gastrojejunostomy. Billroth 1 was a gastroduodenostomy and Billroth 2 was a gastrojejunostomy. There can be various complications if by chance duodenal ulcer recurs. Even after doing a highly selective vagotomy, then we go for truncal vagotomy and amprectomy. The complications of these surgeries can be a duodenal stump blowout. The sutures which we are putting on the duodenum, they can blow out on the 4th post-op day, so duodenal contents will leak in the peritoneal cavity and cause peritonitis. Dumping syndrome, early dumping and late dumping, because the food will be dumped directly into the jejunum. So patient may have some serious issues, like immediately after meals, maybe 5 to 10 minutes or 20 minutes after meals, when the food comes in the jejunum, there will be migration of blood from the peripheries towards the jejunum. So there will be abdominal fullness, bloating sensation, epigastric pain. Patient can present with abdominal pain like that. And because blood has moved away from the peripheries towards the GIT, there will be cool, clammy peripheries. As the food is broken down slowly and slowly, these symptoms will relieve slowly and slowly, and maybe in half an hour to 45 minutes to 1 hour, the symptoms may subside. So early dumping is due to high osmotic load coming in the intestine, while late dumping is seen in the 2nd hour after meals, and this is due to reactive hypoglycemia. When bulky food comes in the jejunum sends signal to the pancreas to produce more insulin, but actual requirement of insulin was less. So some insulin remains in excess, and this excess insulin causes hypoglycemic symptoms, maybe tremors, confusion, faintness like that. And to treat this, we have to again give glucose. So it is advised that patient should not take bulky meal, but small frequent meals. There can be post-vagotomy diarrhea, protein, calorie malnutrition, deficiency of iron, vitamin B12, calcium, phosphorus, increased risk of gallstones and gastric cancer. Complications of peptic ulcer can be bleeding, perforation, stenosis. Bleeding most commonly seen from ulcers situated on the posterior surface on the first part of duodenum. So duodenal ulcers most often bleed, and they are from the gastroduodenal artery. Gastric ulcers rarely bleed, and this bleeding in gastric ulcer is from left gastric artery. Perforation is more commonly associated with ulcers on the anterior surface. So if a duodenal ulcer perforates, contents will leak into the peritoneal cavity causing peritonitis, diffuse abdominal pain, anorexia, nausea, vomiting, and fever. We might see this patient in a shock-like condition. So first we have to manage the shock by giving IV fluids and all. When we do clinical examination, we may find cardboard-like rigidity. First investigation after stabilization would be a chest X-ray where we see gas under diaphragm beneath the right dome of the diaphragm. That is pneumoperitoneum. That indicates hollow viscous perforation. Maybe a perforation of the stomach, duodenum, jejunum, ileum, colon. Best investigation would be a CT scan, and if contrast has to be used, we can use that less injurious contrast like iohexol. In the treatment, to save the life, we have to do a laparotomy and a peritoneal lavage. This lavage will remove the septic load and save the life of the patient. Decision whether to close or not to close the perforation depends on the amount of contamination. If the patient comes to us early within 24 to 48 hours, closure of the perforation with a mental patch, Grams patch. If the patient comes late after 24 to 48 hours, then just leave drains in the peritoneal cavity. Another complication is stenosis. If the ulcer heals transversely, it results in a hourglass stomach. If the ulcer heals longitudinally, it results in a teapot stomach. The various bezors, trichobezor, phytobezor, lactobezor, trichobezor hairs inside the right. So bariatric surgery, basically this is surgery for morbid obesity, also called as metabolic surgery. Indication for doing a bariatric surgery, the BMI is more than 40 or BMI more than 35 with comorbidities like uncontrolled diabetes, hypertension, osteoarthritis, sleep apnea syndrome. Basically, if the BMI is more than 35 with comorbidities and BMI more than 40 with or without comorbidities. Right. Now, most effective bariatric surgeries are run by gastric bypass. Other bariatric surgeries include vertical banded gastroplasty, laparoscopic adjustable gastric banding, and sleeve gastrectomy. In the right hypochondrium, the gallbladder pathologies, most important, the gallbladder stones. The gallbladder stones can be either cholesterol, pigment, or mixed. Cholesterol, more than 50% of cholesterol is there. They're pale yellow in color. Pigment, less than 30% of cholesterol, green, brown, or black color. Mixed, 30 to 50% of cholesterol, gray in color. Cholesterol stones are more common in fat fertile female 40. Whenever there is high cholesterol or less bile salt, bile acid in the gallbladder, such bile is called as lipogenic bile or supersaturated bile. Abnormal enterohepatic circulation, like disease of terminal TB and Crohn's, they can also be associated with gallbladder stones. Pigment stones, more commonly associated with hemolytic disorders like hereditary spherocytosis and sickle cell anemia. If there is more breakdown of RBC in the spleen, more pigment will be produced in the spleen, and this pigment will travel through the splenic vein portal into the liver and will come inside the gallbladder, and this pigment will form pigment stones here inside the gallbladder. Pigment stones may be associated with bacterial infections like E. coli, parasitic infestations like Ascaris and Clonorchis. The stones inside the gallbladder can have variable presentations. Patient may be asymptomatic or symptomatic OPD or symptomatic emergency. Asymptomatic, usually more than 80% of patients are asymptomatic. So ideally, no treatment is required in asymptomatic gallstones. But if asymptomatic gallstone is associated with either a large single stone more than 3 cm, multiple stones, immunocompromised, elderly, typhoid carrier, pregnancy, porcelain gallbladder, adenomatous polyp more than 10 mm in size, hemolytic disorders, and bariatric surgery, then we do a cholecystectomy even if the patient is asymptomatic. However, majority of these patients come to us in the OPD with mild symptoms, mild on and off pain in the right upper abdomen. Hardly anything on clinical examination. So we do ultrasound, which is the gold standard investigation for gallstone disease. The stone itself appears hyperechoic and it casts a post-acoustic shadow. It is with this post-acoustic shadow we are able to make out that yes, this is a stone. And the treatment for symptomatic gallstones is laparoscopic cholecystectomy, where we put 4 ports in the abdomen. Various needed to create pneumoperitoneum, and carbon dioxide gas is used to create this pneumoperitoneum. We do the dissection in calyx triangle, where the boundaries of calyx triangle superiorly by the inferior surface of liver, laterally by the body of gallbladder and the cystic duct, and medially by the common hepatic duct. The content of calyx triangle is the cystic artery, where there is a cystic lymph node affluent situated here. Symptomatic emergency type of presentations. If there is a large stone at the mouth of the gallbladder creating a traffic jam, mucus will get collected inside, stasis, party, acute inflammation of the gallbladder, acute cholecystitis. Sudden onset of severe pain in the right hypochondrium, radiating to the back to the inferior angle of right scapula, and sometimes to the tip of right shoulder, anorexia, nausea, vomiting, and fever. Now, in these patients, when we do the clinical examination, we can elicit a Murphy's sign. If we try to insinuate 4 fingers beneath the right costal margin and ask the patient to take a deep breath, patient suddenly catches her breath. This is Murphy's sign. This simply indicates that the gallbladder is red hot, inflamed, acute cholecystitis. Investigation of choice here is an ultrasound of the abdomen. But if by chance on ultrasound we are not able to see a stone blocking the mouth of the gallbladder, and we are confused between acute calculous cholecystitis and acalculous cholecystopathy. Acalculous cholecystopathy is due to motor weakness of the gallbladder. When the gallbladder is not able to pump the bile out, there will be biliary stasis, infection, and party, acute inflammation of the gallbladder. To differentiate acute calculous cholecystitis from acalculous cholecystopathy, we can do a HEDA scan. And on HEDA scan, if the isotope does not go inside the gallbladder, so non-visualization of the gallbladder is acute calculous cholecystitis. However, in HEDA scan, if the isotope goes inside the gallbladder and does not come out of the gallbladder because of motor weakness of the gallbladder, there will be persistence of isotope within the gallbladder despite washout of isotope from remainder of biliary tree. This is acalculous cholecystopathy. In the treatment for acute cholecystitis, we give IV fluids, IV antibiotics, that is conservative treatment for 5 to 7 days. Then we discharge the patient from the hospital with the advice to come back again to the hospital for laparoscopic cholecystectomy after 3 to 6 weeks, which is called as interval cholecystectomy. Right, so this is how the gallstone looks like on ultrasound. You can see there's a stone here which is white, that is hyperechoic, and this is the posterior black shadow or the post-acoustic shadow. Sometimes there can be complications of laparoscopic cholecystectomy. For example, there may be a bile leak from the cystic duct stump. There may be obstruction in the flow of bile due to a stone slipping into the CVD, or there may be a stricture developing in the bile duct because of healing by fibrosis. Now, if there is a bile leak, and if it is a small bile leak, minimal bile leak, the patient may be asymptomatic or maybe just mild pain in the right hypochondrium. This can be easily treated by putting a stent into the CVD, that is endobiliary stenting, and then this leak will stop. If there is huge amount of collection in the right hypochondrium and it has become infected, patient presents with severe symptoms, then we have to do ultrasound guided drainage of this biliary collection, apart from doing endobiliary stenting. And bile obstruction may be because of a stone which has slipped into the common bile duct. Other pathologies related to gallbladder like mucocele, that is mucus distension of gallbladder, empyema gallbladder is pus inside the gallbladder which is treated by tube cholecystostomy, ultrasound guided percutaneous catheter drainage. Cholestrosis is also called as strawberry gallbladder, where there is deposition of yellowish flakes on the mucosal surface of the gallbladder. Porcelain gallbladder is deposition of calcium within the gallbladder. This is a pre-malignant condition, so the treatment should be cholecystectomy. Meredith syndrome is when there is jaundice due to compression of the common hepatic duct by a large stone inside the gallbladder. Ideally, the gallstone should not create any obstruction in the bile flow, so there should not be any jaundice. But if there is a big stone, this stone may put pressure on the common hepatic duct from outside, can cause compression of the common hepatic duct, interfere with the biliary flow, leading to jaundice. That is Meredith syndrome. Fistula of gallbladder, abnormal relationship of gallbladder with the surrounding people, most commonly with the first part of duodenum. And if this fistula occurs, there are chances that this stone may slip through the fistula into the duodenum, and then this stone will be coming down towards the ileum and may create a traffic jam at the ileocecal junction, leading to intestinal obstruction, cardinal signs of intestinal obstruction, abdominal pain, vomiting, distension, constipation. This intestinal obstruction due to gallstone is called as gallstone ileus. If we take X-ray, we find a regular stride wherein we find multiple air fluid levels, air in the gallbladder, stone in the intestine, and the treatment would be simply removal of the obstruction. Strange stride is gallstone hypertonia and diverticulosis of colon. That is different. So the different strides, what we know, Mechler's stride is vomiting, chest pain, and subcutaneous emphysema seen in Bohr-Havi syndrome. Charcot stride, pain, fever, jaundice, cholangitis. Any traffic jam in the CBD can lead to cholangitis. Raynaud's pentad, pain, fever, jaundice, hypertension, mental confusion. That is again cholangitis with septicemia. Regular stride, gallstone ileus in fistula of gallbladder with the first part of duodenum. Regular stride is multiple air fluid levels on X-ray, air in the gallbladder, and stone in the intestine on X-ray. Strange stride, gallstone hypertonia and diverticulosis of colon. If the gallstone slips and comes into the CBD, or maybe the stone developing in the CBD due to maybe infection in the CBD, patient can come to us in OPD or emergency. In the OPD with intermittent jaundice, first investigation LFT, then ultrasound. Investigation of choice would be MRCP, or if MRCP is not there, we can do ERCP. On ERCP, we can see filling defect inside the CBD because of these stones. There can be single stone or multiple filling defects. And for the treatment of these CBD stones, what we are doing is we are doing a ERCP and then putting a Dormia basket in the CBD and removing the stone. So ERCP with sphincterotomy and CBD stone extraction with a Dormia basket. However, if the patient comes to us in emergency with a complete traffic jam in the CBD, proximal dilatation, cholangitis, pain, fever, jaundice, Charcot stride, Raynaud's pentad, pain, fever, jaundice, hypertension, mental confusion, first motive to save the life, IV fluids, IV antibiotics, if possible, do a quick LFT ultrasound, and then to save the life, we have to remove the septic load, so we do a endobiliary stenting, which is ERCP and stenting. We can simply put a stent into the bile duct like this and drain the bacteria. If the gallstone slips into the pancreatic duct and create a complete traffic jam in the pancreatic duct, it can cause acute pancreatitis. The proximal pancreatic duct will be dilated, and here there is a stone causing complete traffic jam. Patient will present with sudden severe abdominal pain, with shock, and maybe with raised levels of pancreatic enzymes. Most common cause of acute pancreatitis is gallstones, second alcohol, in children, hereditary and trauma, and operative cause ERCP. In acute pancreatitis, there is premature activation of the pancreatic enzymes within the pancreas, which causes pancreatic necrosis. Patient present with sudden severe upper abdominal pain, central part, radiating to the back either from the right or the left side, increases in supine position, relief on sitting and bending forwards, nausea, vomiting, fever is due to secondary bacterial infection, there may be ascites, pleural effusion, bleeding in the retroperitoneum, and acute hemorrhagic pancreatitis, causing bluish discoloration around the flanks, great Turner sign, bluish discoloration around the umbilicus, Cullen sign. Shock-like features like tachycardia, tachypnea, and hypertension, basic resuscitation, we pump in IV fluids to save the life, no role of antibiotics initially because it is enzymatic necrosis and not bacterial necrosis. We can get the pancreatic enzymes blood test done, serum amylase and lipase. Amylase is non-specific, but it starts rising immediately. If it is more than 3 times the normal, it favors acute pancreatitis. Serum lipase starts rising after 3 days, but it is specific. If we do an X-ray, we can find a colon cutoff sign, a sentinel loop sign, and a renal halo sign. But the radiological investigation of choice would be a CT scan, where we can even do the grading of severity of acute pancreatitis. In the treatment, we want to relieve this traffic jam, so we can do this by ERCP, sphincterotomy, and stone extraction using a Dormia basket. Surgery is generally not required in acute pancreatitis, but indication of surgery can be in pancreatic abscess. We do a percutaneous drainage under ultrasound or CT guidance. If there is infected pancreatic necrosis, we do a pancreatic necrosectomy or pancreatic debridement. If there is a pseudocyst of the pancreas and it is not resolving, then also surgical intervention is required. Pseudocyst is just collection of pancreatic enzymes and fluid around the pancreas. We call it pseudo because it is not lined by true epithelium. Usually these pseudocysts are small, patient is asymptomatic and they resolve spontaneously, but sometimes they can become large and can extend from mediastinum above to pelvis below. Can present with pressure symptoms like epigastric pain, can present with malabsorption as well. Sometimes can complicate leading to abscess rupture, but malignancy will never be a complication of pseudocyst because there is no epithelium. Investigation of choice would be a CT scan, and on CT scan, you can see this nice fibrous tissue all around this cyst. So this is what is a pseudocyst. Now, if the patient is symptomatic or there are complications or it is present for more than 12 weeks, then we want to do something for these pseudocysts. We can do a cystoantrostomy, where cystogastroscopy or cystojejunostomy can be done. For prognosis in acute pancreatitis, we can take the help of various prognostic scores like Apache 2, Ranson's class scores, and SOFA scores. A quick SOFA score or Q-SOFA score comprises of respiratory rate more than 22 per minute, systolic blood pressure less than 100 mm of mercury, Glasgow Coma scale less than 15, indicates that the risk of mortality is higher. In mild acute pancreatitis, mortality risk is less than 1%. In severe necrotizing pancreatitis, the risk is 20 to 50%. Chronic pancreatitis, the most common cause is alcohol, second most common is gallstone. It is irreversible pancreatic cellular atrophy with calcification, strictures and ectasia of the pancreatic duct, 4 times more common in males, most often seen after 40 years of age. Patient presents with pain in the epigastrium, especially increasing after meals. There can be malabsorption, diabetes. MRCP, RCP shows chain of flakes appearance. For malabsorption, we give pancreatic enzyme supplements like pancreatoflat and prion. For diabetes, we give insulin. And for pain relief, we ask the patient to avoid alcohol, take small frequent meals, use analgesics before meals, or we can give octreotide. Surgical treatment, what we can do is a longitudinal pancreatic vaginostomy or a side-to-side pancreatic vaginostomy or a modified post-close operation. In the liver abscesses, pyogenic amoebic and hydrated cyst, pyogenic by bacteria Streptococcus malaria and E. coli, amoebic by Entamoeba histolytica, and hydrated cyst by Echinococcus granulosus. Pyogenic liver abscess associated with infection in the bile duct, amoebic fecal-oral, hydrated again fecal-oral transmission. Pyogenic liver abscesses, they present with high-grade fever, chills, rigors, jaundice. Amoebic liver abscess present with fever, jaundice. Hydrated cyst can present with fever, jaundice. High risk of septicemia in pyogenic liver abscesses. If the patient presents with jaundice, first LFT. If the patient presents with pain in the right hypochondrium, first ultrasound. So initial investigation would be ultrasound, but the best radiological investigation would be a CECT of the abdomen. To be more specific, for pyogenic abscesses, we can do a pus culture or blood culture. For amoebic, we can do a stool test to detect the ova of this Entamoeba histolytica and to isolate the cyst or ova basically. And in hydrated, we do a ELISA test where we detect antibodies against the hydrated antigen. In the treatment, pyogenic, it is bacterial, so we target gram-positive, gram-negative anaerobes, third generation cephalosporins, aminoglycosides, and metronidazole. Amoebic liver abscesses, we give metronidazole, piperacillin double dose, 400 to 800 mg thrice a day for 14 days, and hydrated cyst, antihelminthic, mebendazole, albendazole. If the abscess is large, we do a percutaneous drainage and ultrasound or CT guidance, but in hydrated cyst, we take extra precaution wherein we do a pair. First, we do a percutaneous needle aspiration, then installation of hypertonic saline, and then re-aspiration. When we drain the amoebic liver abscesses, we find anchovy sauce pus in amoebic liver abscess, and we see inverted flash ulcers in amoebic colitis. Sigmoid volvulus, when there is long mesentery of the sigmoid colon, it can undergo rotation, generally anti-clockwise. If there is more than 180-degree rotation obstruction, more than 360-degree rotation strangulation, On X-ray, we see a coffee bean sign and a bird of prey sign, and the treatment just leave a fetus for 24 hours. If it is gangrenous, we do a resection and anastomosis. So here, this is what is a coffee bean sign, and this is what is a bird of prey sign seen in sigmoid volvulus. For urinary stones, most common urinary stones are the calcium oxalate stones. The kidney stones are calcium oxalate. Bladder stones are much more common in boys, 10 times more common in boys. Most common urinary bladder stone in boys is triple phosphate. In adults, urinary bladder stone is uric acid. Reasons for these urinary stones: most common idiopathic hypercalciuria. There can be idiopathic hyperoxaluria, idiopathic hyperuricosuriia, idiopathic hypercystinuria, urinary tract infections, prolonged immobilizations, deficiency of vitamin A, hyperparathyroidism, and milk alkali syndrome. Now, different types of urinary stones like calcium oxalate can be monohydrate, dihydrate, dihydrate being the most common. Monohydrate are the second hardest stones. They are commonly seen in normal urinary pH. They are speculated and cause hematuria. Triple phosphate stones composed of calcium, ammonium, magnesium, phosphate. These stones are more commonly seen in alkaline urine due to UTI by Proteus, Klebsiella, E. coli type of people. These stones are mostly opaque. They're too white. They remain silent and can enlarge and take the shape of pelvic calcium system. Stone taking the shape of pelvic calcium system is called as the Staghorn stone. Cystine stones are the hardest stones, and they are seen in patients of cystinuria, acidic urine, and they are difficult to be broken by shock waves, ESWL. Uric acid stones are smooth round oval in uricosuriia patients, acidic urine. They are radiolucent. They are not visible on X-ray. Other radiolucent stones in the body are remembered by the mnemonic PG Lux, PG Medange, Lux Anange, P for parotid, G for gallbladder stones, L lysine, U uric acid, X xanthine. This Lux is the urinary stone. So xanthine, lysine, indena, wheat, pranth, and allopurinol can be other urinary stones. How these urinary stone patient can come to us? Most commonly they come with pain. There can be frequency, hematuria, interruption of urinary stream is seen with large vesicle calculus. Regarding the pain, depending on the location of the stone, the pain location may vary. If it is in the kidney, lumbar pain. If it is in the upper ureter, lumbar pain radiate to the perineum in females and testis in males. If it is at the pelvic rim, that is the junction of upper and middle ureter, then lumbar pain radiate to the inner thigh. If it is in the middle ureter, lumbar pain radiate to the iliac fossa corresponding side. If it is in the lower ureter or intramural ureter, there is strangling, painful desire to pass urine. In the bladder, there is no lumbar pain or radiating pain, just a suprapubic pain. If the stone is at the bladder neck or in the urethra, then the suprapubic pain is referred to the tip of penis. Our clinical approach: first we give pain relieving medicines like diclofenac. We can take X-ray, KUB, or ultrasound, KUB. Investigation of choice is a non-contrast CT scan. In the treatment for stones less than 5 mm, just plenty of fluids. More than 5 mm stones in the kidney, upper, middle ureter, ESWL. More than 1.5 cm stone in the kidney, upper ureter, PCNL, percutaneous nephrolithectomy. For lower ureteric stones, we are doing a URS, ureteroscopic retrieval of stone. We can do this URS for even middle ureteric or upper ureteric stones. For bladder stones, we are doing a lipolapexy, where we pass a cystoscope, break the stone, and then the patient can pass these stones. In URS, we are using a Dormier basket. For urethra stone, we push the stone back into the bladder and treat it like bladder stone. When we are doing a PCNL, we are passing through the renal parenchyma, so it causes bleeding. PCNL is done through 12th rib approach posteriorly. There is risk of injury to the pleura, to the spleen, and to the colon, but not to the lungs. PCNL can also cause hydrothorax and hemothorax. ESWL is extracorporeal shock wave lithotripsy, where shock waves are fired directly onto the stone, and the stone is broken into small fragments. And these fragments, they align themselves in the ureter like stream starch phenomena, and then they pass in urine. The commonest complication of ESWL is also bleeding, but ESWL is not done if there is more than 1.5 cm stone, pregnancy, bleeding, diathesis, distal obstruction, or cystine stones. If there is a traffic jam situation in the urinary tract, for upper urinary tract traffic jam, in emergency situations, we can do endourinary stenting. We can put a DJ stent, and if we are not able to negotiate the obstruction with a DJ stent, we can do a percutaneous nephrostomy. While for lower urinary tract obstruction, first we try putting a Foley's urethral catheter. If not successful, then we can do a suprapubic cystostomy. Urinary tuberculosis is not a ascending infection, it is a hematogenous infection. In kidney TB, the story starts at the renal papilla, so ulcer at the renal papilla. Gradually, there is caseation necrosis involving the entire kidney, kidney, which can become semen kidney and autonephrectomy. In bladder TB, initially the story starts near the ureteric opening, and gradually it can involve the entire bladder. The patient may present with constitutional symptoms of TB. There may be anorexia, weight loss, evening rise of temperature. There may be frequency of micturition and hematuria. First investigation is urine examination, and sterile acidic pyuria is classically seen in urinary tuberculosis. Investigation of choice would be CECT, or if we are doing IVP as well, or CECT. In renal TB in the early stages, we find moth-eaten calluses, that is erosion of the minor calyx. In later stages, we find a putty kidney due to this caseation necrosis. While in bladder TB, in the early stages, we find a gold-full ureteric orifice, and in the later stages, we find a narrow contracted bladder, which is a thimble bladder. This late stage of kidney TB is pseudocalculi appearance, and the treatment for urinary tuberculosis would be anti-tubercular therapy. Also be bacterial, which is polymicrobial, caused by Bacteroides E. coli, can be parasitic by pinworms, can be due to obstruction in the lumen of the appendix by a polyp or carcinoid tumor. Most often presents in late teens, early 20s, more common in males. The presentation can be with mental scoring, which is also called as Alvarado score. M for migratory right iliac fossa pain. Remember, it is migratory right iliac fossa pain. It is not just the right iliac fossa pain. Initially, the pain is in the periumbilical region, and then it shifts from the periumbilical to the right iliac. A, anorexia, N, nausea, vomiting, T, tenderness, R, rebound tenderness, E, elevated temperature, L, leukocytosis, and S, shift for neutrophils. In this mental scoring, 1 point is given for everything, but 2 points are given for tenderness, and 2 are given for leukocytosis. The total score becomes 10. If the score is 5 or less than 5, then acute appendicitis is ruled out. But if it is 7 or more than 7, there is high probability of acute appendicitis. How to approach these patients coming to us in emergency? Before you touch the patient, you ask the patient to demonstrate the pain path. So he uses his finger to demonstrate that pain started from the periumbilical and then it went towards the right iliac fossa. That is the pointing sign. Pulse rate is generally between 80 to 90 beats per minute. Temperature usually less than 100.4 degree Fahrenheit. When you do the clinical examination, you can elicit tenderness in the right iliac fossa, that is pain on pressure. If you press at the McBurney's point, the patient winces in pain. This is McBurney's sign. When you are releasing the pressure, again the patient winces in pain. This is rebound tenderness. And this is when the parietal peritoneum close to the inflamed appendix is also becoming red hot. Then when you are releasing the pressure, there is elastic recoil of the inflamed parietal peritoneum. And that is causing pain. So this is called as rebound tenderness or Schottky and Bloomberg sign. Also, you may find localized guarding and rigidity in the right iliac fossa, where the abdominal muscles in the right iliac fossa, they try to resist any external pressure. Various other signs which can be seen. Rovsing sign. That is, if you press in the left iliac fossa, patient complains of pain in the right iliac fossa. This is due to shifting of gas or maybe shifting of intestines from the left to the right side. And if there is red hot appendix on the right side, then the patient can experience pain. If the red hot inflamed appendix is lying on the obturator muscle in the pelvic area, if you try to stretch the obturator muscle by internal rotation of flexed right hip, then patient may present with pain in the right iliac fossa. This is obturator sign. If the inflamed appendix is lying retrocecally on the psoas muscle and you try to stretch the psoas muscle by hyperextension of right hip, patient complains of pain in the right iliac fossa. This is psoas sign. Pain in the right iliac fossa just on cuffing. This is Dunphy's sign. Generally, no investigation is required in acute appendicitis. It is a clinical diagnosis. However, we can do some simple blood tests like total leukocyte count and differential leukocyte count. Generally, the total leukocyte normally is between 4,000 to 11,000 per cubic millimeter. But in acute appendicitis, it can be mildly elevated, 11,000 to 14,000 per cubic millimeter. And since it is an acute inflammation, so acute inflammatory infiltrate, that is neutrophils or polymorphs, will be raised in this situation. No investigation is needed, but if the patient is fussy, then the best investigation to see inflamed appendix would be CECT of the abdomen. Generally, ultrasound of the abdomen is not done to diagnose acute appendicitis, but sometimes we might get confusing clinical scenarios. Suppose a 25-year-old girl comes to us with pain in the right iliac fossa. When we are examining this girl, we may find tenderness in the right iliac fossa, but the classical rebound tenderness might be missing. And we are not able to make the diagnosis whether it is acute appendicitis or maybe torsion of the ovarian cyst, or if suppose she does not remember when she had her last menstrual cycle. This might be a case of ruptured ectopic pregnancy as well. So whenever we are in a confusional state, we can take the help of ultrasound. Ultrasound is not done to make the diagnosis of acute appendicitis, but to rule out other differential diagnoses. And when we are doing the ultrasound, if we find that the diameter of the appendix is more than 6 millimeter, then it favors acute appendicitis. Appendix looks like a blind, tubular, aperistaltic, non-compressible structure in the right iliac fossa. With a diameter more than 6 millimeter, it favors acute appendicitis. Now, in the treatment for mild acute appendicitis is conservative with antibiotics. No need to do appendicectomy if it is just a mild appendicitis. It can be successfully treated with antibiotics. But if it is a severe appendicitis, obstructive type of appendicitis, then we need to do a appendicectomy. For doing appendicectomy, we can take the help of various incisions, muscle splitting incision, muscle cutting incision, and we can do laparoscopic appendicectomy as well. Generally, we are using muscle splitting incision. In this, we cut the skin subcutaneous tissue external oblique aponeurosis at the mid-bunny's point usually, and then we put an artery forceps into the internal oblique and transverse abdominis muscle and just split the muscle fibers. And then we see the peritoneum in front of us and pinch the peritoneum and bring it out. And then we go inside the peritoneal cavity and do the appendicectomy. Since we are not cutting the internal oblique and transverse abdominis muscle, the strength of the muscles is better and the chances of hernia after surgery would be less. So muscle splitting incisions would give a better strength in the right iliac fossa as compared to if we are cutting these muscles like in muscle cutting incisions. There are two muscle splitting incisions, Meckburney's or gridiron, and Lanz incision. Lanz is relatively more transverse and it gives a better cosmetic outcome in the right iliac fossa. That is because of addition of the omentum, maybe the small intestine, maybe the cecum over this appendix. And if the patient comes to us with mass, we admit the patient in the hospital, give conservative treatment, IV fluids, IV antibiotics. This is Ochsner-Sharon regime. By giving IV fluids and IV antibiotics, the mass decreases slowly, and maybe in 5 to 7 days we discharge the patient from the hospital with the advice to come back to the hospital again after 3 to 6 weeks for interval appendicectomy. If we take a look at the inflammatory bowel diseases, the Crohn's and ulcerative colitis, the Crohn's disease is also called as regional enteritis. Exact cause of these diseases is not known, but they are thought to be autoimmune. Both these diseases are common in Western countries, rich people, white people. Both the diseases, the peak age of presentation is somewhere between 20 to 30 or maybe 20 to 40 years. A second peak can be seen after 50, 60 years of age as well. Crohn's disease can affect any part of GIT right from mouth to anus, but most common site is the terminal ileum and the cecum. Ulcerative colitis most commonly starts in the rectum and is spread proximally in continuity. So initially there may be proctitis, then proctosigmoiditis, then proctosigmoidocolitis, may involve the entire colon, universal colitis or total colitis or pancolitis, and sometimes it can spread to the terminal ileum, that is backwash ilitis. Crohn's disease can involve the anal region as well commonly. Crohn's disease is characterized by skip areas. Crohn's is not continuous. Ulcerative colitis is continuous. Crohn's disease, pathologically, it involves all the layers of the intestine. It is transmural. While ulcerative colitis only involves the mucosa and superficial submucosa. In Crohn's disease, we find non-caseating granulomas, while in ulcerative, there is non-specific inflammation. Crohn's disease, we find serpentine ulcers, ulcerative collar button ulcers. Crohn's disease, cobblestone mucosa, ulcerative colitis, pseudopolyps. The risk of stricture sinus fissure fistula is more in Crohn's disease. Clinically, Crohn's can present with abdominal cramps, mass or pain in the right iliac fossa, diarrhea, constipation. Ulcerative presents with diarrhea, which can be watery mucus or bloody diarrhea, and depending on the frequency of the stools, we can classify the severity of ulcerative colitis: mild less than 4, moderate less than 6, severe less than 10, and fulminant more than 10 motions in one day. Both Crohn's and ulcerative can be associated with extraintestinal manifestations, like they can involve the joints, which is a polyarthropathy, sacroiliitis, ankylosing spondylitis. In the eyes, there can be uveitis, scleritis. In the skin, there can be pyoderma gangrenosum, erythema nodosum. In the bile duct, there can be sclerosing cholangitis. Primary sclerosing cholangitis is more often associated with ulcerative colitis, and there is risk of bile duct cancer, that is cholangiocarcinoma. However, the common site of cholangiocarcinoma is the hilum of right and left hepatic ducts, that is the confluence of right and left hepatic duct, which is called as Kleck's tumor. Best investigation for Crohn's, since it is a terminal ileum, so CECT, while ulcerative colitis, since it is a colon, colonoscopy. If we are doing contrast studies, then in Crohn's disease, because of the thickening of the terminal ileum, only a thin rim of contrast will be flowing through this area on barium wheel follow through, which is called a string sign of Cantor. In tuberculosis of the intestine also, we find something like this, when only thin rim of contrast will be flowing through the affected bowel. So that is also string sign, but that is simply string sign, and in Crohn's disease, it is string sign of Cantor. In ulcerative colitis, when we are doing barium enema, then we find loss of hostile folds in the colon, and the colon looks like a pipe. That is a lead pipe appearance. The treatment mainstay are the steroids. We can use 5-aminosalicylates in inflammation and pulmonary disease. We can use immunomodulators like levodopa, monoclonal antibodies like infliximab, rituximab. Surgery is rarely done in Crohn's because Crohn's involves multiple areas, skip areas are there, so we cannot do multiple resections. Plus, even after doing surgery, even after removing the diseased bowel, the recurrence is very high in Crohn's disease. So surgery is rarely done in Crohn's, but yes, surgery is curative in ulcerative colitis after removing the disease segment. And surgery is generally reserved for very severe cases, like if the medicines are not working, patient has become dependent on steroids, there are extraintestinal manifestations, risk of cancer is high like in ulcerative colitis, or there are some complications like severe hemorrhage, toxic megacolon, or perforation. That means surgery in ulcerative colitis will be done when there is a massive disease. Suppose it is involving the entire rectum and the colon. So we have to remove the entire rectum and colon, that is total proctocolectomy. After removing the entire rectum and colon, we are left with the ileum and the anal canal. We can bring the ileum out on the abdominal wall as a permanent ileostomy for the whole life. But if the patient does not want this ileostomy on the abdomen for the whole life, he wants that he should pass feces from the normal route, then now we can create pouches from the ileum, and we can connect these pouches with the anal canal. This is called as ileal pouch anal anastomosis. We can make different types of pouch, but the commonest is the J pouch. We can make inverted J pouch, W pouch, M pouch, S pouch. And one complication with this pouch surgery would be, because this is a dirty area, the chances of infection would be high here. So inflammation of the pouch or infection of the pouch, which is called as pouchitis, that can be a problem. Diverticulosis of colon is most commonly seen in the sigmoid colon. Constipated individuals, if the fecal matter stays in the rectum for a long period of time, then pressure in the sigmoid will increase, sigmoid will dilate, and because of high pressure here, especially in elderly people, जैसे जैसे उम्र बढ़ती है हमारे कमजोर होते हैं, in elderly people as we grow older, the tissues become weaker and weaker. If there is a high pressure in this area, it can force the mucosa submucosa to protrude outwards. These diverticulas most often seen in the sigmoid colon over the mesenteric border because the point of entry of blood vessels make the wall of the sigmoid colon weak, so chances of protrusion will be more on the mesenteric border. However, they can also be seen on the anti-mesenteric border. These are acquired diverticulas, false diverticulas, as they do not contain all the layers, they just contain mucosa and superficial submucosa. Patient can be asymptomatic, or sometimes patient can present with pain in the left hilate fossa or maybe bleeding per rectum. Complications like diverticulitis or perforation can occur. When we are doing barium enema, then we find a sawtooth appearance on barium enema. Here you can see the multiple outpouchings. So this is what we see on barium enema. Investigation of choice otherwise is the CCT of the abdomen. The treatment initially is conservative with diet modification and avoiding constipation, but if there are some complications, then we can remove the affected segment into anastomosis. If we see in the hypogastrium, the bladder and urethral traumas, bladder is mainly extraperitoneal. So majority of bladder injuries are extraperitoneal, but sometimes, rarely, 20%, we can find intraperitoneal bladder ruptures, especially when there is an overdistended bladder. Trauma to an overdistended bladder can lead to dome or fundus of the bladder projecting in the peritoneal cavity, and that ruptures. So the bladder ruptures intraperitoneal and leakage of urine in the peritoneal cavity. There will be sudden severe hypogastric pain associated with syncope. In these patients, we can do a simple test, put a needle in the peritoneal cavity, peritoneal tap. If that reveals urine, it means intraperitoneal bladder rupture. The treatment would be lower midline laparotomy, peritoneal lavage, repair the bladder, leave a Foley's catheter in the bladder for 7 to 10 days. Whenever we are doing any bladder surgery and putting the sutures over the bladder, because urine is continuously coming in the bladder, so the sutures can become wet and they can break. So we have to leave a catheter in the bladder for a few days so that the sutures can heal. Extraperitoneal bladder rupture is the commonest rupture, and herein, this area is actually the area where the pelvic bone, the pubic bone lies. So in case of road traffic accidents pelvic fracture, there is a high risk of injury to the extraperitoneal bladder or maybe to the posterior urethra. In extraperitoneal bladder ruptures, we may find teardrop bladder. If you look at the urethral injuries, in urethra, here, this is the posterior urethra, while this is the anterior urethra. Posterior urethra, that part which lies within the prostate is prostatic urethra. That part which is below the prostatic urethra in the posterior urethra is the membranous urethra where there is external sphincter. The anterior urethra, that part which lies in the perineum is the perineal or the bulbar urethra, and that part which lies in the penis is the penile urethra. Out of the urethral injuries, prostatic urethra is protected by prostate, so it is saved. Penile urethra is protected by penis, so it is saved. That means injuries can be seen either in the membranous urethra or the bulbar urethra. Out of these two, bulbar urethral injuries are the most common. However, if we talk about the pelvic fracture road traffic accident where the pubic bone is fractured, there are more chances of injury to the membranous urethra. And in these cases, the most common site of injury is near the apex of prostate. Because of this reason, there will be inflammation here, rubor tumor calidolar, so swelling in this area will push the prostate up. When we are doing a digital rectal examination, we will not find the prostate at the normal location, but the prostate will be pushed up. So high-lying prostate is a feature of posterior urethral injury or a membranous urethral injury. Perineal urethra or bulbar urethral injuries are commonly seen with the injury or blow to the perineum. For example, loose manhole covers. If somebody falls on the loose manhole like this, then this may cause injury to the perineum. Or maybe bicycle accidents, like during our childhood, especially the boys, when you're racing the bicycle with your friends, especially the shafted bicycle, dande wali cycle jab chalate hain, full speed mein chala rehte hain, you're going in full speed and suddenly the chain slips. So the perineum comes onto that shaft and that causes injury to the perineum. Or if somebody is falling from height, then also there is risk of injury to the perineum. Whether it is anterior urethra or posterior urethral injury, what is going to happen? The urine can leak from the injured side outside, blood can leak outside, and blood can also pass from the external urethral meatus. Plus, there is a possibility that due to injury, there might be some edema at the injury site. Urine may not go out easily. Urine may not leak freely also. So urine may get collected inside the bladder, leading to retention of urine. In both posterior urethra and anterior urethra, we may find retention of urine, hematoma, and blood at the external urethral meatus. The difference is, in posterior urethral injuries, the hematoma will be in the pelvis, while in bulbar urethral injuries, hematoma will be in the perineum. To identify this rupture, we can push the contrast from below. The contrast will be traveling in the urethra above, and wherever there is rupture, the contrast will leak out from the ruptured site. This is called as retrograde urethogram when you are taking the X-ray while the contrast is going inside. In the treatment, if the patient presents with retention of urine, we should not use the Foley's catheter for relieving the retention, because there is a risk while passing the Foley's catheter may come out from the injured site, and you may falsely inflate the balloon, which can widen the urethral rupture. So instead of putting a Foley's catheter, it is better to do a suprapubic cystostomy. This would be the treatment of choice for retention of urine in suspected urethral ruptures. Benign prostatic hyperplasia. The instrument which we use for suprapubic cystostomy is a supracath. This image what you're seeing, this is a retrograde urethogram where the contrast is pushed from here and this contrast is going up in the urethra. Benign prostatic hyperplasia. After 60 years of age, more than 50% of males suffer from BPH. This may be because of increased conversion of testosterone into 1,5-dihydrotestosterone by the enzyme 5-alpha reductase. 1,5-dihydrotestosterone is 20 times more potent than testosterone, so it causes more enlargement of the prostate. Normal weight of prostate is 20 grams. But in BPH, the transitional zone enlarges, which may lead to enlargement of the median lobe and the lateral lobes. Cancer prostate occurs in the peripheral zone, which causes enlargement of the posterior lobe. Okay. So now, when this prostate enlarges, the whole story is related to diameter of the prostatic urethra. Normal diameter is like this, but in BPH, the prostatic urethra becomes narrow. Patient can present with various lower urinary tract symptoms, which we call as LUCs. And these symptoms can be classified according to storage problems or voiding problems. In storage problems, the patient can present with frequency of micturition, maybe more common at night nocturia, sometimes urgency and urgent continence. While voiding symptoms include hesitancy, patient has to wait for some time before the urine starts. Poor flow. The caliber of the urine stream has gone down drastically. When the patient tries to strain, then the lobes of the prostate become even close to each other and the urine stops. That is intermittency. And then patient may present with dribbling of urine. How to approach these old gentlemen? You do a digital rectal examination in the OPD. You can do the ultrasound of the abdomen where you can measure the volume of prostate. On ultrasound, you can also measure PVR, that is post-void residual urine. That means after maturation, how much volume is left inside the bladder. If the value of PVR is more than 100 ml, then it is considered significant. We can also get a blood test done for PSA, that is serum prostate-specific antigen. PSA is a serine protease which is secreted by prostatic epithelium only. It is responsible for liquefaction of semen. And this, since secreted only by the prostate, will be elevated in various pathologies of prostate and not in any other pathology. The normal value of serum PSA is 0 to 4 nanogram per ml. If it is more than 10, it is suspicious of cancer. More than 20 to 35 suggests advanced prostatic cancer. When we have to treat these patients, depends on the patient presentation. If there were only mild symptoms, no complications, then we can treat these patients with medicines. In the medical treatment, we have got two medicines, selective alpha-1 blockers and 5-alpha reductase inhibitor. Selective alpha-1 blockers are considered as a medical treatment of choice because these alpha-1A blockers, they relax the prostatic urethra and improve the urine flow, which is actually the most troublesome problem in BPH patients. While 5-alpha reductase inhibitors like finasteride, dutasteride, they reduce the size of the prostate. Right? Selective alpha-1 blockers like tamsulosin and alfuzosin, they are considered as a medical treatment of choice. However, if the patient has got severe symptoms or maybe some complications of BPH like retention of urine, maybe acute retention, chronic retention of urine, or maybe bilateral hydroureteronephrosis, uremia, PVR more than 100 ml, recurrent urinary tract infection, stones in the bladder, diverticular in the bladder, if these are the complications, then we should not go ahead with the medical treatment because medicines are going to take long time. Patient already has got severe symptoms or complications, we have to provide the relief early. So surgical removal of the prostate would be the best option. And for surgical removal of prostate, the gold standard treatment is TURP, where we do a transurethral resection of prostate. And in this TURP, we are using the irrigation fluids. Irrigation fluid of choice in TURP is 1.5% glycine. We have got other modalities also, like green light laser enucleation of prostate, holmium laser evaporation of prostate. Green light laser has the advantage where bipolar cautery can be used, where normal saline can be used as irrigation fluid. When we are doing this prosthetic surgery, some complications can occur like congestive cardiac failure. This is due to volume overload. During TURP, we are using the fluid, or maybe any endourological procedure, we are using fluid for irrigation. So when you are cutting the prosthetic chips, the veins are getting opened up. So this fluid will get absorbed into the circulation, will increase the volume, circulatory load, and the heart can fail. Another complication, TUR syndrome or water intoxication syndrome. If we are using water as the irrigation fluid, water will get absorbed into the circulation, will cause dilution of important ions like sodium, dilutional hyponatremia, which can lead to altered sensorium. That is the reason why we don't use water. We cannot use normal saline in TURP because in TURP we have to do cautery for resecting the prostatic chips, and sodium chloride ions interfere with electrocauterization. That is the reason why we are going with glycine 1.5%. Dextrose should not be used because it will increase the risk of infections. However, in green light laser enucleation of prostate, where bipolar diathermy can be used, normal saline can be used as irrigation fluid. Apart from this, there can be severe hemorrhage after TURP. Sometimes there may be retrograde ejaculation. Now, if you look at this picture, there is an internal sphincter in the bladder neck, external sphincter in the membranous urethra. When we are doing TURP and resecting the chips at the top of the prostate, we might cause injury to the internal sphincter. If this is gone, then at the time of ejaculation, normally what happens when the ejaculate comes in this prostatic urethra, normally the internal sphincter closes and the external sphincter relaxes, so the ejaculate passes down. But if you damage somebody's internal sphincter, at the time of ejaculation, the ejaculate may go up into the bladder, and this is retrograde ejaculation. If by chance the surgeon injures the internal sphincter as well as the external sphincter, there won't be any control and the patient will present with urinary incontinence. There can be risk of sepsis as well, and sometimes stricture urethra can form. If we move into the groin area and take a look at the hernias, commonest hernia is the inguinal hernia. In case of young males, it is the indirect inguinal hernia. Elderly males, it is the direct inguinal hernia. Femoral hernia is 4 times more common in females. Most common hernia to undergo strangulation is a femoral hernia. If we take a look at the differences between indirect and direct, the anatomy of the inguinal canal, there is a deep inguinal ring, which is a U-shaped defect in the transversalis fascia. There is a superficial inguinal ring, which is a triangular defect in the external oblique aponeurosis medially. The floor of the inguinal canal is formed by the inguinal ligament, and the roof is formed by the conjoint tendon. So now what can happen? In case of males, there is spermatic cord inside, and females, it is the round ligament of uterus. If the intra-abdominal pressure increases and forces the abdominal contents to protrude through the deep inguinal ring, like we are seeing here, it is coming out from the deep inguinal ring. This usually comes in a downward forward medial direction and can drop down into the scrotum. This hernia is lateral to inferior epigastric vessels. These what you're seeing, these are inferior epigastric vessels, the red color. Blue colored hernia is coming through the deep inguinal ring, which is lateral to the inferior epigastric vessels. So indirect inguinal hernia is lateral to inferior epigastric vessels. While direct inguinal hernia protrude directly through the Hasselbeck's triangle in elderly people because of weak transversalis fascia or weak Hasselbeck's triangle here, and this hernia usually comes in a forward direction. So the chances of direct inguinal hernia going into the scrotum are less. But this direct hernia is medial to the inferior epigastric vessel. So landmark to distinguish indirect from direct are the inferior epigastric vessels. Indirect hernia is lateral to inferior epigastric vessels. Direct inguinal hernia is medial to inferior epigastric vessels. If we have to differentiate inguinal from femoral hernias, then inguinal hernias usually present with a bulge of swelling above and medial to the pubic tubercle. Femoral hernias come out through the femoral canal. Here there is the femoral sheath, where there are 3 compartments: the lateral compartment for the femoral artery, intermediate for the femoral vein, and medial for the lymph node, or it is empty, that is the femoral canal. So if the herniation occurs through the femoral canal, that is the femoral hernia. Here is the pubic tubercle, and this acts as a landmark to distinguish inguinal from femoral hernia. Inguinal hernia is present as a bulge above and medial to pubic tubercle, while femoral hernia is present as a bulge below and lateral to the pubic tubercle. There are various other classifications to describe these hernias, like European Hernia Society, wherein we can use various letters like P for primary, that is first time the hernia has occurred; R for recurrent, again and again the hernia is taking place; LMF, L is lateral, that is indirect inguinal; M is medial, that is direct inguinal; F is femoral. We can use the numbers like 1, 2, 3. If we are able to pass one finger into the defect 1, 2 fingers in the defect 2, 3 fingers in the defect 3, and the diameter of one finger is taken as 1.5 centimeters. Niehaus classification is something which is commonly asked. According to this, 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. 1, 2 indirect, 3A direct, 3B both, 3C femoral, 4 recurrent. So 1, 2 are indirect hernia, small and large. 3A is direct hernia. 3B is both indirect as well as direct inguinal hernia. 3C is femoral hernia, and 4 is recurrent hernia. Another classification is based on the content, is based on the clinical presentation. If the hernia is not visible, occult. If it is visible but reducible and positive cuff impulse, that is reducible. If the hernia is having adhesions in the scrotum, we may not be able to reduce it, irreducible. If the neck of the hernia sac is tight, because of which we are not able to put the hernia back, obstructed. If the neck of the hernia sac is too tight, so as to compromise the blood supply of the contents in the hernia, strangulated or maybe incarcerated, which can lead to gangrene, so this would be an emergency. Based on the contents of the hernia, if omentum is coming out in the hernia, then it is omentocele or epitocele, and omentum gives a doughy feel. Enterocele, intestine. Litters, mecals. Amnions, appendix. Rectus is the circumference of the intestine. Medials, when there is W loop of bowel. Sliding, when the organ forms one wall of the hernial sac, most commonly the sigmoid colon, second most commonly the cecum. Pantaloon, double inguinal hernia. Pantaloon is also called as saddle hernia. Cooper's is a double femoral hernia. How to approach these hernia patients? Inguinal hernia is present at the inguinal or inguinoscrotal swelling. First, you do the examination in supine position and check for reducibility. Then you can do the examination in standing position and look for cuff impulse. If you are not able to make out whether it's an indirect hernia, or femoral hernia on clinical examination, then you can use your 3 fingers and do a Siemens test. In this, you block the 3 potential openings from where the hernias come out, like the deep inguinal ring, the Hesselbeck's triangle, and the femoral canal. And now ask the patient to cuff. If you have blocked the 3 openings nicely, nothing will come out. Now you gradually release fingers one by one and see from where the hernia is coming out. If it is coming out from the deep inguinal ring, it is indirect inguinal. If it is coming out from the Hesselbeck's triangle, then it is direct inguinal hernia. And if it is coming out from the femoral canal, then it would be a femoral hernia. The treatment for all the hernias, the aim is same. We have to put the hernial contents back, create a barrier so that the hernia does not come out again. For inguinal hernias, we do hernioplasty, that is tension-free repair. We use a mesh and do a mesh hernioplasty. The mesh can be made of polypropylene or polygelatin. This is mesh repair or tension-free hernioplasty is called as Lichtenstein operation. The mesh should have thin thread and large pores. Earlier we were doing Bessonese, shoulders and Stoppa's operation for these hernias. We can even do laparoscopic surgeries for hernia repairs like TEP and TAPP. TEP is totally extraperitoneal repair and TAPP is transabdominal preperitoneal repair. Nerves which can be injured in open hernia surgery, ilioinguinal nerve being the most common. However, iliohypogastric and genitobranch or genitofemoral nerve can also be injured. Congenital hernia or congenital hydrocele, the story is, during intrauterine life, the pink colored peritoneum that is actually going through the inguinal canal into the scrotum, which may act as a guide for testicular descent also. But before birth, this connection of the peritoneum with the scrotum completely obliterates. If the connection of the peritoneum with the scrotum persists even after birth, then whatever is there inside the peritoneal cavity that can travel through this connection and go into the scrotum. If fluid comes through this connection into the scrotum, that is congenital hydrocele. If omentum or intestine or maybe any other content comes here, that is a congenital hernia. Generally, these congenital hernias which are present right from birth, they usually disappear by 3 years of age. That means this connection spontaneously closes. But if it persists even after 3 years of age, then we simply open the inguinal canal, put this connection back into the abdomen and close the inguinal canal. This is herniotomy. So whether it is congenital hernia or congenital hydrocele, the treatment of choice is herniotomy. And this is usually done after 3 years of age. Femoral hernias, they are more commonly seen in females, elderly females, low weight females. The surgery is what we can do on Lotus and Lockwood and Machiavelli. Umbilical hernias more commonly seen in blacks with equal incidence in males and the females. Generally, they also disappear by 2 years, but if they persist after 2 years, then we have to do repair. In umbilical hernias, there is protrusion of the umbilicus in a forward direction, while in paraumbilical hernias, like this is the umbilical hernia, while this is the paraumbilical hernia. Paraumbilical, the umbilicus does not pop out. The herniation is to the side of the umbilicus. So umbilicus actually dips inside. So umbilicus becomes C-shaped or crescent type. Paraumbilical hernias, more commonly seen in adults, maybe obese individuals, cirrhosis, and the treatment would be anatomical repair. Spigelian hernia, it's something which occurs at the lateral border of rectus abdominis muscle above the arcuate line. It is also called as interparietal hernia. The herniation occurs through the layers of the anterior abdominal wall. The chances of pain are more, the chances of swelling are less, and the treatment would be anatomical repair. There will be increased chances of strangulation in these Spigelian hernia. In the scrotum, the testicular torsion, varicocele, and hydroceles. The testicular torsion is simply rotation of the testis around this, and the most common cause is high investment of tunica vaginalis. If the tunica, the visceral layer and the parietal layer, they are not covering the testis, but there is high investment of tunica, testis becomes unsupported and it can rotate. This is called as if the testis is hanging like a clapper in a bell. This is the bell clapper deformity, which is the most common cause of testicular torsion. Sometimes there can be simple inversion of testis as well. Sudden rise in intra-abdominal pressure, sudden forceful sneezing, coughing can lead to testicular torsion, or maybe separation of the spermatic cord can also cause torsion. If there is testicular torsion, it is also the testicular artery usually which is undergoing the torsion, so the supply to the testis will decrease. Ischemia, gangrene, risk is there. Generally, this testicular torsion occurs between 10 to 20 years of age or maybe 10 to 25 years of age. Patient present with sudden onset of severe pain, with redness, swelling of the scrotum. When we examine, we may find high-lying testis, thick spermatic cord, and absence of cremasteric reflex. Clinical test to differentiate testicular torsion from epididymoiditis is a Prenz test. If we elevate the scrotum and patient feels relief, then it is epididymoiditis. But if you elevate the scrotum and there is no relief, rather pain can worsen, that is testicular torsion. So Prenz sign is positive in epididymoiditis but negative in case of torsion. If there is any doubt, best would be take the patient in the operation theatre and do immediate scrotal exploration. If the patient has come to us early within 12 to 24 hours, we feel that the testis can be viable. When you do the scrotal exploration and if the testis are viable, you derotate the testis, fix the testis, that is orchidopexy. And for whatever reasons, today one testis has undergone torsion. For the same reason, the other testis can undergo torsion later on. So you have to fix the other testis also at this point of time, that is contralateral orchidopexy. However, if on scrotal exploration, if the patient has come to us late after 12-24 hours, if the testes are not viable, if the testes are gangrenous, then we have to remove that gangrenous testis orchidectomy and do a contralateral orchidopexy. Note that inferior vena cava is situated slightly onto the right side, because of which the right renal vein is short and the left renal vein is long. The right testicular vein opens directly into the inferior vena cava. The left testicular vein opens at an angle of 90 degrees in the left renal vein. The horizontal flow of blood in the left renal vein will offer resistance to the blood flow from the left testicular vein into the left renal vein, because of which a back pressure will be there, which may damage the valves in the left testicular vein. And if these valves become incompetent, then the blood will keep falling down, will put more pressure in the spermatic veins and the pampiniform plexus of veins, because of which they will get abnormally dilated and tortuous. Native route of venous drainage from the testis will be the cremasteric vein. Hydrocele is simply a normal collection of fluid within the processus vaginalis. Most common cause is filariasis, common in eastern UP and Bihar. If the swelling is confined within the scrotum, it is vaginal hydrocele. If it extends up to the inguinal canal, it is infantile. If it extends up to the peritoneal cavity, this is communicating or congenital hydrocele. Another type of hydrocele can be encysted hydrocele of the cord, like the pink color suppose is the spermatic cord. Sometimes there may be fluid collection in relation to the spermatic cord, what you're seeing here, or sometimes there is another condition where there is sperm collection in relation to the spermatic cord, which is called a spermatocele. When we examine these patients, we feel one testis, two testis, and this swelling is also giving the third testicular feel. So a three testicular appearance can be seen in spermatocele would be the best answer. If that is not given in the option, then encysted hydrocele of the cord. We can even find hydrocele in Lord's operation can also be done in hydroceles, that is plication of thin wall site in small to medium sized hydroceles. And in case of adults, we have got various perineal operations where we can do Thiersch wiring. We leave a non-absorbable thread all around the anal opening, reduce the prolapse, and then pull the two ends and tighten it. We do not forget to put at least one finger inside the anal opening when we are tying the knot. This is Thiersch wiring. We can do other perineal operations like Elon's and Altemius operation. However, they can be classified into internal, external. Internal, which occurs above the dentate line. External, which occurs below the dentate line. This is painless. This is painful. Internal hemorrhoids are often seen at 3, 7, and 11 o'clock position. We can grade the severity of internal hemorrhoids. If the mass remains inside the anal canal only but it is bleeding, that is grade 1. If at the time of defecation or straining the mass comes out, but after defecation the mass goes back inside, that is grade 2. If the mass comes out on straining or defecation, but it does not go back after defecation, it has to be reposited manually, then it is grade 3. And if it remains permanently outside, that is grade 4. One term, thrombosed external hemorrhoid. If there is external hemorrhoid which is painful, and if suppose the feeding artery develop a thrombus, no supply to this mass, ischemia, severe pain here. But the best part is, since the feeding artery has got a thrombus, no supply, this will fall off automatically in 5 days. This is called as 5 days self-limiting painful disease, thrombosed external hemorrhoid. In these hemorrhoids, the commonest presentation would be bleeding per rectum, because when the heart fecal matter is coming through this area, it will rub the anal mucosa here, may open the vein here, and the bleeding would be like a splash in the pen. This bleeding should be differentiated from bleeding in case of anal fissure. Anal fissure is a laceration in the anal mucosa in the posterior anal wall in midline, above the anal verge, distal to the dentate line, very painful condition. When the heart fecal matter is passing through this area, because of fissure behind, it may leave a line of blood on the posterior surface of stool. So in case of hemorrhoids, bleeding is in the pan, pot में छींटे मिलते हैं खून के. But in anal fissure, bleeding is on the surface of the stool. Fissure में जो पॉटी होती है, उस पे खून लग के आता है. Right. However, we can do the proctoscopy to identify these hemorrhoids. Most common cause of bleeding per rectum, hemorrhoids. In infant, most common cause of bleeding per rectum is intussusception. In a child, it is juvenile polyp. Adults, hemorrhoids, elderly colorectal cancer, or maybe diverticulosis of colon. Most common cause of bleeding per rectum from the right colon. In elderly people, it is angiodysplasia of colon. The treatment for hemorrhoids, for first degree hemorrhoids, we do sclerotherapy. We inject the sclerosing agent like 5% phenol in almond oil at the apex of the hemorrhoidal mass. For second degree hemorrhoids, we can do bending, where a special band applicator is used and the band is left at the base of the hemorrhoid, and this mass will fall off automatically in 5 to 10 days. Rectum, abnormal relation will develop between the anal canal and the skin outside, which is called as fistula in ano. So there may be abnormal connection between the anal canal and the skin, or maybe abnormal connection between the rectum and the skin here. That is fistula in ano. Most common type of fistula is intersphincteric due to infection of the anal gland. A Goodsall's rule helps us in identifying whether the fistulas are straight or curved. If the external opening of the fistula is located anteriorly, then these are direct type. If the external opening is located posteriorly, then they are curved type and they open in midline posteriorly. Investigation of choice is MRI for these fistulas because we want to know the relationship of the fistula with the sphincter muscles. The treatment can be fistulotomy and seton placement. Anal fissure is laceration in the anal canal, which is located in midline posteriorly, just above the anal verge, below the dentate line, at 6 o'clock position. Generally, the patients have got a tight anal opening, that is anal stenosis, and they are constipated. It is an extremely painful condition. Bleeding is like a longitudinal streak of blood on the posterior surface of stool, and many times we find a sentinel skin tag, which is actually guarding a chronic anal fissure. In the treatment of these anal fissures, generally the treatment is conservative. We want to relax the anal opening and make the stool soft. We advise the patient to take 6 baths twice a day, sit in a tub containing lukewarm water, 30 minutes in the morning, 30 minutes in the evening. Hot fomentation may relax the anal sphincter. We advise stool softeners, dietary modifications, avoid constipation, and we can ask the patient to use muscle relaxant creams for local application in the anal canal, like diltiazem and nitroglycerin. Diltiazem has to be applied 2 times in a day, nitroglycerin 3 times in a day, because diltiazem has to be applied only 2 times, that is preferred. Nitroglycerin can cause severe headache, so we avoid this. If by chance this treatment fails, then we have to do surgical treatment, and in surgery, we have surgery to relax the anal opening, but we don't have any surgery to make the stool soft, so we can do a lateral sphincterotomy, which is a surgical treatment of choice. Sometimes we can do internal sphincterotomy. A Lord's 4 to 8 finger anal dilatation was there, but it was a blind procedure, so it has become obsolete. Create a tract in the subcutaneous tissue. From the skin, the hair can migrate into the subcutaneous tissue. Once one hair goes inside, more hairs may come here. This may create a foreign body reaction. Patient can present with some serous discharge or pus discharge coming out. This is what is pilonidal sinus. The treatment, what we can do here, we can do sinogram. We can just put the contrast here, and sinogram can be the investigation of choice. In the treatment, we can excise this area and leave it open, let it heal by granulation tissue, but the chances of recurrence are high. Best results with least recurrence rates are obtained if we remove this area and put some soft tissue cover in this area, that is plastic surgical reconstruction. Thank you for your patience. Thank you for watching the revision of adult surgical problems. Wish you all the best. Take care. Right, beta. So now let us take a look at a quick revision about oncosurgery. First of all, we'll revise the concepts in oncosurgery. That is, just a moment. Right. So in oncosurgery, first we try to understand the concepts once again. Basically, why the cancer occurs, what is the type of cancer, what is the common site of cancer, risk factors, how the cancers can present, how they can spread, how we need to approach the patient depending on the clinical presentation, what investigations we are supposed to do, what should be the first investigation, next investigation, investigation of choice, staging investigation of choice, investigation of choice for metastasis, then what are the different stagings we can do, like ENN stagings, then what should be the treatment for those specific cancers. if we have to understand the whole story, first let us try to take a look at what will be the common type of cancer in some area of the body. So area which require protection in our body, like the skin or maybe area near the natural openings of our body, will require protection. So they'll be lined by squamous epithelium. That is why malignancy near the natural openings of the body will be squamous cell carcinoma. For example, the brown colored story what you're seeing here, that will be the squamous cell carcinoma. Like if you talk about the GI tract, the oral cancers, the esophageal cancers, and the anal cancers will be squamous. Now from the stomach, we know that the lining becomes columnar. So columnar lining will lead to adenocarcinoma. That means stomach, duodenum, jejunum, ileum, the cecum, ascending colon, transverse colon, descending colon, sigmoid colon, rectum. There will be adenocarcinomas. Also inside the gallbladder there is columnar lining, so there will be adenocarcinoma. In the pancreas also we have this columnar lining, so it will be adenocarcinoma. Now, in the urinary tract, if we take a look, the outer portion of the kidney where there are nephrons, there will be adenocarcinoma. So all the pink area is adenocarcinoma. Then the pelvic ileal system, the ureter, the bladder and the urethra, their job is just to transport the urine. So this is transitional epithelium. So right from pelvic ileal system, ureter, bladder, urethra, it is transitional cell carcinoma. However, when we are coming towards the end, that means in the distal urethra, it will be a squamous cell carcinoma. This would be a squamous cell carcinoma. That means kidney cancer can be adenocarcinoma, can be transitional cell carcinoma. Most commonly it is a adenocarcinoma. Bladder cancer, most commonly it will be a transitional cell carcinoma. Prostate is a gland with secretions, so columnar lining adenocarcinoma. Penis is outside, so that will be squamous cell carcinoma. And testicular malignancy, germ cell tumors, the seminomatous, non-seminomatous, so it will be a staminoma, which will be more common. The thyroid gland has got follicles and parafollicular C cells. Malignancy arising from the follicle, which shows finger-like projection, is papillary cancer, while which does not show finger-like projection is a follicular cancer. Most common thyroid cancer is a papillary thyroid cancer. Malignancy from the parafollicular C cells is medullary thyroid cancer. Inside the breast, there are ducts in the lobules, so there can be ductal carcinoma or a lobular carcinoma. Ductal carcinoma, 80 to 85%, and lobular cancers, 15% around. Right? Lobular cancers are usually bilateral and multifocal. Right. Now, what will be the common site of malignancy? The common site of malignancy will be at that particular area where the carcinogens get more time to stay. For example, oral cancer is related to tobacco chewing or tobacco smoking. So those who are chewing the tobacco, they keep the tobacco in the gingivobuccal sulcus or maybe the buccal mucosa. While the smokers, it is the lateral border of tongue, the middle one-third of tongue. Esophageal cancers, most commonly they occur in the middle esophagus, so it is the middle esophagus or the upper two-third of esophagus, while in Western countries the esophageal cancer is related to GERD, reflux. So Western countries common site of esophageal cancer, lower esophagus, and that will be a adenocarcinoma because of Barrett's esophagus. Stomach cancer, most often the culprit is the Helicobacter pylori, so it is the pre-pyloric region which is the common site of cancer, but in Western countries the cancer in the stomach is because of reflux, so it is the cardia of the stomach. While duodenum, jejunum, ileum cancers are rare because continuously peristalsis is there, so the carcinogens cannot stay here. Now in the colorectal area, rectum is the biggest reservoir, followed by the sigmoid colon. So fecal matter stays in the rectosigmoid area for a long period of time. That is why common site of malignancy in the colorectal is the rectosigmoid. And here in 38% of cancers in the rectum and 21% in the sigmoid. That means 59% of colorectal cancers occur in the rectosigmoid area. In the anal canal, cancers are usually squamous cell carcinomas, that means distal to the dentate line, and cancers of the anal verge, they are squamous cell carcinomas. In the gallbladder, it is the fundus of gallbladder, while in pancreas, it is the head of pancreas, which is the common site of malignancy. In urinary tract, whenever urinary mucosa is exposed to more of carcinogens, whether it is related to smoking or maybe other toxins, maybe due to analgesic abuse or maybe due to long-standing kidney stones, commonly the kidney cancers arise from the proximal convoluted tubule in the nephron, while bladder cancers are most commonly seen in the lateral bladder wall and the trigone area, because this would be the area where the carcinogens would be staying for a long period of time. In the prostate, the cancers usually arise from the peripheral zone leading to posterior lobe. In the penis, it is the glans or the prepuce area, usually combination of glans and prepuce. Testis can arise from anywhere inside the testis, and thyroid, most often it is the follicle, that is papillary thyroid cancer. Breast, it is the upper outer quadrant, which is the common site of breast cancer. Least common site is the lower inner quadrant. Now, why these cancers occurs? What can be the risk factors? One common thing, it can be genetic, it can be familial, or it can be related to the lifestyle of the person or the environmental factors. So, in the environmental factors, like oral cancer is related to tobacco chewing or smoking. So, if the carcinogens are staying here for a long period of time, long-term exposure of a carcinogen, that is the key for these cancers. So, when the carcinogens are coming in contact with the mucosa for a long period of time, then the mucosa gets irritated, and they can come when this mucosal cells, they will try to undergo mitotic changes in order to protect themselves. Right. So, the risk factors for oral cancer can be tobacco chewing, smoking. Esophageal cancer can be smoking, alcohol, smoked food. The pathologies like Ecclesia cardia, GERD, the Barrett's esophagus, Zenker's diverticulum. Human papilloma virus is one of the common culprits for cancers near the natural openings in the body, whether it is oral cancer, esophageal cancer, anal cancer, cervical cancer, or maybe distal urethral cancers. Epstein-Barr virus is associated with stomach cancers. Radiation exposure to a particular area can cause chronic irritation and that can lead to cancer. In esophagus, there can be tylosis palmaris plantaris, Plummer-Vinson syndrome, or Patterson-Brown-Kelly syndrome, which is iron deficiency glossitis esophageal web, can be associated with esophageal cancer. The stomach cancers, they again can be linked to smoking alcohol, can be linked to smoked food, can be linked to canned foods which have got high preservatives like nitrosamines, high salt intake, more pickle intake, spicy foods. So all this can lead to stomach cancer. Also, person who is taking less amount of vitamins and antioxidants, the mucosa becomes weak, so it is more vulnerable to be acted upon by carcinogens. So that can be the leading factor for this stomach cancer, or maybe deficiency of vitamin and antioxidant for the entire malignancies. Apart from this, in the stomach, most important culprit is the bacteria, Helicobacter pylori. So that is the most important cause for stomach cancer. But now this bacteria has been eradicated from Western countries. So this is implicated in the etiology of cancers in India or maybe the developing countries, or you can say worldwide. Yes, it is the bacteria. Apart from this, there can be type A gastritis, autoimmune gastritis, or atrophic gastritis. There can be meningitis disease. There can be reflux gastritis. Maybe whenever there is damage to the pylorus, say after gastric surgery. And if you are doing a gastrojejunostomy, then the jejunum contains reflux into the stomach, causing reflux alkaline gastritis, which can cause intestinal metaplasia in the stomach, leading to adenocarcinomas in the stomach. Or stomach cancers can be associated with gastric ulcers, adenomatous polyps, or maybe mutations in the gene like P53, ROA, SMARCA1. Colorectal cancers are usually associated with people who are taking huge amount of red meat, or maybe high animal fat content, or maybe low fiber in diet. So this low fiber will cause constipation. So the carcinogens will stay in the rectosigmoid area for a long period of time. Apart from this, inflammatory bowel diseases like Crohn's and ulcerative, where ulcerative colitis has more risk of colon cancer. Cholecystectomy. If you do a cholecystectomy, then you will not be having the stored bile inside, and if the patient is taking a bulky fatty meal, there may be improper digestion of fat. So there'll be more fat content coming into the rectosigmoid area, leading to increased risk of colon cancer. The adenomatous polyps, familial adenomatous polyposis, this is one of the important risk factors which is associated with Gardner syndrome, Charcot syndrome. There is a hereditary non-polyposis colon cancer, which is the Lynch syndrome. There can be the genetic mutations like APC gene, that is very important in colon cancer, or maybe radiation exposure can lead to colon cancer. The anal cancers, they are linked to human papilloma virus infection. Gallbladder cancers, most often caused by stone inside the gallbladder. If the stone present in the gallbladder for a long period of time, there are chances of malignancy. Porcelain gallbladder, where there is calcium deposition in the gallbladder. The typhoid carriers, where the salmonella causes chronic irritation of the gallbladder mucosa. Adenomatous polyp in the gallbladder more than 10 mm in size can cause gallbladder cancers. Pancreatic cancers, whether it is head of pancreas or periampullary, they are linked to smoking, maybe hereditary, maybe related to chronic pancreatitis and diabetes. The urinary malignancies, kidney and bladder cancer, they are also called as industrial cancer. So smoking, the toxins of the smoke, they are continuously getting excreted to the urinary tract. Urinary mucosa continuously getting exposed to these toxins is the most important risk factor for kidney and bladder cancer. Apart from this, any chemical exposure, if more chemical or dye or contrast agent is coming in the body, it is again getting excreted to the urinary tract. So this is also called as industrial cancer, where people who are working in chemical industries or maybe polish industries or maybe furniture industries, textile industries, they will have more chances of this kidney and bladder cancer. Also, when there is long-term analgesic abuse, long-standing stone disease, that can also lead to cancer. Kidney cancers can be related to von Hippel-Lindau syndrome as well. The prostate cancer's exact reason is not known, but it is considered as part of aging. And probably, since we are using the androgen ablations, so we might think that there might be some relation with the androgen for prostate cancer. Penile cancer, the most important risk factor is poor hygiene. Those individuals who do not clean their glands on a regular basis, there may be smegma persisting, which causes chronic irritation, and that can lead to penile cancer. Human papilloma virus infection, long-standing genital warts, the penile intraepithelial neoplasias like erythroplasia of Currat, Bowen's disease, or maybe smoking, multiple sexual partners, all these can be linked to penile cancer. The testicular cancers most commonly are related to undescended testes. Thyroid malignancies, the papillary thyroid cancer is due to radiation exposure, especially in childhood, or maybe thyroglossal cyst can also lead to this papillary thyroid cancer. Follicular thyroid cancer, most often it is related to long-standing endemic goiters. Breast cancer, familial, genetic, familial, if the mother had cancer, or mother's mother had cancer, mother's sister had cancer, one sister had cancer, or she herself had cancer in one of the breasts, the chances of developing cancer in the other breast are high. It is not only the maternal story, but also on the papa's side, paternal side, that means father's mother or father's sister had breast cancer, then also the chances of cancer in the daughter are high. Genetic factors, BRCA1 and BRCA2 genes, both are implicated in female breast cancer, but only BRCA2 is implicated in male breast cancer. The environmental factors, any female who is exposed to more of estrogens during her lifetime, like early menarche, late menopause, nulliparous, or maybe postmenopausal obese female, hormone replacement therapy after menopause, high estrogen-based OCPs taken for a long period of time, less phytoestrogen consumption in diet, this can be related to breast cancer. However, if there is late menarche, early menopause, or multiparity, or prolonged breastfeeding, or having first child at an early age, or consumption of more phytoestrogens in diet would be protective for breast cancer. Now, how these cancers grow pathologically, they can grow either as an ulcer or maybe some proliferative growth. So as we can see here, there is an ulcer developing here, or there may be a proliferative growth. And based on this, the patients can present. Now, in oral cancer, how the patient is going to come to you, there would be a growth or maybe ulcer in the oral cavity, which is actually the ulcer is not healing, suppose. The esophageal cancers, if there is a polyp growing if there is a polypoidal mass growing into the esophagus, it can create a traffic jam situation in the esophagus, leading to difficulty in swallowing, that is dysphagia. If there is a cancer inside the stomach, this stomach cancer may either bleed, and if it bleeds, it can present with melena, or it can present with hematomasis, it can present with epigastric mass. Obviously, anorexia weight loss is something which we commonly see in all these malignancies. That is because of substances produced by the tumor cells, which can lead to this cachexia story. The colorectal cancers, commonly the rectosigmoid cancers, they most often present with bleeding for rectum. However, if we compare the right colon with the left colon, the right colon cancers often bleed because they are ulcerative, while left colon cancers, they are annular, so they can present with obstruction more often. In rectal cancers, we find tenesmus, alternating bowel habits, alternating constipation and diarrhea, and most often it is the bleeding for rectum. Anal canal cancers can present with the growth coming out from the anal canal, maybe a prolactin cauliflower-like mass coming out of the anal canal. Gallbladder cancers can present either with mass or maybe cholecystitis type of features, or maybe jaundice type of features. Pancreatic cancers most often present with jaundice. And the urinary malignancies, whether it is the kidney or the bladder cancers, we should know the concept that in all the cancers, it is not only the cancer cells which are multiplying, but also the blood vessels are growing. So there are more chances of breaking of these blood vessels in any cancer, and that can lead to bleeding. And this bleed will come out from the natural opening in relation to that particular area. Like if there is bleeding here, then this blood will come out through the external urethral meatus, and we call it as hematuria, which is usually painless. So both kidney and bladder cancers most often present with painless hematuria. Prostate cancers are usually asymptomatic. They present when the cancer is actually advanced, may have gone into the bones like the lumbar vertebra, so patient can come to us with backache. A patient of penile cancer will come to you with some growth or ulcer on the penis and the glans or the prepuce area. The testicular cancers will present with scrotal enlargement or maybe heaviness in the scrotum. Thyroid cancers will present with swelling in the neck, and breast cancers also present with a lump in the breast, which may be associated with indrawing or dimpling of the overlying skin, circumferential retraction of nipple, blood discharge from nipple, or if the cancer cells go into the subdermal lymphatics and block the subdermal lymphatics, there can be puny orange type of appearance. Sometimes there can be lymphedema of the upper limb. If the cancer cells have gone into the axillary lymph nodes, there will be lymphedema. And there can be really Paget's disease, where there is erosion or the nipple may disappear because of intraductal spread of cancer cells through the lactiferous duct. How these cancers can spread? When we talk about carcinomas, which arise from the mucous or epithelium, they can spread locally. They spread more commonly via lymphatics. They can spread through blood as well. Sarcomas, which arise from the connective tissue or the supportive tissue, they spread locally. They do not spread via lymphatics generally. They can spread through blood. Okay. So now, when we talk about the spread, like oral cancer, locally, if the cancer is arising from the mucosa, it will go into the submucosa, into the muscle, and then the adventitia or maybe the adjacent organs. Same thing, the esophageal cancer from mucosa, submucosa, muscle, adventitia, and the adjacent organs. When we go into the abdomen, wherever there is peritoneum, that means inside the peritoneal cavity, all the GIT would be having the peritoneum. So we would be having the serosa. So mucosa, submucosa, muscle, serosa, that is how the stomach cancer can spread, and then to the adjacent organs. Same way, colon cancers or rectal cancers, the upper rectal cancer especially, mucosa, submucosa, muscle, serosa, and lower down, when the lower third of the rectum goes out of the peritoneal reflection, that will not be having the serosa. Okay. The gallbladder cancers can spread from the mucosa, then into the different layers and go into the liver. Pancreatic cancers, they can also spread from the pancreas and involve the duodenum or maybe the stomach. The urinary malignancies like the kidney cancer, they can spread from the kidney, may go into the renal capsule, involve the adrenal gland, the gyrota fascia, and maybe the paranephric fat as well. Bladder cancers arising from the mucosa, going to the submucosal muscle adventitia and then to the adjacent organs. Prostate cancers, locally, they do not spread medially, they spread upwards and laterally. So involvement of seminal vesicles occur early, but involvement of urethra is late. The penile cancers, they are arising at the glans and prepuce, they may involve the corpora cavernosa and then the tunica, and then they can even spread to the scrotum area. The testicular cancers arising from the testis can involve the tunica of the testis, can involve the epididymis, spermatic cord, and maybe the scrotum. The thyroid cancers arising from the follicles can spread to the capsule and may come out of the capsule into the adjacent organs. Breast cancer can spread anteriorly and involve the skin, and posteriorly from the breast they can involve the pectoralis fascia, pectoralis major, pectoralis minor, and the ribs and the intercostal muscles. Involvement of ribs and intercostal muscles is considered as involvement of chest wall. If we consider the spread of all these cancers through lymphatics, depending on what is the lymphatic drainage. So we should know better conceptually that lymph nodes are situated along the supplying vessels. So the entire head and neck malignancies, they would be draining into the cervical lymph nodes. All the upper limb malignancies would be draining into the axillary lymph nodes. The breast malignancies most often draining into the axillary lymph nodes, and second commonly the internal mammary lymph nodes. Thyroid malignancy would also be draining into the neck lymph nodes. If we go inside the, suppose like esophagus, it will be going into the mediastinal lymph nodes, the stomach cancers into the celiac lymph node. So in GIT, we have got foregut, midgut, hindgut. Foregut principal supplied by celiac trunk, so celiac lymph node. Midgut cancers, midgut supplied by the superior mesenteric. So superior mesenteric lymph nodes would be the principal lymph node, and hindgut by the inferior mesenteric. So inferior mesenteric lymph node would be the principal lymph node. The kidney cancers would be going into the regional lymph nodes. The bladder cancers, because now bladder is a pelvic organ, and we know that the abdominal aorta bifurcates into common iliac, and common iliac divides into internal iliac and external iliac. Internal iliac is going towards the pelvis, so pelvic organs are supplied by internal iliac. So pelvic organ malignancies will be going into the internal iliac lymph nodes. So bladder cancer going into the internal iliac lymph nodes. Prostate cancer also goes to the internal iliac lymph nodes. On the way, there is obturator lymph node, so that is usually the first lymph node involved in prostate cancer. Penis, which is outside the perineal area, the skin of the perineum or the scrotum of the penis, or maybe the entire lower limb is drained by the inguinal lymph nodes. So malignancies of the lower limb, penis, scrotum, or the perineal area which is outside, that goes to the inguinal lymph nodes. But the testicular blood supply is directly from the abdominal aorta. Gonadal artery is a direct branch of abdominal aorta, whether it is testicular or ovarian, whether it is right side or left side. These malignancies, testis and ovary, they'll be going to pre-paralytic lymph nodes. The right testicular cancer goes to the interaortocaval lymph nodes, and the left testicular cancer goes to the left paralytic lymph nodes. When we talk about the blood spread of these cancers, then through blood, the cancer will be going into the draining vein, and you have to just see where the draining vein is actually opening. So if we look at almost all the malignancies, these malignancies are ultimately draining into the vena cavas, whether it's the superior vena cava or maybe the inferior vena cava, and both of them are opening into the right atrium to right ventricle to pulmonary artery to lungs. So usually lung is the common site of metastasis for various malignancies in the body. However, when we say GI malignancies, then we know the superior mesenteric artery or the inferior mesenteric artery. If we take a look here, now this part is the midgut, so this will be supplied by superior mesenteric. If there is a cancer here, that will be going into the superior mesenteric lymph node. If we talk about the hindgut area, that is from the distal one third of transverse colon descending colon sigmoid, this area is drained by the inferior mesenteric lymph node. So cancer in this area will be going to inferior mesenteric lymph node and inferior mesenteric vein. Whether it is midgut, superior mesenteric vein, hindgut, inferior mesenteric vein, ultimately they are going into the portal vein. As you can see, the inferior mesenteric vein is opening directly into the splenic vein, while the superior mesenteric vein joins with the splenic vein to form the portal vein. So malignancies of the GI tract draining into the superior inferior mesenteric veins will be going into the liver. So the common site of metastasis for colorectal cancers would be liver. 33% of colorectal cancer patients, by the time they come to us, they present with liver metastasis. The kidney cancers, they would be draining into the inferior vena cava ultimately. That is the right renal vein and the left renal vein. They both open into the inferior vena cava. So inferior vena cava and the right atrium, right ventricle, pulmonary artery, lungs. So lung would be the common site of metastasis. However, we should know that prostate cancer in males and breast cancer in females, they most often go to the bones through the backs and vertebral plexus of veins. They go into the lumbar vertebra most commonly. Other cancers which go into the bones are kidney, bronchus, and thyroid. So you can remember it by PBKBT, and one wonderful mnemonic shared by one of our students, Pakistan Bharat Ka Bhag Tha, right? Pakistan Bhi Bharat Ka Bhag Tha. So that is how we can remember. Pakistan Bharat Ka Bhag Tha, right? So that is how we can remember that what are the common cancers which spread to the bones through blood, right? If we talk about just trying to understand this blood spread, suppose testicular cancer. So you know that the testicular cancer will be ultimately draining into the inferior vena cava. So inferior vena cava is ultimately opening into the right atrium. So lungs would be the common site of metastasis for testicular cancers. And in lung metastasis, whether it's a kidney cancer, testicular cancer, we find rounded opacities that we call as cannonball deposits. So this is how the cancers can spread. Now, how we need to approach these patients, depending on how the patient presents to us. Like oral cancer patient would come to you with some ulcer or growth in the oral cavity, you can take a biopsy. So that would be the investigation of choice. And then to stage the cancers for wherever there is nerve, vessel, and muscle, then MRI gives us better information. The head and neck area and the pelvic area having a lot of muscles. So when we have to do a local staging for these cancers in the head and neck area or the pelvic area, we prefer doing a MRI. Behind the breast, there are pectoralis muscles. So for breast also, we are doing MRI for staging purpose. While if we go into the thorax inside or maybe the abdomen inside, we prefer doing a CCT over the MRI, right, for the local staging. However, for metastasis, we have to do a PET scan for all the cancers. In PET scan, that is positron emission tomography, we use isotope 18-fluorodeoxyglucose, which has a half-life of 120 minutes. This is glucose. This will be rapidly taken up by the mitotic cells in the body. Wherever there is cancer inside the body, if you give glucose isotope, it will be rapidly taken up by the cancer cells. And when you do a whole body CT scan, now we have got PET MRIs also, which have come up. If you are doing a PET MRI, then also you will see those glucose uptake as golden shadows wherever there is a cancer present inside the body. So that is how we can find out whether the cancer has spread to other areas in the body or not. Based on this, we can do a TLM staging. So if we just summarize this concept here, for oral cancer, patient came to you with a growth or ulcer, you took a biopsy, investigation of choice is a biopsy, staging investigation MRI, metastasis PET scan. If we talk about esophageal malignancies, because of a polypoidal mass inside the esophagus, dysphagia, usually first investigation in dysphagia is a barium swallow. When we do barium swallow in esophagus, then we may find a filling defect along with a rectal appearance, and rarely we can find a pulco appearance, which is commonly seen in colon cancer. If we are suspecting cancer in the esophagus, we do upper GI endoscopy and take a biopsy. So investigation of choice is upper GI endoscopy and biopsy. For staging of esophageal cancers, we do CCT, and for metastasis PET scan. If we have to know the depth of tumor invasion, we can do endoscopic ultrasound. Whether it is esophagus, stomach, or maybe colorectal, for depth of tumor, we can do endoscopic ultrasound. Stomach cancers, if the patient presents with melena, first investigation will be stool for occult blood to see whether RBCs are present in this stool or not. If yes, that means there is upper GI bleed, so you do upper GI endoscopy, and if you find a cancer in the stomach, you take a biopsy. So investigation of choice for stomach cancer will be upper GI endoscopy and biopsy. If a stomach cancer patient presents with epigastric mass, then first investigation to be done in any abdominal mass would be ultrasound. And if you see a solid tumor in the stomach on ultrasound, you do upper GI endoscopy and take a biopsy. So investigation of choice is endoscopy, biopsy. For staging, CECT, and for metastasis, PET scan. For depth of tumor, endoscopic ultrasound. The colorectal cancers which often present with bleeding per rectum, we can do a colonoscopy, and it is a whole colonoscopy, because if you do the colonoscopy and suppose you find a cancer in the sigmoid colon, you might feel that your job is done and you may not see the other part of the colon. But never do this, because there are possibilities that even if you found the cancer in the sigmoid colon, you may find cancer in other areas of the colon as well. So a whole colonoscopy has to be done, and if you see a tumor there, you just take a biopsy. Investigation of choice for colorectal cancers would be colonoscopy and biopsy. For staging purpose, for colon cancers we do CCT, but for the rectal cancers, because the rectum is in the pelvic area, so we do MRI for staging of rectal cancers. While for metastasis, for both colorectal, we do a PET scan. Anal canal cancers also, if the patient comes to you with a cauliflower-like prolapsing mass from the anal canal, you can take a direct biopsy. That is the investigation of choice. For local staging, you can do MRI, and for metastasis, you can do a PET scan. For gallbladder cancers, if the patient presents with a mass in the right upper abdomen, do ultrasound first. If there is a solid tumor, do a CECT of the abdomen to see the cancer. Because we cannot take any endoscope inside the gallbladder, so endoscopic biopsy is not possible for gallbladder malignancies. If gallbladder cancer patient presents with jaundice, first investigation will be LFT, then ultrasound, and if you see a tumor in the gallbladder, do a CECT of the abdomen. For pancreatic cancers, head of pancreas, and periampullary cancers, if the patient presents with jaundice, first do LFT, then ultrasound, and if you see a solid tumor in the pancreas, then also ultrasound. You can do a CECT for head of pancreas cancer. You can do a ERCP and take a biopsy from periampullary carcinomas. So investigation of choice for gallbladder cancer would be CCT, carcinoma head of pancreas would be CCT, but for periampullary cancers, it would be ERCP and biopsy. However, now for head of pancreatic cancers in clinical practice, endoscopic ultrasound biopsies are also being routinely done, which might replace the CCT as the investigation of choice for head pancreatic cancers. For staging purpose, we do a CCT, and for metastasis, we do a PET scan. For kidney cancers, patient present with painless hematuria, first we have to do a urine cytology evaluation to look for malignant cells. If we find cancer cells in urine, that means there can be malignancy anywhere in the urinary tract. Most common site of malignancy in the urinary tract would be urinary bladder, because bladder is a big reservoir where carcinogens can stay for a long period. So we suspect a bladder cancer if urine cytology is positive for cancer cells. So we do a cystoscopy to look inside the bladder, but if we don't find a tumor inside the bladder, then we do a CCT to look for kidney malignancy. Again, inside the kidney, if it's adenocarcinoma that is outer part of the kidney, we cannot take any endoscope into that area, so we just do a CCT of the abdomen. For bladder cancers, patient presenting with painless hematuria, first investigation urine cytology for malignant cells. If cancer cells are present in urine, we do a cystoscopy. If you find a tumor inside the bladder on cystoscopy, take a biopsy, that is cystoscopy and biopsy. For staging purpose, bladder cancers, because bladder is in the pelvic area, so we do a MRI. And for metastasis, we can go with a PET scan. For prostate cancer, we do a transrectal ultrasound guided prostatic biopsy. 12 biopsies are taken, and that can give us the diagnosis. So investigation of choice would be prostatic biopsy through the transrectal route. Now perineal routes are also being used for prostatic cancer biopsies. For staging of prostate cancer, again prostate would be in the pelvic area, so we'll be doing a MRI for local staging, and for metastasis, we'll be doing a PET scan. For penile cancer, patient comes to you with a growth on the penis, you can take a direct biopsy, so investigation of choice is biopsy. And for staging, again, there are corpora cavernosa in the penis, the corpora spongiosa, so MRI would be the staging investigation of choice. And for metastasis, it would be PET scan. For testicular malignancies, patient coming to us with scrotal enlargement. Overall, the commonest cause of scrotal enlargement is a hydrocele. Also, we should know that commonest malignancy in a young male is a testicular cancer. So patient coming with scrotal enlargement, first thing what we think of is hydrocele. In the OPD, we do a transillumination. If it is hydrocele, transillumination is positive. But if it is a testicular tumor or cancer, then transillumination is negative. We are tempted to put a needle into the scrotum to see whether there is fluid or not, but never put a needle. It is always better to do ultrasound of the scrotum and then a CECT of the abdomen and scrotum to look for pre and paraortic lymph nodes as well. We do a CECT of the abdomen. For metastasis, we do a PET scan. Thyroid cancers, patient coming to you with swelling in the neck, you do ultrasound guided FNAC, and for staging you can do MRI. For metastasis again the PET scan. For breast cancers, most commonly they present with breast lump. Any patient coming to you with breast lump, the standard protocol is we cannot ignore the breast lumps. We do a triple assessment: C, RP, C clinical, R radiological, P pathological. Clinical, detailed history and examination. Radiological, ultrasound for less than 40 years and mammography for more than 40 years. And pathology, we do a biopsy. So the best investigation of choice would be ultrasound guided needle biopsy from the breast lump. And if it turns out to be cancer, then for staging purpose, since we want to see the pectoralis muscles as well, so we do a MRI. And for metastasis, we do a PET scan. So this is how we are going to approach all these different cancers. Now, once we come to know that okay, this is a cancer and this is how far it is spread, we can do a TNM staging. Like for esophagus, T1 submucosa, T2 muscle, T3 adventitia, and T4 adjacent organs, where T4A is pleura pericardium diaphragm, and T4B is trachea bone aorta. Lymph node staging in esophageal cancer: N1, 1 to 2 lymph nodes, N2, 3 to 6 lymph nodes, and N3, 7 or more than 7 lymph nodes. M1 is metastasis. If we are using a prefix C, that means it is a clinical staging. If we are using a prefix P, that means it is a pathological staging. Clinical staging means before the primary treatment, whatever you are seeing clinically or maybe pre-op investigations, that is the staging. When you have done the surgery, suppose, then you send a specimen to the pathologist, and now the pathologist can measure exactly what it is. So we can use the prefix P if it is a pathological staging. Simple difference to understand, like a breast cancer, suppose on clinical examination or on ultrasound or maybe on MRI, you found that the tumor is 1 centimeter in size, so you are writing it as T1. But when the surgery was done for this breast, and suppose the entire breast was removed, and pathologist was looking at the entire breast, when he noticed that lump and he measured that lump with the scale, suppose it came out to be 3 centimeters. So it will make the stage T2, right? So that is how there is a difference between clinical and pathological staging. If we are using the prefix Y, that means a neoadjuvant therapy has been given to the patient, and because of this neoadjuvant therapy, there might be regression of the tumor, which may downstage the tumor. So now after giving neoadjuvant therapy, the staging may change, and then we use the prefix Y. We use some suffixes also, like TX. X means cannot be assessed. We use the suffix 0. 0 means we have assessed and there is no evidence of tumor. we use the suffix is. Is is in situ. In situ means when the cancer has not breached the basement membrane, right? So we can use these different prefixes and suffixes. So we were talking about esophageal cancer staging. Now we'll just try to differentiate the esophagus, stomach, and colon cancer staging. T1, esophagus, submucosa, stomach, submucosa, colon, submucosa. T2, all three, muscle. T3, esophagus, it is adventitia, stomach, it is subserosa, colon, it is subserosa. T4, in esophagus, it is adjacent organs. In stomach, T4A, penetrate the serosa or perforate the serosa, and T4B is adjacent organs. In colon cancer, T4 is adjacent organs. In esophagus, T4A is pleura, pericardium, diaphragm, and T4B is trachea, bone, aorta. Lymph node staging. N1 for esophagus, stomach is same, 1 to 3 lymph nodes, but colon it is 1 to 2 lymph nodes. N2, esophagus, stomach it is same, sorry. Lymph node staging for esophagus and stomach it is 1 to 2 lymph nodes, and colon it is 1 to 3 lymph nodes. N2 for esophagus and stomach it is 3 to 6 lymph nodes, but for colon it is 4 or more than 4 lymph nodes. N3 in esophagus and stomach it is 7 or more than 7 lymph nodes. In stomach, N3A is 7 to 15 lymph nodes, N3B is more than 15 lymph nodes. M1 in all the three is distant metastasis. Right? In breast cancer, T1 less than 2, T2 2 to 5, T3 more than 5, T4 any size, T4A chest wall, T4B skin, T4C both, T4D inflammatory cancer. Like QD orange is skin involvement. If the skin involvement is less than 1/3 of the surface of the breast or up to 1/3 of the surface of the breast, that is T4B. But if it is involving more than 1/3 surface area of the breast, then it becomes T4D. Lymph node staging in breast cancer, N1. In breast cancer, lymph node staging is only for the ipsilateral, that is same side lymph nodes. If the opposite lymph nodes are involved, then it is not through lymphatics, it is through blood, so it will be termed as M1 metastasis. Okay, so lymph node staging in breast cancer is for same side lymph nodes, ipsilateral lymph nodes. N1 mobile axillary, N2A fixed axillary, N2B internal memory, N3A apical and axillary, N3B axillary and internal memory, and N3C supraclavicular lymph nodes. M1 is distant metastasis. Now when we summarize the treatment of all these cancers, we have got 5 options in the treatment: surgery, chemo, radio, hormonal, and targeted therapy. Surgery is usually the mainstay of treatment in these different cancers. When we are doing surgery, we have to remove the tumor along with adequate margin so that there is no possibility of leaving residual cancer cells behind. In chemotherapy, we are giving cytotoxic drugs, anti-cancer drugs. These anti-cancer drugs or medicines, they not only destroy the cancer cells but also destroy the normal cells. So we have to be very careful in using this chemotherapy. We have to weigh the advantages and disadvantages. If the advantages are more, then we go ahead with chemotherapy. Radiotherapy is giving the radiation. So that is going to give us local control of the cancer. Those cancers who have got a hormonal etiology like prostate and breast cancer, there we can use the hormonal therapy. Like in prostate cancer, we use anti-androgens or androgen ablation. In breast cancers, anti-estrogens, right, or estrogen ablation. Targeted therapy, because of the researches and advancements, now we are able to know the molecular factors or the growth factors which are responsible for the cancer, so we can target those factors also and we can give some therapy against that. Like if HER2/neu gene is positive in any cancer, like breast cancer or maybe stomach cancer, then we give targeted therapy against HER2/neu, that is trastuzumab or Herceptin. So this is the overall summary in the treatment of these different malignancies. Now we'll take a look one by one at all these cancers. So in oral cancer, most common it is squamous cell carcinoma. Most common site in India or worldwide it is gingivobuccal sulcus or the buccal mucosa, but in Western countries it is the lateral part of the tongue, middle 1/3. Risk factor is tobacco chewing. Esophageal cancer, it's most commonly squamous cell carcinoma, more often in the upper 2/3, that is the middle 1/3. In Western countries it is adenocarcinoma, which is in the lower third of the esophagus. Risk factors for esophageal cancer like smoking, alcohol, smoked food, betel nut liquid, GRD, Barrett's, Ecclesia, Zenkus, human papillomavirus, radiation, tylosis, Plummer-Vinson syndrome, or Peterson-Brown-Kelly syndrome, iron deficiency, glossitis, esophageal wedge, commonly seen in middle-aged females, leading to squamous cell carcinoma in the upper esophagus, that is in the post-cricoid region. Pathological esophageal cancers can grow as a polyp, leading to dysphagia, which is initially for solids and gradually for both solids and liquids. Whenever there is a traffic jam in the esophagus, there will always be a risk of regurgitation, aspiration, and pulmonary complications. Esophageal cancer patient developing hoarseness of voice is because the cancer has gone and involved the recurrent laryngeal nerve. There can be anorexia, weight loss as well. If the patient comes with dysphagia, we do a barium swallow, and on barium swallow we can find a filling defect, and we can find a rat tail appearance. Right, apple core appearance can also be seen in esophageal cancer, but most often it is seen in colon cancer. This is the apple core appearance. This is very many picture in colon cancer. Right. If we are suspecting esophageal cancer, then we do upper GI endoscopy and take a biopsy from this tumor. Make the diagnosis. For staging, we do CCT of the thorax. For depth of tumor, endoscopic ultrasound. For metastasis, we do PET scan or positron emission tomography, where we use the isotope fluorodeoxyglucose, 18-fluorodeoxyglucose, having half-life of 120 minutes. Staging is the TNM staging. T1 submucosa, T2 muscle, T3 adventitia, T4 adjacent organs, T4A pleura, pericardium, diaphragm, T4B trachea, bone, aorta. Prefixes used: C for clinical staging and P for pathological staging. Lymph node staging: N1 is 1 to 2, N2 3 to 6, N3 7 or more than 7. M1 is metastasis. Tx means we cannot assess the tumor. T0 when there is no evidence of tumor, and TIS is carcinoma in situ. R0 means no residual tumor. That means if the surgeon has done the surgery, after surgery, if there is no tumor left inside the body, that we call as R0 resection. The mainstay of treatment for esophageal cancer would be surgery, where we have to take adequate margin around the cancer. Proximal margin taken is 10 centimeters, distal is 5 centimeters, so we'll end up doing a total esophagectomy with esophageal reconstruction. We commonly use stomach for esophageal reconstructions. This is a I-value operation which is done by transthoracic approach. Early complication can be anastomotic leak, which can lead to pulmonary complications. Here we can see how the stomach is pulled up as a tube and anastomosed with whatever esophagus is left. Late complication of the surgery can be a stricture at the anastomotic site. Chemotherapy, what we can use in esophageal cancer is 5-fluorouracil and cisplatin. Any therapy which is given before the main therapy, that is neoadjuvant, and therapy given after the main therapy is adjuvant therapy. Stomach cancer, most often it is adenocarcinoma, most commonly in the prepyloric region, but in Western countries it is the cardia of the stomach. Both are adenocarcinomas associated with smoking, alcohol, salt, pickles, smoked food, canned food, decreased vitamins, antioxidants, Helicobacter pylori, Epstein-Barr virus, autoimmune atrophic gastritis, Meniere's disease, reflux gastritis, gastrical adenomatous polyps, or maybe mutation in P53 SMARCA1 ROA. Pathologically, or they can present either as a growth or an ulcer. If they involve the entire stomach, a diffuse gastric cancer can present with a leather bottle stomach. This leather bottle stomach is also called as Linitis plastica. We can classify the stomach cancers as early and advanced. Early is the Japanese classification, advanced is the Borneo classification. The difference between early and advanced is if muscle is involved, then it is advanced, while involvement of mucosa, submucosa is early. Mucosa, submucosa muscle is advanced, irrespective of lymph node involvement. A molecular classification for stomach cancers, it can be Epstein-Barr virus positive, microsatellite instability, genomically stable, or chromosomal instability. Clinically, patient can present with malignant hematemesis, epigastric mass, anorexia, weight loss, can spread to lymphatics, and we can find a cross-use sign in pancreatic cancer, stomach cancers, wherein the tumor produces some substances which changes the property of platelets, so the platelets start aggregating at different places in the vein, and we can find a migratory thrombophlebitis, which is called as cross-use sign in cancers. Most commonly, this is seen in pancreatic cancers. Stomach cancer spread locally. If it is a proximal stomach cancer, from mucosa, submucosa muscle serosa, it can go into the spleen. For distal gastric cancers, mucosa, submucosa muscle serosa into the pancreas. Through lymphatics, principal lymph node is celiac lymph node, and through blood, it most often goes to the liver. Stomach cancers can even spread transperitoneally, though ovarian cancers more often spread directly into the peritoneal cavity. But if it's ovarian cancer or maybe a stomach cancer, if it is breaking into the peritoneal cavity, the tumor cells getting collected on the peritoneal surface called as peritoneal seedlings or peritoneal deposits. The tumor cells getting collected around the umbilicus, this is the cister Mary Joseph nodule. Tumor cells getting collected on the functional ovary, this is Krukenberg tumor, and tumor cells getting collected on the anterior rectal wall, this is Blummer's shelf. This is how we can see periumbilical tumor deposits. When this cancer spread to the lymph nodes, enlarged left supraclavicular lymph node is called as Virchow's node or Royce's sign. Enlarged axillary lymph node is Irish node. Patient can present with melena, hematemesis, mass. If the patient presents with melena, stool for occult blood should be the first investigation. If it is positive, do upper GI endoscopy. If you find a tumor, take a biopsy. If the patient presents with epigastric mass, first do ultrasound. And if you find a mass in the stomach, do an endoscopy and take a biopsy. So investigation of choice, endoscopy, biopsy, staging, CCT, depth of tumor, endoscopic ultrasound, and for depth for distant metastasis, PET scan, where we use 18-fluorodeoxyglucose, half-life 120 minutes. T1 submucosa, T2 muscle, T3 subserosa, T4 perforate the serosa, T4 be adjacent organs, N1, 1 to 2, N2, 3 to 6, N3, A, 7 to 15, N3B more than 15 lymph nodes, and M1 is distant metastasis. Best treatment is surgery, where we remove the tumor along with a margin of 5 centimeters. If it is a proximal gastric cancer, then when we take a 5 centimeter margin, we actually land up in removing the entire stomach. Also, in proximal stomach cancers, because there are short gastric vessels which are supplying the stomach, there may be involvement of lymph nodes on the short gastric vessel, and some of these lymph nodes may be embedded into the hilum of the spleen. If the stomach cancer has gone into these lymph nodes, then unless and until we remove the spleen, we will not be able to remove these hilar splenic lymph nodes. So when we are doing a total gastrectomy, we also do a splenectomy to achieve adequate lymphatic clearance in proximal stomach cancers. However, if the cancer is in the distal part of the stomach and we take a 5 centimeter margin, we still can preserve some part of the stomach. So there is no point in doing a total gastrectomy. We just do a partial or subtotal gastrectomy for proximal stomach cancers. The colorectal cancers, as we can see here, the most common site is the rectum, followed by the sigmoid colon. Combined, the rectosigmoid is the commonest site, followed by the cecum. Most commonly, it is adenocarcinoma. The risk factors: increased consumption of red meat, animal fat, less fiber, less vitamins, antioxidant, smoking, alcohol, adenomatous polyps, familial adenomatous polyposis, Gardner-Turcot syndrome, Lynch syndrome, hereditary non-polyposis, colorectal cancer, inflammatory bowel disease, ulcerative colitis more than Crohn's, radiation exposure, APC gene mutation, or cholecystectomy. This is familial adenomatous polyposis, multiple adenomatous polyps, more than 100 adenomatous polyps in the colon. Diagnostic of FAP. This is autosomal dominant associated with APC gene mutation. In 50% of these patients, there is congenital hypertrophy of retinal pigment epithelium as well, and more than 100 adenomatous polyps is diagnostic of familial adenomatous polyposis. Gardner syndrome is when FAP is associated with epidermoid cyst or desmoid tumors. Turcot syndrome, when FAP is associated with brain tumors, there will be high risk of malignancy with this FAP. Another condition is familial hematomatous polyposis, which is Peutz-Jeghers syndrome, where there are multiple juvenile polyps in the intestine associated with melanin pigmentation of the lips, or maybe the buccal mucosa, or maybe the hands and the forearms. Pathologically, right colon cancers are ulcerative, so they present with bleeding. Left colon cancers are annular, so they present with obstruction. Rectal cancer most commonly present with bleeding per rectum, alternating constipation, diarrhea, tenesmus type of thing, and 1/3 of patients present with liver metastasis. Bleeding per rectum, elderly people, colonoscopy and biopsy, whole colonoscopy. You can see a tumor like this and you can just take a biopsy from this tumor. Barium enema shows apple core appearance in colon cancer. For staging of colon cancer, CCT. Staging of rectal cancer, MRI. Depth of tumor, endoscopic ultrasound, distant metastasis, PET scan. We use 18-fluorodeoxyglucose with half-life 120 minutes. T1 submucosa, T2 muscle, T3 subserosa, T4 adjacent organs, N1, 1 to 3 lymph nodes, N2, 4 or more than 4 lymph nodes, M1 distant metastasis. In the treatment for colon cancers, we have to remove the tumor with a 5 centimeter margin. For rectal cancer, 2 centimeter margin. In rectal cancer distal margin, even 1 centimeter can be acceptable. For colon cancers, if it is the right colon cancers, we do a right hemicolectomy, remove the right half of the colon, connect the ileum with the transverse colon, that is the iliotransverse anastomosis. If it is the left colon cancers, you remove the left colon, left half of the colon, that is the left hemicolectomy. Right. We can even do right extended hemicolectomy if the tumor is more towards the hepatic flexure of colon. While for anal canal cancers, we can do anterior resection, low anterior resection, and if the cancer is situated in the lower part of the rectum, which is close to the anal sphincter, if the cancer, suppose this is the anal canal and this is the lower rectal cancer, if you have to take a distal margin of 2 centimeters, we might be damaging the anal sphincter. So in these cases, we try doing an endoscopic circular stapler, sphincter preserving surgery. If we are not able to preserve the sphincter, then we have to remove the rectum and anal canal. So for that, we do a abdominoperineal resection of the rectum and the anal canal. We are just left with the sigmoid colon inside. There is no rectum anal canal in this patient. So we bring the sigmoid colon out on the abdominal wall as a permanent sigmoid colostomy, so that now the fecal matter will be passing permanently through the sigmoid colon here on the abdominal wall. We can just put a bag on this and patient keeps on emptying that bag. Right. Carcinoma anal canal is a squamous cell carcinoma associated with human papillomavirus. The treatment of choice for carcinoma anal canal is a combined chemo and radiotherapy, which we call as Negro regime. If chemo and radiotherapy fail, then we do abdominoperineal resection. For carcinoma of anal verge, that means which is at the anal opening, which is not in the anal canal, it is at the anal opening, we do a wide excision. Chemotherapy in colorectal cancer is oxaliplatin. Targeted therapy in rectal cancer is cetuximab. The tumor marker for colon cancer is carcinoembryonic antigen. Gallbladder malignancy, most often at the fundus of the gallbladder, it's adenocarcinoma, can be associated with gallstones, porcelain gallbladder, adenomatous polyp more than 10 mm or typhoid carriers, can present with cholecystitis, mass or jaundice, and the investigation of choice is CCT of the abdomen, and the treatment will be removal of the gallbladder with the lymph nodes, that is radical cholecystectomy. For pancreatic cancers, most commonly they are adenocarcinomas, most often in the head of the pancreas. However, second most commonly, they may be in the periampullary region here, maybe terminal CVD, terminal pancreatic duct, ampullary mucosa, duodenal mucosa close to the ampulla. Out of these two, head pancreatic are more common, but they present late because they will take time to cause traffic jam of the CVD. But periampullary carcinomas, which are less common, they will present to us early because they can create a traffic jam in the CVD early. Since they present early, they can be diagnosed early and treated treated early. So periampullary cancers will have a better prognosis than head pancreatic cancers. Most commonly, they are associated with smoking, chronic pancreatitis, hereditary, and diabetes. Most commonly, they present with jaundice. In head pancreatic cancer, the jaundice is progressive type because once the head pancreatic cancer starts obstructing the CVD, it will continue to obstruct unless until you remove the cancer. While in periampullary cancers, jaundice occurs early and it can be waxing waning type. That means increasing, decreasing type, because if there is a periampullary carcinoma, there is a possibility that when there is obstruction here, proximal people are dilated, so the proximal muscles may contract forcefully and they may try to throw the tumor cells out into the duodenum. If the tumor cells are shed off into the duodenum, the traffic jam will be cleared, bile will pass down, and the jaundice will disappear. Again, this tumor will start growing. Again, the patient will have jaundice. Again, the proximal pressure may throw this tumor into the duodenum, and traffic jam clears off, bile passes down, jaundice disappears. So we find a waxing waning type of jaundice. In pancreatic cancers, there is marked weight loss, and in Courvoisier's law in pancreatic cancers, they say that gallbladder should always be distended whenever there is a traffic jam in the CVD, whether it is because of the stone or maybe because of the cancer. But if it is a stone causing obstruction of the CVD, there is a possibility that this stone might have slipped from the gallbladder. And if the patient was having gallstones for a long period of time, there is a rare possibility that these gallstones in the gallbladder may have caused chronic fibrosis of the gallbladder, where the gallbladder can become narrow and contracted. So Courvoisier said that gallbladder is always palpable if CVD obstruction is due to cancer, but gallbladder may not always be palpable if CVD obstruction is due to a stone. For carcinoma head of the pancreas, we do CECT. We can even do endoscopic ultrasound guided biopsies. For periampullary cancers, we are doing ERCP and biopsy. Tumor marker for pancreatic cancer is CA19-9. If CA19-9 is not given in the option, then go for carcinoembryonic antigen. The treatment for pancreatic cancers are not responding to chemotherapy or radiotherapy usually, so the mainstay is against surgery, and in surgery we have to remove the tumor with a nice margin. So we can remove this shaded area, like we remove the head of the pancreas, the duodenum, the common hepatic duct, the common bile duct, and the gallbladder. Once we remove this head of the pancreas, duodenum, common bile duct, and the gallbladder, then we'll be left with the body of the pancreas with the pancreatic duct, the pylorus of the stomach, and the common hepatic duct here. So we just connect the jejunum with all three. We do a pancreaticojejunostomy, hepaticojejunostomy, and duodenojejunostomy. So this is the pylorus preserving pancreaticoduodenectomy, which is the treatment of choice now. Earlier, we were not able to preserve the pylorus, so that was a classical Whipple's operation. When we removed the head of the pancreas, the duodenum along with the pylorus, the common bile duct, and the gallbladder. So we were connecting the jejunum with the pancreatic duct, that is pancreaticojejunostomy, the common hepatic duct with the jejunum hepaticojejunostomy, and the stomach with the jejunum gastrojejunostomy. This is a triple bypass or classical Whipple's operation, but now it has been modified because we can save the pylorus, and that is the pylorus preserving pancreaticoduodenectomy. The gastrointestinal stromal tumor. Now, stroma is the connective tissue. It can occur from any part of GIT, most commonly the stomach, second most commonly the ileum. The gist does not arise from the mucosa, it arises from the interstitial cell of Cajal. It is associated with c-KIT gene mutation. There is overexpression of CD117. Risk of malignancy increases if the size is more than 5 centimeters or there are more than 50 microscopic per high power field. If it becomes malignant, it will be a sarcoma which does not spread commonly by lymphatics. So the treatment would be a wide local excision like partial gastrectomy. Lymph node removal is not required in the treatment of gist. If gist is massive, malignant or recurrent type, then we give imatinib or Gleevec, which can be given for the entire life. Gastrinoma. Gastrinoma is also known as Zollinger-Ellison syndrome. As the name implies, gastrin producing tumor. This tumor can occur in the gastrinoma triangle, which is bounded superiorly by the junction of cystic duct and the common bile duct, inferiorly by the junction of the second and third part of duodenum, and medially by the junction of neck and body of the pancreas. These tumors can occur either in the side of pancreas area or maybe in the duodenum area, and they keep on producing the gastrin, and gastrin will keep on stimulating the parietal cell to produce more and more acid. So there will be very high acid production in these gastrinomas. These can be autosomal dominant associated with MEN1 syndrome. Because of huge amount of acid secretion, there can be severe GI ulcerations, and the patient will be presenting with abdominal pain. This is just an important note about the difference between Callett's triangle and hepatocystic triangle or hepatobiliary triangle. The hepatocystic triangle or the hepatobiliary triangle is used by the surgeons for laparoscopic cholecystectomy, which is bounded superiorly by the inferior surface of liver, laterally by the body of gallbladder and the cystic duct, and medially by the common hepatic duct. While Callett's triangle, its superior boundary is different. Superiorly it is the cystic artery, laterally by the body of gallbladder and cystic duct, and medially by the common hepatic duct. Content of hepatocystic or hepatobiliary triangle would be the cystic artery and the cystic lymph node of Lund. While content of Callett's triangle will be empty. Sometimes, if the cystic lymph node of Lund is present on the inferior surface of cystic artery, then that can form the content of this Callett's triangle. This gastrinoma can be associated with non-beta islet cell tumor of the pancreas. We can do various lab investigations or blood tests for gastrinoma, like we can give injection of secretin, which is a secretin provocative test, if there is rise in serum gastrin more than 110 picogram per ml, or if the serum gastrin levels are more than 200 to 1000 picogram per ml, or if the basal acid output is more than 15 millicurie per hour, or if we give a pentagastrin injection and there is no marked response in acid secretion, then we feel that this can be a case of gastrinoma. Radiologically, CCT of the abdomen, endoscopic ultrasound would be better investigations to look for this gastrinoma, and the treatment should be aggressive PPIs and removal of the tumor. Carcinoma tumor or Argenta phenomena. This arises from the Argenta tissue, the Kulczycki cells in the crypts of liver cone. Most common site is the small intestine in GIT. They can arise from the rectum colon or the appendix. More commonly seen in females. Grossly, they are hard yellow. Microscopically, there are small cells which are arranged in nests. Immunohistochemically positive for chromogranin B. Clinically, the tumor produces certain substances like serotonin and histamine type, where there can be sinuses, flushing, diarrhea, borborygmi, asthmatic attacks. Sometimes pulmonary and tricuspid stenosis can be associated. They rarely metastasize. Only 4% give rise to metastasis. They may secrete 5-hydroxytryptamine serotonin, 5-hydroxyindolestic acid in urine, and the plasma marker is chromogranin A. If we talk about treatment for carcinoma tumor of the appendix, we have got two options. Either we can simply do an appendicectomy, or we'll end up doing a right hemicolectomy. If suppose the tumor is small, say 2 centimeter, less than 2 centimeter, no involvement of cecal wall and no involvement of lymph nodes, then we can do appendicectomy. But if the tumor is big, 2 or more than 2 centimeter in size, cecal wall is getting involved and the lymph nodes are getting involved, then we do a right hemicolectomy for these carcinoma tumors of appendix. For urology cancers, kidney tumors, Wilms tumor or nephroblastoma, commonly seen in small babies less than 5 years of age, due to inactivation of Wilms tumor suppressor gene. If there is inactivation of WT1, that is Weger and Dennis-Reich syndrome. Inactivation of WT2 is back with Wiedemann syndrome. Most commonly, Wilms tumor is seen at the upper pole of the kidney, presents with abdominal mass, pyrexia or hematuria. CCT abdomen would be the investigation of choice, and the treatment would be surgery with chemotherapy. Even radiotherapy can be used in the treatment of Wilms tumor, and the surgery generally done is radical nephrectomy. Wilms tumor is a mixed tumor having both epithelial and connective tissue elements. adult kidney cancer, hypernephrom or renal cell carcinoma. Most commonly it is adenocarcinoma arising from the proximal convoluted tubular epithelium. Most commonly it is a clear cell type. Kidney and bladder cancers are known as industrial cancers. The most important risk factor is smoking. However, various dyes, chemicals, contrast like aniline dyes, naphthalene, benzidine, azo dyes, long-term use of analgesic, long-term stone disease, von Hippel-Lindau syndrome can be associated with kidney cancer. Most often present with painless hematuria, but can present with pain and mass in the lumbar region whenever the kidney gets enlarged because there is fluid inside the kidney, and any mass, solid mass with fluid inside, may be palpable. In left kidney cancers, we can even find left-sided varicoceles. For example, if it is the right kidney cancer and goes into the right renal vein, there is no traffic jam to the right testicular vein, so no varicocele. But if it is the left kidney cancer, left renal vein, then the left testicular vein, there is a traffic jam, because of which there will be pooling of blood in the left testicular vein, spermatic vein, and campaniform plexus of veins, leading to left-sided varicocele. So left kidney cancers can lead to left-sided varicoceles. The kidney cancer can produce certain substances. The tumor produces certain substances which can be associated with paraneoplastic syndromes like hypercalcemia, erythrocytosis, and raised DSR. First investigation for painless hematuria will be urine cytology to rule out cancer cells. If urine cytology is positive for cancer, the first thought which comes to our mind is we are dealing with a bladder cancer, so we do a cystoscopy. If we don't find a tumor on cystoscopy, then we suspect it's a kidney cancer, so we do a CCT of the abdomen, which is the investigation of choice. In the treatment, kidney cancers do not respond to chemo or radiotherapy, so surgery is the only treatment. Now the decision whether to do a partial nephrectomy or total nephrectomy or radical nephrectomy depends on. If the tumor is small in size, suppose it is less than 4 cm in size, there is no need to remove the entire kidney, we can do a partial nephrectomy. We can even do a partial nephrectomy if the tumor size is between 4 to 7 centimeters. That means 4 to less than 7 centimeters. In selected cases, we can do a partial nephrectomy. However, if it is a bilateral kidney cancer, then also we'll have to do a partial nephrectomy because we have to preserve some nephrons inside the patient. If the patient is having only one functional kidney, then whatever is the tumor size, we try to remove the tumor with a margin, but we also try to preserve some nephrons, so we do a partial nephrectomy. If the patient is having compromised renal function, then also we try to preserve as many nephrons as possible, so we proceed with a partial nephrectomy. However, in other cases, we do a radical nephrectomy. Like this is a specimen of radical nephrectomy where this was the tumor, as you can see in this picture. We have removed this kidney along with the lymph nodes and the surrounding fat and fascia. We can also try immunotherapy with BCG in these kidney cancers. Even vaccine trials are going on. Bladder cancers, most commonly they are transitional cell carcinomas. However, squamous cell carcinomas can occur inside the bladder. They may be because of schistosomiasis, bilharziasis. Adenocarcinoma of the urinary bladder is seen at the dome or fundus of urinary bladder, like in congenital bladder divertical, which is in midline anterior superiorly. Most common site of transitional cell carcinomas in the bladder is the lateral bladder wall and the trigone, associated with smoking, dyes, and chemicals. Pathologically, we can classify the bladder cancers into 3 categories: the non-muscle invasive, which is the most common, muscle invasive, and carcinoma in situ. For example, if this blue color is the mucosa, pink the submucosa, and brown the muscle. So if there is a cancer in the bladder which is confined to the mucosa and the submucosa, this is non-muscle invasive. While the yellow color, what you're seeing here, which has gone into the muscle, this is the muscle invasive. We can even find flat, multicentric malignancies inside the bladder. These are carcinoma in situs. Most common out of these 3 types is a non-muscle invasive cancer. Most often, these patients of bladder cancer, they present with painless hematuria. And first investigation in painless hematuria would be urine cytology to look for malignant cells. If it is positive, you start thinking that we are dealing with bladder cancer, so you do a cystoscopy. If you see a tumor on cystoscopy, you can take a biopsy. Staging investigation for bladder cancer would be MRI. As we know in the pelvic area, whether it is rectal cancer, prostate cancer, penile cancer, anal canal cancer, we are doing MRI. Even for head and neck area, we are doing MRI. Even for breast cancer, because of the pectoralis muscles, we are doing MRI as the staging investigation. In the treatment, again, surgery remains the mainstay of treatment. For non-muscle invasive, it is easy to do a transurethral resection of the bladder tumor. And once we resect the tumor, after this, we put the mitomycin C inside the bladder. That is intravesical chemotherapy with mitomycin C. For muscle invasive bladder cancers, these are invasive cancers. Either we can give chemo and radio as a treatment, but more preferred is a radical cystectomy, where we remove the entire urinary bladder. Usually we call it a cystoprostatectomy. Once you remove the urinary bladder, then you can either create a new bladder using ileum, or if new bladder cannot be created, then you have to do urinary diversion, divert both the ureters in the ileal pouch or maybe the colonic pouch, that is ileal conduit or colonic conduit. Right. We can also use intravesical immunotherapy with BCG in these cases. Prostate cancer is the commonest cancer in elderly males. 70% of males after 80 years of age suffer from prostate cancer. It is believed to be a part of aging. It is a very, very slow growing cancer. Cancer can unpick lung prostate cancer. No known risk factors, but androgens might be playing some role. Usually patients are asymptomatic. They come to us with low backache when the cancer is already spread. Prostate cancer occurs in the peripheral zone, causes enlargement of the posterior lobe. It is an adenocarcinoma. Locally, the prostate cancer spread upwards and laterally, so involvement of seminal vesicles occur early, but involvement of urethra is late. Through lymphatics, it goes to the obturator lymph nodes and then the internal iliac lymph nodes, and through blood, it goes most commonly to the lumbar vertebra through what backs and vertebral plexus of veins. Bony metastasis in these androgen estrogen dependent cancers are osteoblastic, that means associated with new bone formation, while bony metastasis in other cancers would be breaking the bone, osteoclastic. Bony metastasis are more common in PBK, BT, Pakistan, Bharat ka bhag tha, P for prostate, B for breast, K kidney, B bronchus, T thyroid. This is how the bony metastasis can look like. These rounded shadows, what you're seeing, this is how the bony metastasis looks like. This is the bony metastasis in femur, something like this. Investigation of choice for prostate cancer would be transrectal ultrasound guided prostatic needle biopsy. 12 biopsies are taken from the prostate, and we can do a Gleason grading, where the Gleason score ranges from 2 to 10. For breast cancer, we do a Bloom-Richardson grading. For staging of prostate cancer, we do MRI. For distant metastasis PET scan, where we use 18-fluorodeoxyglucose, half-life 120 minutes. And the tumor marker for prostate cancer is serum prostate-specific antigen. The treatment of prostate cancer, if the cancer is confined within the prostate, then we deal differently. If the cancer has gone beyond the prostate, say to the lumbar vertebra, then we cannot do a curative treatment, that will be palliative treatment. If the cancer is confined within the prostate, and if the age of the patient is less than 70 years, where the life expectancy is more than 10 years, then we can remove the entire prostate, either by surgery, radical prostatectomy, which can be done by robotic radical prostatectomy, or maybe open surgery, or if not surgery, then we can destroy this prostate by radiotherapy. External beam radiotherapy or even brachytherapy can be given, where we can implant the sheets of radioactive material. We use iodine-125 or palladium-103 in the treatment for these prostate cancers. However, if the cancer is confined within the prostate, but the patient is quite old, say more than 70 years of age, life expectancy less than 10 years, then it is believed that since these cancers are very slow growing, they are part of aging, so unnecessary, do not give complications to the patient which can disturb his quality of life by doing a radical prostatectomy or external beam radiotherapy. So we do active surveillance in these cases. We keep following up these patients with maybe MRI after every 6 months. These are the robotic instruments which can be used. This is the computer console and the robotic instruments. This is the robotic operation theater, where the robotic instruments are here. The computer console is here. The surgeon is not operating here. The surgeon is operating a computer. He's just trying to move the instruments through the computer. because computer gives a better surgical precision. So robotic surgeries are coming up in a much big way now. However, if the prostate cancer has gone beyond the prostate, say into the lumbar vertebra, then you will not be able to remove complete cancer from the patient's body. So you cannot offer a curative treatment. You will be doing a palliative treatment. And in this, we give therapy to destroy the androgens, so androgen ablation, which can be done by medicines or by surgery. Medical androgen ablation is better than surgical castration. In surgical castration, we remove both the testes of the patient, that is bilateral subcapsular orchidectomy in prostate cancer, and that is for removing the testicular source of androgens. When we have to give medical androgen ablation, we can use LHRH agonists like goserelin, buserelin can be used. Androgen receptor blockers like enzalutamide can be used. LHRH antagonists, degarelix can be used. Testosterone production blocker like abiraterone can be used. Penile cancers, the squamous cell carcinomas often at the glands prepuce. Most common risk factor is poor hygiene, smoking, human papillomavirus, long-standing genital warts, penile epithelial neoplasia, glands erythroplasia of Currat-Sharp-Bowen's disease. They usually present as ulcerative false vein growth on the penis, enlarging inguinal lymph nodes. The reason for lymph node enlargement 50% of the time it is because of infection and 50% because of tumor. Death in penile cancer patient is because of torrential hemorrhage due to erosion of femoral or iliac vessels by the enlarged inguinal lymph nodes. You can take a biopsy, do an MRI and PET scan to stage the penile cancer, and then treatment best would be surgical removal with a 2 cm margin. The decision whether to do a partial penectomy or total penectomy depends on how much of penile stump can be preserved. If after removing the tumor along with a 2 cm margin, the length of the penile shaft left is more than or equal to 2 centimeters, then we do a partial penectomy, otherwise total penectomy. When we are doing a total penectomy, then we are left with the perineal urethra, so we just refashion the perineal urethra in the perineum, that is perineal urethrostomy. And for lymph nodes, inguinal lymph nodes, first we give 3 weeks course of antibiotics. If the lymph nodes were enlarged because of infection, they will regress with antibiotics, but if they persist, that means they're because of tumor, so we do removal of these lymph nodes. The testicular cancer is the commonest cancer in a young male. Most common is a seminoma. The germ cell tumors, seminomatous, non-seminomatous embryonal carcinomas, yolk sac tumors, and the teratomas. Most common cause undescended testis. Most commonly present with scrotal enlargement, heaviness in the scrotum, and large preparatory lymph nodes can present with a pediatric lump. Hemoptysis in testicular cancer simply means that testicular cancer has metastasized into the lungs. Seminomas spread most commonly by lymphatics. Teratomas more commonly spread by blood. Right testicular cancer spread more commonly into the interaortocaval lymph nodes. You know the testicular artery is the branch of abdominal aorta, so lymph nodes involved in testicular cancer would be the preparatory lymph nodes. From the right side, if you see these vessels, the lymph nodes which are situated between the IVC and the aorta, they are going to get involved. While in left testicular cancer, the lymph nodes which are situated on the left of aorta, that is left paraortic, they are going to get involved. The lung metastasis, what we see in these cancers, whether it's testicular lung cancer or kidney cancer, they are called as cannonball deposits. The patient, this is an image of cannonball deposit here, radiology MCQ. You can see the nice rounded opacities. These are cannonball deposits. How to approach these patients of scrotal enlargement? Transillumination, that would be negative. Do ultrasound of the scrotum, don't do transscrotal venous biopsy. You can take the help of tumor markers like alpha-fetoprotein in yolk sac tumors, HCG in choriocarcinomas, LDH, and placental alkaline phosphatase in seminoma can be raised. Investigation of choice would be CT of the abdomen, where we can know about the preparatory lymph nodes, but whether it's a seminoma teratoma can be known only when we remove the testis. So we do a high inguinal orchidectomy, where we remove the testis along with the spermatic cord. And then the primary treatment given would be chemotherapy. In this we give VP, bleomycin, etoposide, cisplatin. Seminomas are radiosensitive, and prognosis of seminoma is better than teratoma. Thyroid cancers, most commonly they are differentiated thyroid cancers, papillary being the most common, follicular being the second most common. Sometimes there can be undifferentiated anaplastic thyroid cancer, which carries a poor prognosis. Medullary thyroid cancer arises from the parafollicular C cells, lymphomas, and metastasis to thyroid from kidney and breast cancer can come. The difference between papillary and follicular cancer: papillary is more common, usually in younger age group, less than 40 to 50, most commonly associated with radiation exposure to the neck. However, thyroid muscle cyst can also be associated with this papillary thyroid cancer. While follicular cancer most commonly is associated with long-standing anemic whititis, follicular cancers are usually encapsulated. Pathologically, papillary cancers we find orphan aniide nuclei in Samoma bodies. These are orphan aniide nuclei where you can see the empty nuclei, just like the orphan, and these are the metastatic calcification bodies, the Samoma bodies. Samoma bodies can be seen in various other tumors as well, like serous cystadenoma of ovary, papillary renal cell carcinoma, papillary thyroid cancer, salivary adenomas, pituitary adenomas, meningiomas. Pathologically, the follicular thyroid cancers, they are difficult to be distinguished from follicular adenomas because the only difference between follicular adenoma and follicular carcinoma, if there is no invasion of the capsule, like here, what you're seeing this area, this is the capsule here. The difference between follicular adenoma and carcinoma is if the capsule is invaded or maybe nerves and vessels are invaded, then it's a carcinoma. So when we are doing an ultrasound guided FNAC, we are putting a needle here, and FNAC will not be able to tell us whether the capsule or the neurovascular invasion is there or not. So FNAC cannot distinguish between follicular adenoma and follicular carcinoma. Most often, these patients present to us with a neck swelling. Papillary spread commonly by lymphatics, follicular spread commonly by blood. The tumor marker for both serum thyroglobulin and the treatment for both total thyroidectomy with removal of involved lymph nodes. Papillary, since they spread by lymphatics, have a better prognosis than follicular, who spread commonly by blood. After total thyroidectomy, we can give thyroxine suppression therapy, and we can use radioisotope iodine 131 for the thyroid assays. Medullary thyroid cancer arises from the parafollicular C cells. Medullary thyroid cancer is not dependent on PSH. Serum thyroglobulin is not the tumor marker. Pathologically, medullary thyroid cancer is characterized by amyloid stroma. This is autosomal dominant, associated with MEN2A, B, that is multiple endocrine neoplasia A and B. They also present with neck swelling and enlarged lymph nodes. 25 to 30% of patients of medullary thyroid cancer can present with diarrhea. That is again because of the substances secreted by the tumor cells in medullary thyroid cancer. The tumor marker for medullary thyroid cancer is serum calcitonin. If calcitonin is not given in the option, then go for carcinoembryonic antigen, and the treatment would be total thyroidectomy with removal of involved lymph nodes. Breast cancer, most common cancer in females. It is the invasive ductal cancer, most often it is the adenocarcinoma, most commonly involving the upper outer quadrant and least commonly the lower inner quadrant. Risk factors: familial, maternal, paternal. Genetic factors: BRCA1, BRCA2 in females, only BRCA2 in males. Hormonal factors like early menarche, late menopause, nulliparous, postmenopausal, obese female, patients taking hormone replacement therapy, patient taking high estrogen content OCPs for a long period, less phytoestrogens in diet like beans pulses. Protective factors are late menarche, early menopause, multiparity, prolonged breastfeeding, having first child at an early age, and more consumption of phytoestrogens in diet. Pathologically, breast cancer can arise either from the duct or the lobule, most often from the duct. Both can be in situ and invasive types. Most common is the invasive ductal cancer. Remember, lobular cancers are usually bilateral, multifocal, and they're associated with E-cadherin antibodies. According to the newer guidelines, the lobular carcinoma in situ is now not considered as cancer. It is actually a benign story with malignant potential. Pathologically, we can do a Bloom-Richardson grading, which is based on PMT, pleomorphism, mitoticate, and tubule formation. Based on this, we can classify whether the cancer is well differentiated, moderately differentiated, or poorly differentiated. Well differentiated means where the cellular architecture is preserved, so they'll be less aggressive, and poorly differentiated means there will be huge amount of mitosis and pleomorphism, so the prognosis of poorly differentiated cancers will be poor. Ductal breast cancers, most commonly they are not otherwise specified NOS. However, colloid, papillary, and tubular type of ductal cancers have got a better prognosis. Medullary type can also be there, and inflammatory type of ductal breast cancer has the worst prognosis. How these patients present most commonly as a lump in the upper outer quadrant, which is cancer lump is usually hard, irregular, may or may not be fixed to the underlying overlying structures, may or may not be associated with involvement of lymph nodes or the nerves. Dimple or indrawing of the skin does not mean that cancer has gone into the skin. This dimple in the skin can be just because the cancer has involved the suspensory ligaments. So if the ligament is involved by the cancer, this ligament is trying to pull the skin inside, and that will cause indrawing or dimpling in the skin. There can be circumferential retraction of the nipple and blood discharge from the nipple. If the cancer cells go into the subdermal lymphatics, that is the superficial lymphatics, then the patient can present with PUD orange type of appearance, or you can say something like this. Most commonly, they are not otherwise specified NOS. However, colloid, papillary, and tubular type of ductal cancers have got a better prognosis. Medullary type can also be there, and inflammatory type of ductal breast cancer has the worst prognosis. How these patients present most commonly as a lump in the upper outer quadrant, which is cancer lump is usually hard, irregular, may or may not be fixed to the underlying overlying structures, may or may not be associated with involvement of lymph nodes or the nerves. Dimple or indrawing of the skin does not mean that cancer has gone into the skin. This dimple in the skin can be just because the cancer has involved the suspensory ligaments. So if the ligament is involved by the cancer, this ligament is trying to pull the skin inside, and that will cause indrawing or dimpling in the skin. There can be circumferential retraction of the nipple and blood discharge from the nipple. If the cancer cells go into the subdermal lymphatics, that is the superficial lymphatics, then the patient can present with PUD orange type of appearance, or you can say something like this. This is due to the blockade of subdermal lymphatics by the cancer cells. That means the cancer has gone into the skin. If the surface area involved is less than 1/3 or 1/3, then it is T4B. But if the surface area involved is more than 1/3 of the breast surface, then it becomes T4D. There can be satellite nodules, skin ulceration. They also suggest skin involvement. Lymphedema of the arm, this is due to blockade of the axillary lymphatics by the tumor cells. Pagets disease, this is basically the erosion of the nipple. Eventually the nipple can disappear. This is due to intraductal spread of breast cancer. This is not eczema or a skin lesion. Now, breast cancer can spread locally. If it goes anteriorly, it can go into the skin. Posteriorly, it can go into the pectoralis fascia, pectoralis major, minor, ribs and the intercostal muscles. Involvement of ribs and intercostal muscles is involvement of chest wall. Involvement of pectoralis muscles is not considered as involvement of chest wall. Why we are focusing here? Because in staging of breast cancer, if chest wall is involved, then it is T4A. If pectoralis muscle is involved, that is not T4A. Right. Through lymphatics, the breast cancer most often spread to the axillary lymph nodes. Also, if the cancer is in the posterior or medial part of the breast, it can involve the internal mammary lymph nodes. Through blood, most commonly the cancer goes into the bones, most commonly in the lumbar vertebra, through the brachial vertebral plexus of veins. It can even go into the liver, lungs, and brain. How to approach the breast lumps? Triple assessment, CRP, clinical, radiological, and pathological. Clinical, detailed history and examination, radiological, ultrasound for less than 40 years, mammography more than 40 years, and the best would be pathological. Biopsy, needle biopsy would be the best investigation of choice. We can even do FNACs. When we are doing the mammography, we know that young females have got more dense and glandular breast. So less than 40 years, because of the high density of breast, we might miss a lesion on mammography. Old females, the density of breast decreases. So if there is any lesion inside, we can identify these lesions better. So after 40 years, mammography is good. Ultrasound guided needle biopsies can be done. Like this black area, what you're seeing, this is the hypoechoic area, probably this is the cancer. And this white linear shadow, what you're seeing, this is the needle which we are putting into the tumor. And we take a biopsy from here, and that is how we make the diagnosis. When we're doing mammography in breast cancer, we can find irregular speckled microcalcifications suggestive of cancer. For staging of breast cancer, we do MRI. Like if we are doing a contrast MRI here, after washing out the contrast, we can find the contrast inside this irregular area. So this is how we come to know whether the cancer is confined within the breast or it is going into the pectoralis muscles as well. And for metastasis, we do a PET scan using 18-fluorodeoxyglucose, which has got a half-life of 120 minutes. Once we have done all the staging, all the investigations, then the staging is the TNM staging. T1 less than 2, T2 2 to 5, T3 more than 5, T4 any size, T4A chest wall, T4B skin, T4C both, T4D inflammatory. T1 can further be subcategorized. T1 micro when it is up to 1 mm, T1A more than 1 mm up to 5 mm, T1B more than 5 mm up to 10 mm, and T1C more than 10 mm or 1 cm up to 2 cm. T2 will be more than 2 cm to 5 cm, T3 will be more than 5 cm, and T4A chest wall, T4B skin, T4C both, T4D inflammatory. Remember, if PUD orange or redness of the skin involves more than 1/3 surface of the breast, then it will be inflammatory or T4D. In the axillary lymph nodes, we know there are 3 levels. Level 1 is lateral to pectoralis minor, level 2 antipectoralis minor, and level 3 medial to the pectoralis minor. Infraclavicular apical lymph nodes are level 3 lymph nodes. Generally, we talk about level 1 and level 2 lymph nodes in breast cancer. So lymph node staging is done only for the ipsilateral lymph nodes. If a contralateral lymph node is involved, then the cancer has not gone via lymphatics, but it has gone through blood, so it is a metastasis. So in lymph node staging, we talk only about the same side lymph nodes or ipsilateral lymph nodes. And one is mobile axillary, N2A is fixed axillary, N2B is internal memory, N3A is axillary and apical, N3B is axillary and internal memory, and N3C is supraclavicular. So you can say that N3A is actually the infraclavicular or the apical basically. Distant metastasis would be M1. In the treatment for breast cancer, we have got those 5 options: surgery, chemo, radio, hormonal, and targeted therapy. In surgery, what we are doing nowadays, most commonly it is the modified radical mastectomy done for breast cancer. But if you look at the history of surgery for breast cancer, originally Halsted mastectomy or radical mastectomy, where the Halsted removed the entire breast, the pectoralis major, pectoralis minor, along with the lymph nodes in the axilla. This was radical. But then it was modified to modified radical, where there is no need to remove the pectoralis major and minor. We just remove the breast and the lymph nodes. That is modified radical mastectomy. If lymph nodes are not involved, we can do a simple mastectomy, that is just remove the breast, not the lymph nodes. Nowadays, as the awareness of breast cancer is increasing, patients are coming to us even at very early stage of breast cancer. So we may not remove the entire breast, because many times when we are doing a mastectomy, maybe a simple or modified radical, when we are removing the entire breast, a lot of patients want breast to be reconstructed. So if we have to do those breast reconstructions either by silicone gel or some other methods, then if the patient comes to us at a very early stage in breast cancer, then we don't remove the entire breast, we just remove that lump along with a 1 cm margin, which is called as lumpectomy here in breast cancer, or maybe breast conservative surgery, or maybe wide local excision. right? But whenever we are doing a breast conservative surgery, we have the apprehension that we might have left some tumor cells behind. So adjuvant radiotherapy is mandatory whenever we are doing a wide local excision or breast conservative surgery. If because of any reason radiation cannot be given, then wide local excision or breast conservative surgery cannot be done. Once again, the emphasis, if we use the prefix C, that means it's a clinical stage. If we use the prefix P, this is the pathological stage. If we use the letter Y, then it is status after neoadjuvant therapy. M is used for multiple synchronous tumors. PCR is pathological complete response. That means whatever therapy we have given. Now, after that, if suppose we have done the surgery and given the specimen to the pathologist, if there is absence of tumor cells in the resected breast axilla on pathological examination, we say it is PCR, pathological complete response. Lobular carcinoma in situ is just a high-risk benign lesion and not a cancer. NAST is the term which we are using for neoadjuvant systemic therapy, which can be anything chemoradiofhormonal targeted, and NACT, NSCT is neoadjuvant chemotherapy. As we know that in breast conservative surgery, we are doing a wide local excision, removal of a tumor with 1 centimeter margin, but adjuvant radiotherapy will be must. We can also do oncoplasty. Now, oncoplasty means we are just trying to reconstruct that area from where the tumor has been removed. So suppose you have done a wide local excision or maybe breast conservative surgery, there might be some defect left inside. If we want to restore that architecture of the breast, we can do some volume adjustment, which we say volume displacement, or sometimes we have to put some volume there, that is the volume replacement. So that is oncoplasty. Many times, if suppose before the operation, we feel that lymph nodes are not involved in cancer, if we have to find out whether the lymph nodes are involved in cancer or not at the time of operation, then before the operation, we can inject a dye either around the tumor, that is in the peritumoral area, or we can inject the dye around the areola, that is in the periareolar region, or this can also be called a subareolar region. The brown color, what you're seeing, this is the areola. The black thing is the nipple. So we either inject the dye around the tumor, that is peritumoral. If this is not in the option, then periareolar, that is around the areola. The dye can be a methylene blue along with a radio-labeled sulfur colloid, or maybe the radio-labeled albumin. The technetium 99 is the isotope which we can use, so we can inject either this, or we can even use a fluorescein or indocyanine green dye, which is non-radio isotope dye. Once you inject this dye will be taken up by the lymphatics and will go into the lymph nodes, and the lymph nodes will get colored. Now, when you're taking this patient for surgery, you have injected this dye maybe 1 hour before surgery. When you are doing the surgery, you will be seeing the tumor, you will be seeing the lymph nodes as well, the colored lymph nodes. You take few lymph nodes, maybe 5, 6, 7 lymph nodes, give it to the pathologist at that point of time, wait for what the pathologist says. Within 30 to 45 minutes, the pathologist is able to tell us whether cancer cells are present in these lymph nodes or not. Before the operation, the lymph nodes were not involved as per the investigations. So your plan in surgery is not to remove the lymph nodes, but still you want to be absolutely sure. That is why you are doing the sentinel lymph node biopsy. If the pathologist tells you that lymph nodes are not having cancer, that means the original plan was good. No need to remove the lymph nodes. Go ahead. But if the pathologist says that there is cancer in these lymph nodes, then you have to abandon the original plan. You have to do the primary surgery, whatever you are planning, whether it was a breast conservative surgery or wide local excision or maybe simple mastectomy. But since now the lymph nodes are involved, you will have to make a separate incision in the axilla and remove those axillary lymph nodes also. So that is the use of sentinel lymph node biopsy. Once we are doing a mastectomy, then we can do the breast reconstruction, most commonly by a silicone gel. We can use various muscle flaps as well, like a transverse rectus abdominis muscle flap, latissimus dorsi muscle, deep inferior epigastric perforator. These can be used. Apart from the surgery story, we can give chemotherapy with adriamycin, cyclophosphamide, and taxanes. Radiotherapy, if hormone receptors are positive like ERPR are positive, then we give anti-estrogens. In premenopausal females, because the estrogen load is high, we give selective estrogen receptor modulator tamoxifen, 20 mg once a day for 5 to 10 years. However, in postmenopausal females, where the estrogen production is because there is more conversion of steroids in the body fat into the estrogen by aromatization, so we give aromatase inhibitors. In targeted therapy, if HER2 gene is positive, we give trastuzumab or pertuzumab. We can classify these breast cancers into early, locally advanced, and metastatic. For early breast cancer like T1, T2, N0, N1, M0, we can do a breast conservative surgery or modified radical mastectomy with or without radiotherapy, hormonal therapy, targeted or chemotherapy. For locally advanced breast cancer, that is T3, T4, N2, N3, M0, we can do neoadjuvant therapy, then modified radical mastectomy, and then completion therapy with maybe chemo, or if required, we can give radiotherapy, hormonal therapy, or targeted therapy. In metastatic breast cancers, that means any T, any N, but M1, curative surgery is not possible, or curative treatment is not possible, only palliation is possible, like you can do a simple mastectomy. For prognosis, we can calculate a Nottingham prognostic index, and this depends on the stage of the tumor, that is TNM, where lymph node status is the most important. In the molecular classification for these breast cancers, we can classify them into luminal A, luminal B, HER2 neu enriched, basal or triple negative, and claudin low, according to the latest guidelines now, which have been published in the recent edition of Bailey and Love, which has come late in the year 2022. According to that, luminal A has got the best prognosis, where estrogen progesterone receptors are positive, HER2 neu is negative with a low Ki67, Ki67 value. Luminal B is where estrogen progesterone receptor is positive, HER2 neu is negative, but the Ki67 is high. HER2 neu enriched, where estrogen progesterone receptors are negative, only HER2 neu is positive with a high Ki67. So this will be having a poor prognosis. A basal or triple negative, where ERPR, HER2 neu, all three are negative with a high Ki67. Claudin low is where everything is negative, the claudin levels are low. Right. So luminal A has got the best prognosis. Thank you very much for your patience. Thank you for your patient listening. Hope this revision of oncosurgery helps. May God bless you all. Wish you all the best.